Good afternoon, everybody, and welcome to the STEMI Council CSI National Conference. And before we begin the conference, I would request our organizing chairman and president of the CSI Delhi branch, Dr. Suman Bhandari, to give the inaugural letter.
Thank you, Dr. Naik. Good afternoon. On behalf of the Delhi CSI, I would like to welcome the Honorable President CSI India, Dr. P.P. Mohanan, the past President, Dr. M.K. Das, the President-elect, Dr. P.S. Banerjee, the Honorary Secretary Debrata Roy, the respected Executive Committee members of the CSI India, and the speakers and delegates of this very august STEMI Council CSI. It is indeed a pleasure and privilege to welcome you all to the National Conference of the STEMI Council CSI. We all know STEMI is an integral part of the NIC database, usually representing 15-20% of total PCIs in India. Some tertiary care centers do most of the work as STEMI, thus saving a number of lives from major heart attacks. These 2 days, we will focus on current aspects of management of STEMI, including talks and learning from key opinion leaders, including numerous foreign and national faculty, and also case-based learning and complications to keep us on guard. I would like to thank the Executive Committee of Delhi CSI for giving their valuable input during the brainstorming session we had prior to hosting this important council meet, and of course the outstanding work of Dr. Nitish Naik, the convener of this meet, and who is ably guided by our treasurer, Dr. Rakesh Yadav, and who is also the editor of the prestigious Indian Heart Journal. With these words, I would again like to welcome you all to these exciting 2 days of deliberation on STEMI, and hope we all have a great learning experience. And I would thus like to welcome you again and hand over the proceedings to Dr. Naik. Thank you very much. Thank you.
Thank you, sir. Thank you for your encouraging words. And once again, as convener, past President Dr. M.K. Das, our President-elect Dr. P.S. Banerjee, our Honorable Secretary Dr. Debrata Roy, and obviously the Organizing Chairman and the President of CSI Delhi branch, Dr. Suman Bhandari, and all our EC members and our honorable speakers, both national and international, without whose support, this conference would not really have been possible. And it's always, and I was very privileged to be nominated for this position by the National CSI. And this STEMI Council of CSI was established as a sub-council of CSI because, of the very nature of the illness that we are going to be talking about, STEMI. With ST elevation MI is, something that has affected the nook and corner of this country without exception, both in rural and urban areas. And in fact, as per recent data, I've been told that nearly 500,000 cases of ST elevation MI are diagnosed every year in this country. And I'm sure there'll be many more, if not an equivalent number or even double that number, who would remain undiagnosed throughout this and, are unable to seek medical contact. And patients. And which is why I think so CSI formed this STEMI sub-council, because we have to have established some sort of a national guideline and perspective on how we should be treating these patients in India. And the CSI under the STEMI Council under the supervision of CSI had recently, in fact, come up with a document to how to treat ST elevation MI during the COVID era. And I think so that had inputs from all across the country, and we're very grateful for CSI for organizing that paper. In this meeting, we have tried to cover topics that cover from the very basic needs in primary care to the most advanced therapies that should be available in the highest levels of highest tertiary care centers in this country. And to go through these sessions, we have a galaxy of leaders, stalwarts from across the country, as well as from across the 7 continents, to help us, understand what is the latest that is happening in STEMI care. And I hope this conference is helpful for both our learned cardiologists colleagues as well as many physicians who are also tuning into this program. So with these few words, I would now like to request our Honorary Secretary, Dr. Debrata Roy, to give his comments for this conference. Dr. Debrata Roy, please.
Thank you, Dr. Naik. I wish a very good afternoon to all the dignitaries on screen and off screen, and to all the delegates who have assembled together for this great conference. I think Dr. Naik has fulfilled a so long unmet need on behalf of the CSI by organizing this conference. And I believe after the conference, there will be emergence of certain directions along which the CSI should move to bring about a meaningful change in STEMI management in India. Dr. Naik, with Dr. Suman Bhandari as the organizing chairman and Dr. Rakesh Yadav as the treasurer, has formulated a wonderful program and has assembled a galaxy of faculties. And I believe all the participants will enjoy the proceedings. I wish this conference a huge success. Thank you. Over to you, Dr. Naik.
Dr. Debrat, for your encouraging words. And now I would like to request Dr. M.K. Das, our immediate past president of CSI.
Thank you, Dr. Naik. Good afternoon, everyone, colleagues and friends, faculty and delegates, and also the dignitaries who are on the screen and off the screen. It is quite heartening that STEMI Council of CSI is organizing this annual conference virtually in this challenging time. As you know, that STEMI is a burning problem, not only in our country or in our subcontinent, but also globally. And most important factor that actually, inhibits the process of the accurate management or appropriate management is the logistics. But with those logistics, we'll have to carry on with our activities, manage the patients of STEMI in an appropriate manner, and we should attempt to prevent the STEMI rather than it should be controlled, and it should be managed with the complications when they are presenting in the emergency situation. With these few words, I thank and also congratulate the organizers, especially Dr. Nitish, Dr. Rakesh, and Dr. Bhandari for their endeavor to arrange an updation and educative process in the form of conference, so that all the physicians and cardiologists are benefited. Thank you very much. Good day, and long live CSI.
Thank you, Dr. Das. Thank you for your support for the conference, and we are ever so grateful to you. And now I would like to request our President-elect, Dr. P.S. Banerjee, to say a few words. Dr. P.S. Banerjee, sir, please.
Good afternoon, Dr. Naik. and all the dignitaries who are present in this meeting. It is a wonderful job you have done to present such an international standard of meeting on STEMI. And I hope that all our members across the country and the postgraduates will enjoy this meeting because of the galaxy of the panel of faculties that we have seen. And I know that the science is ever growing, so also the cardiology. So whatever the new information we will get from this meeting will be actually delivered into the clinical practice, and that will help to increase our knowledge in the future to come and benefit the patients. And I know that this is a real tough time, as Dr. Das has said, because of this COVID pandemic to manage and organize such a big meeting. So all the credit goes to Dr. Naik, Dr. Rakesh Verma, and Dr. Rakesh Yadav and Dr. Suman Bhandari. So I wish this meeting a grand success and hope that years to come, we will find increased number of such meetings to increase our knowledge in the practice of cardiology. Thank you very much. Long live CSI.
Thank you, Dr. Banerjee. And now I'll request our president, Dr. P.P. Mohanan, to formally inaugurate the conference. Sir, I would like to request you to press the space bar button on your computer to light the lamp. This is a virtual conference and we can't have you on the dais. So,
is it the one that I'm doing?
Yes, sir, you just press your space bar button, sir.
Okay. Dr. Das and Dr. Banerjee and my other distinguished friends. It gives me immense pleasure to welcome you all for this two-day virtual bonanza in this very challenging time. Dr. Nitish and his team is going to give us an excellent scientific deliberatory program, and I'm sure all of us are going to learn, and every one of us, you are going to take home some excellent learning point. As it was mentioned, globally, I think about 7 million STEMI happens yearly, and unfortunately, 2.5 of them happens in our country. Our NIC data shows we do about 100,000 primary PCI, and another 400,000 patients with STEMI undergo lysis. But what happens to the rest of the 2 million people? Possibly they are left unreperfused. I mean, but then despite all these grim statistics, I can still say that we are on the right track, because if you look at the STEMI in hospital mortality, And about 12 years ago, if you look at the statistics from CREATE registry or the Kerala registry, you could see that the STEMI in hospital mortality was 8.9%. Over the years, our own data, the ACS CUB data, the largest randomized control data showed it has come down to 3.6%. So I am sure all over the country, the STEMI in hospital mortality is coming down. You look at even the COVID times, where we did the COVID AMI study of more than 47,000 patients. Here again, the mortality is 6%, even during these difficult times. So I think our STEMI care, whatever it is available for all of us, are improving over the time. But as discussed by my colleagues, a systems of a proper strategic STEMI care is the need of the hour. And either with the heart attack apps or so now we had in a smaller way found out that a GIS based mapping of very many hospitals, which can be done. We have done it in Kerala. It can be repeated all over the India. And that can tell the patient which are the nearby hospital which will give you a catheter-based reperfusion or a lytic-based reperfusion. That can be, that should be one of our models, apart from whatever the STEMI model that we have. Now, each state may require different model. One of the things which worries me and worries every one of us is the increasing prevalence of young MI happening. All of us learn from literature that's only 5% or 7%. The Bangalore data, which was published recently, just is mind-boggling, saying that less than 45 years, you have about 25% of STEMI is happening. Now, that is something which we have to do, consider very seriously how to prevent that. The secondary prevention is another area where the CSI can definitely improve upon, conveys the message now that we have the Lancet article saying the importance of 50% reduction of maize rate with the poly pill is something which possibly the CSI should propagate that message. So with all your permission, I have great pleasure in inaugurating this great meeting. Satyameva Jayate. Thank you.
Thank you, sir. Thank you. Thank you for your kind words. And it's my proud privilege to propose the vote of thanks for this meeting. And at the outset, I would like to thank our President, Dr. P.B. Monan, who's under exemplary leadership. CSI is attaining new heights. In fact, it really happened, and I'm really thankful to you, sir, for pushing us to get this meeting to reach the stage where it is today. To Dr. M.K. Das, I'm especially grateful, and I feel very privileged that I was able to work under his stewardship in CSI, and I'm very grateful for his support throughout this meeting. He has been very kind and very supportive for this meeting, and thank you, sir, for your support. To Dr. P.S. Banerjee, sir, we look forward to your, as the change of guard happens, and we are gratefully looking forward to this new era that gets unleashed, and we look forward to your national meeting and your perspective as you take over the national CSI. Thank you, sir, for your constant support, and I'm very grateful to you. Dr. Suman Bhandari has been a pillar of strength. He has been extremely supportive of all the steps that we have taken. He has organized special sessions to make sure that this meeting happens. And I must say that we were very fortunate to have Dr. Suman Bhandari at the helm of affairs. And thank you, sir, to all the EC members from CSI Delhi branch who have been helping me through this. Dr. Debrata Roy has been, again, a source of constant support. He has helped guide this meeting, and I'm very thankful to him for helping me organize this meeting. And to all the chairpersons, speakers, faculty who are taking part of this meeting, I'm very grateful. I'm sorry we might have pestered you on and off to seek your permission and to seek your time so that you may contribute to this conference. But once again, thank you so much for making this event a success. And I hope that we enjoy the deliberations throughout the day. To my friends, especially Rakesh, I cannot thank him enough because he is the backbone of this meeting. And in fact, if it was not for this support, this meeting would never have ever have happened. So thank you, Rakesh, from the core of my heart. This very special thanks to you. And I would also like to thank all the people who have been behind us, helping us, from the audiovisual to our event management team and to all other friends and colleagues who have helped me organize this meeting. And lastly, I would like to thank, but not the least, to thank our industry partners, without which whom this event would not have happened. And we have had very extensive help from them, and without whose help, this scientific meeting would not have happened. I would like to especially thank Abbott, Medtronic, Boston Scientific, Translumina, Intas Pharmaceuticals, Torrent, Sun, MQ, Novartis, Lupin, who have all helped us in organizing this meeting. So I think so. With these words, I would like to draw this inauguration ceremony to a close and look forward to having you at the meeting. The meeting is organized in two halls, in the BC Roy Hall and the Andreas Grunzig Hall. And select the hall to join in, and this link will be valid.
Thank you. Thank you very much.
Thank you, sir. So we can now log into our respective halls, and we will start the meeting sharp at 1 o'clock.
Okay.
Thank you.
And
Thank you.
Thank you.
Dr. H.K. Chopra, Dr. Kajal Ganguly, Dr. Naveen Jamwal, Dr. Rakesh Yadav, Dr. S.S. Iyengar, Dr. Thomas Alexander, and Dr. Vitul Gupta. I'd like to request Dr. H.K. Chopra and Dr. S.S. Iyengar to kindly begin this session.
Thank you very much. Thank you very much, dear friends, ladies and gentlemen. At the outset, I express my gratitude and thanks to Dr. Nishit for inviting us. Also express my gratitude to the President of CSI, Dr. Mohanan, all my colleagues on the dais and off the dais on the occasion of a very, very important opening session of STEMI Council of CSI National Conference 2021. We all just heard from Dr. Mohanan that the STEMI is happening more in the younger population now. He just spoke about the data from Bangalore. And we know that 3 million people fall victim every year to STEMI in our country. And if we see our data from Delhi, 100 individuals per day in Delhi and 1 in every 15 seconds is a victim of STEMI. It's a matter of great concern. And we also know that primary PCI is the gold standard, no doubt about it. But is that the solution? The solution is pharmacoinvasive approach, especially in the COVID era. We have many people here who are part and parcel of the registry, like we have Dr. Thomas Alexander, Dr. Iyengar, in the Indian registry data in 2014 and 13, which they published is huge data. And we have the registry data coming up very soon from Mission Delhi, Dr. Naik, Dr. Rakesh Yadav, and many other people, faculty members from All India Institute, Mission Delhi. I'm sure we will have some data. And we already have one presenter from Shimla, Dr. Negi, who will be giving us his data also. So before wasting any time, I'll invite this first speaker, Dr. Arun Chopra, to have his presentation on definition of MI and its relevance in today's status. Dr. Arun Chopra, please. Dr. Iyengar, you want to give any comment? Dr. Iyengar.
Good morning, ladies and gentlemen. I think we'll straight away start with Dr. Arun Chopra's presentation.
Good afternoon. Can you see my slides, please?
Yeah, we can see it. Please go ahead.
Okay. All right. Good afternoon. So we know that we are talking about myocardial infarction in general and STEMI in particular. While definition seems too much of something which is well known, I feel there is a lot of interest in how the present generation definition of myocardial infarction has evolved and what is its relevance to our day-to-day practice. So as you can see from the 1950s, the definition of acute MI started evolving. We had several iterations, and this universal definition of MI came up about 2 decades back. And in the last approximately 2 decades, we've had this 4th iteration of the universal definition, which came up in 2018. And this is what we are following at the moment. The benefit is that it helps everybody reach a common definition, an accepted definition of myocardial infarction. And this is endorsed by ESC, ACC, World Heart Federation. And therefore, this gives us a uniform definition for defining MI in studies. Anyways, so the basic definition, the crux is this. Myocardial infarction is signified by the presence of acute myocardial injury detected by abnormal cardiac biomarkers in the setting of evidence of acute myocardial ischemia. So whereas this does appear to be very simple, there are certain complications with this, which I will try and clarify in the next 10 minutes or so. So basically the criterion for myocardial injury is detection of an elevated level of cardiac troponin above the 99th percentile of upper reference limit. But we must understand that in this larger amber circle of increased troponin, there is a smaller circle, which is the circle of acute myocardial infarction. So these are individuals who have both myocardial injury and evidence of clinical myocardial ischemia which has led to myocardial infarction. And there are various other conditions like anemia, tachyarrhythmias, heart failure, CKD, hypotension, hypoxemia, which overlap with these two conditions. And there may also be situations in these conditions when enzymes are not elevated. So these three conditions sort of overlap, and I shall now try to help you in understanding what the present definition is. So the present definition means myocardial injury as defined by rise in cardiac troponin above the 99th percentile with at least one of the following three symptoms typical of acute myocardial ischemia, ECG changes suggestive of acute MI, or imaging evidence of acute MI in the form of echo, CT, MRI, etc. ECG criteria are of course well known, and there is another session for this. I won't go into details of this, but on the basis of this definition, MI is classified these days into 5 categories. So type 1 is the classic MI which we see, acute atherothrombotic plaque rupture. Type 2 is another common variety of MI in our patients, supply-demand mismatch, and I'll be defining these subsequently. Type 3 is MI which presents with sudden death, where the time has not been available to check biomarkers. Type 4 and 5 are procedure related, and I shall discuss these subsequently. So type 1 is the classical myocardial infarction, which occurs due to plaque rupture or plaque erosion with an occlusive thrombus, sometimes with a non-occlusive thrombus. But it is important to integrate these ECG findings with the aim of classifying type 1 MI into either STEMI or non-STEMI in order that we may treat these patients appropriately according to their clinical status and according to the current guidelines. So this is what we define type 1 MI as: elevated troponin above the 99th percentile with symptoms of acute myocardial ischemia, ECG changes or pathological Q waves, imaging evidence of infarction, and identification of coronary thrombus upon angiography or on autopsy. So any one of these 5 issues, along with evidence of myocardial injury in the right clinical setting, myocardial infarction. Coming next to type 2 MI, which is now increasingly seen in our multi-specialty hospitals and ICUs, is this MI which is caused by some amount of atherosclerosis usually, but not always, along with a condition of oxygen supply demand imbalance. So the precipitating event may be vasospasm, coronary microvascular dysfunction, spontaneous coronary artery dissection, which is not related to atherosclerosis, but basically there is a increased requirement or increased demand along with a reduced supply, one or both, which leads to all the issues which we saw in type 1 MI, with the exception that here we don't need angiographic or imaging documentation of thrombus because there is no evidence of plaque rupture in this situation. Here, the main causative issue is supply-demand mismatch. Therefore, we have to understand the framework in which type 2 MI is diagnosed. So the important issue is the context. So the patient may present with chest pain, but may develop chest pain when he or she is admitted secondary to another illness or process. And these may be the issues involved. There may be fixed coronary atherosclerosis with superadded spasm, embolism, dissection, other cardiac events like tachyarrhythmia, severe bradyarrhythmia, or non-cardiac events like respiratory failure, anemia, hypotension, or shock, all of which create a situation of demand and supply mismatch. Type 3 MI, as I mentioned earlier, is individuals who have cardiac death with symptoms of myocardial ischemia along with ECG changes, but in whom biomarkers have not been tested, and this may or may not be proved upon autopsy. Type 4 is PCI related MI, where the cutoff is elevation of cardiac troponin levels more than 5 times the 99th percentile, and along with all the other findings which are classical of a PCI related periprocedural MI, This particular MI, which is occurring within 48 hours of the procedure, is called type 4A. 4B is MI related to stent thrombosis, which may occur later. And type 4C is MI related to stent restenosis. So 4A, B, and C are all related to PCI. Type 5 is CAPG related within 48 hours of the index procedure. If there is an elevation of cardiac troponin levels more than 10 times the 99th percentile, and it's important that even if this troponin level cutoff is not met, the development of new Q waves on an ECG confirms the presence of a periprocedural MI. So these are the types of MI as defined presently by the 4th universal definition. Furthermore, reinfarction is within 28 days of incident MI, fresh ST elevation with chest pain and a re-elevation of biomarkers. Recurrent MI is acute MI occurring after 28 days of incident MI. So after having defined what acute MI is as per the current definition, I'll be touching certain specific issues which are contentious. And the most important issue is the troponin issue. This is a problem with the current MI criteria because the central focus is now upon troponins. So clinicians often encounter elevated troponins in other clinical scenarios also. So ESC, ACC, etc. have now given very concrete guidelines in this regard. Here we find that the point of care testing is now being given up in favor of the high sensitivity troponin because this is more sensitive. It brings about a 20% relative increase in the diagnosis of type 1 and a doubling in the increase in the diagnosis of type 2 MI. Furthermore, we need to remember that it's only elevations above 5-fold the upper reference limit, which are 90% predictive of type 1 MI. Initially, when these guidelines came out in 2018, the recommendation was to test troponin once at admission in the ER and once again 3 hours later, especially for non-STEMI. In STEMI, which was classical, we did not wait for the results of biomarkers to take those patients up for primary PCI. So this was more important for non-STEMI. And to account for ability in values, certain cutoffs were suggested. If the first value of troponin is normal, the second value had to be elevated more than 50 to 60% above the first. And if the first value was elevated above the 99th percentile, then the second value needed to be elevated only another 20%. However, this has now been changed to more stringent cutoffs, 0R 1R and 0R 2R in the last year's ESC guidelines for non-STEMI, because now we have more solid data for the behavior of troponins in the setting of acute MI. As you can see in the commonly used Roche assay of troponin T, high is considered to be more than 52, and a 10% elevation in 1 hour or a 20% elevation in 2 hours is considered to be diagnostic of myocardial infarction or rather myocardial injury and suggestive of myocardial infarction in the proper clinical setting. In CKD, they have tried to test different levels. They could not reach because the data was very variable. So they have advised that we stay with the same cutoff levels in CKD as in regular patients with acute MI, while considering that there may be several patients who have relatively stable elevated levels in CKD, which may be due to some amount of chronic myocardial injury related either to the elevated blood pressures, related to small vessel ischemia, or related to the uremic toxic effect, which could all have an adverse impact on myocardial function. However, the correlation in elevated troponins and long-term survival is excellent, and therefore if troponin is high in such patients, it should not be ignored and must be treated with respect. This is a graph which shows the kinetics of troponin. So we have trouble in our diagnosis here if we test too early, because it takes about 2 hours for troponins to become detectable in significant amounts. And there is some trouble if the testing is done too late or when the levels are going down, because their repeat testing at 1 to 2 hours may not really reveal a significant rise or fall in troponin levels. So in this setting, in the first 24 hours or so, troponins are excellent after the first 2 hours of onset of chest pain. But apart from that, we have to know that if we are later in the course of the infarction, testing should not be very soon, and it may be 3 to 6 hours before we test. Finally, how to correlate everything? We look for troponin rise and fall. If troponin rise and fall is clear with acute myocardial ischemia, it's either type 1 or type 2 MI, depending upon the mechanism. If there is no evidence of active ischemia, this is myocardial injury, which may be related to acute heart failure or myocarditis. And if a troponin level is elevated but stable, this is chronic myocardial injury, as occurs in CKD or structural heart disease. This has a worse prognosis but is not treated like MI. So the diagnosis of MI using the criteria here requires an integration of clinical findings, ECG, biomarkers, imaging, all viewed in the context of the time horizon over which this event unfolds. Some new entities have been mentioned in this guideline. I'll not be going into details of this, but these are Minoka, SCAD, and Sakatsubo syndrome. Minoka is basically all the diagnosis of acute MI, but on angio, there are non-obstructive coronary arteries with no coronary artery stenosis more than 50% in the infarct-related artery. We can look at Minoka as a working diagnosis, just as we approach heart failure. So it's a working diagnosis, and then we need to work up these patients by imaging techniques and look for alternative diagnosis. We don't have time to discuss more, but just keep in mind that 6 to 8% of acute MIs are associated with non-obstructive coronary arteries. This is more common in women and young patients, and the prognosis is not excellent. It's equivalent to 1 to 2 vessel disease. The 1-year mortality is about 3.5%. Hence, this needs to be diagnosed and treated carefully. Takotsubo syndrome or cardiomyopathy is the so-called broken heart syndrome, in which we have transient LV dysfunction, which typically improves with time, often associated with emotional stress. And I won't have the time to go into details of this. So I'll end by concluding that definitions for acute MI have seen several iterations in the last 2 decades. The focus of diagnosis has shifted from predominantly an ECG-based diagnosis to predominantly biomarker-based diagnosis. High sensitivity cardiac troponins are now the investigation of choice, with troponin I being more specific and troponin T being more sensitive. We also have more clear troponin cutoffs now in the recent past, and we have clear 0.1 and 0.2 R values to help us in diagnosing MI. The causes of elevated troponins other than infarction are also now quite clarified, and we need to keep these in mind and know what to treat as MI, what not to treat as MI, but respect them because of the worse prognosis that occurs in them due to elevated troponins. And finally, 3 new syndromes which have been added to incorporate entities which were not specifically covered by the earlier definitions: MI with non-obstructive coronary arteries, spontaneous coronary artery dissection, and Takotsubo syndrome or cardiomyopathy. These are not uncommon. They occur in about 10% of the patients with MI, and we need to diagnose them and treat them appropriately. Thank you.
Thank you very much, Dr. Arun Chopra, for a most brilliant and lucid presentation. With this, I request Dr. Kajal Ganguly to introduce the next speaker in the topic. Dr. Kajal Ganguly.
Hello, can you hear?
Yeah, we can hear.
Okay. Next speaker is Dr. Rajiv Gupta. Yes. Dr. Gupta, please.
Yes, good afternoon, everyone.
Hello.
Yeah.
Yes.
Good afternoon.
Good afternoon.
Good afternoon.
Right. Do I share my slides? Good afternoon, everyone. Thanks, Nitish, the chairpersons, and my teacher who is following and critically monitoring my talk, Dr. Prabhakar, and my friend Dr. Arun for a lucid presentation. We move ahead to epidemiology of STEMI in Indians. And let us talk about how different it is from the other population. You would appreciate that the STEMI is a contributor for hospitalization for acute coronary syndrome in Indian population is quite high. In the CREATE registry, almost 60% of the patients presented as STEMI. And moving ahead to the Kottayam, Kerala and TRACE registry, all of them had a higher percentage of patients presenting as STEMI as compared to European population. This higher presentation of STEMI is more because in the European countries, it is only 1/3 of the patients presenting. Unfortunately, these patients occur at a younger age in Indians. And if we see the percentage of less than 40 years patients, it is to the tune of 25%. This is reduplicated in the CREATE data where patients of less than 50 years of age were to the tune of 30%, and in the Kerala registry data again to the extent of 22.4%. It's not only these younger patients, higher contribution for STEMI, but what is surprisingly happening is that the onset of symptoms to the hospital admission time in Indian patients is prolonged to the extent of 300 minutes. And when they reach the hospital, they are primarily catered and cured by thrombolysis, and primary angioplasty is done only in the tune of 8%, and the thrombolysis is done by streptokinase. All this would lead to higher mortality, the 30-day mortality in STEMI in Indians as compared to the Western population. It's not only the age and the mortality, but if we see the education status of these patients in STEMI, you would appreciate that the primary level of education is quite low, and this may contribute to the long-term effect of management in STEMI. The symptom onset and prolongation of presentation beyond 6 hours is quite significant, and this probably leads to damage of the heart muscle and a lower LV ejection fraction in our group of patients. When we see the risk factors of these profile, we would appreciate that the conventional risk factors less explain the occurrence of STEMI, and we have to look for other causative etiologies. The health insurance of our population is only to the tune of 3 to 5%, and this also has an implication because the urban patient contributes to 62.5% of the patients and the rural 17%. But unfortunately, the availability of ambulance service for transport to the hospital is quite less. They use either private conveyance or public transport, and unfortunately, the payment mode for treatment is by the patient, and free treatment is available to quite less number of patients. This late presentation to the hospital has been reduplicated in almost all studies in Indian patients, varying from 4.5 to around 10.8 hours. In the CREATE data, it was around 6 hours. And this late presentation would lead to an opportunity to salvage the myocardium, which, if available in the early stage, can save these patients. We understand that late presentation is also contributed by the prevailing traffic conditions and congestion we have in our traffic. And for every 13 minutes delay, there is an 8% increase in the risk of 1-year mortality. The mortality would go higher as we go later to the hospital for care. This higher mortality in STEMI has been almost identical in the Kerala and CREATE registry of 8.2 and 8.6% and is significantly higher than the Western data. The higher mortality is after calculating the average GRACE risk score and explains that the numerous factors contribute. So if we see the Indian data, they have higher burden of STMI, they have lower age, they have delayed presentation in the hospital, more of them are thrombolized and few are subjected to PCI. Thrombolysis is done by streptokinase, resulting in a higher mortality as compared to the other data. The 30-day mortality is not the only factor. High 30-day mortality associated with a higher reinfarction, a higher cardiac arrest, and stroke rate. All this would contribute to the morbidity profile of these patients, and the 30-day mortality in the Kerala registry and in the CREATE registry is almost same. And if we extrapolate this data critically, we would understand that our patients are with higher mortality are of the lower middle class or upper middle class, and they would contribute to the mortality. So our lower age, younger patients and a higher economic burden associated with the rural and urban distribution discrepancy all leads to less number of PCI centers operating. A Hurricane effort by the cardiologist of increasing the PCI centers has done a continuous overwhelming effort resulting in control of this. The Tamil Nadu STE profile and the Kottayam profile has brought out clear outlines that the low per capita income, the density of populations in the city, a poor health insurance backup, variable standards of medical care, ignorance about the disease, disorganized and inadequate ambulance service, all is associated with lack of awareness in the patient population, silent or painless MI in the Indian population, delay for call, attention and equipped ambulances, and lack of primary PCI facilities, which has resulted in the increased mortality. The increased burden, the lower age, the predominant form of STI presenting as ACS, and in the Indian patients having lower LDL as compared to the Western population probably brings out clearly that we have to look at some variation in this paradox where the conventional risk factors in the northeastern India STMI group were lower, and we have to evaluate the hidden or the newer risk factors which may explain the disease profile better, looking at albuminuria, higher homocysteine, LPA, the thrombogenic factors, the oxidative stress, and the endothelial dysfunction all would contribute. To enumerate a simple example of serum albumin getting lower would lower the 9 factor 9, 11, 12, and because of the urinary excretion. Paradoxically, the liver will produce more thrombogenic factors and hamper the fibrinolytic system, promoting a clot formation in the coronary arteries. Associated with the environmental interplay of mutations in the gene coding, explaining that the low density lipoprotein in Indians also contribute to accelerated atherosclerosis. Re-emphasizing that opening up the re-establishing the infarct flow, but unfortunately the Kerala registry has told us that inappropriate thrombolysis was done in non-STMI and unstable angina, missing a chance of proper thrombolysis reserved for the STEMI group, and also emphasizing that appropriate thrombolysis by pre-hospital thrombolysis, facilitated thrombolysis, and the pharmacoinvasive therapy would help us in salvaging the myocardium by reducing the delay from the event to the reperfusion rate. If we have reduction, we will avoid myocardium damage and reduce the mortality. The CREATE registry has also taught us that the mean time from symptoms onset to reach hospital was high, and this is an opportunity of establishing the role of pharmacoinvasive therapy by thrombolizing them and then sending to a PCI compatible center. And CSI has done a lot of work in this and brought out position statements saying that thrombolytic therapy is recommended within 12 hours of symptoms. If primary PCI cannot be performed within 120 minutes of first medical contact, then thrombolize and consider these patients for a referral. We have to accept that our challenges are far and many, but we have to draw some conclusions that Indian young patients need to be prevented by a vigorous lifestyle holistic approach. The high STEMI burden has to be recognized with pre-hospital thrombolysis. The late presentations have to be cut short for their presentations, have more PCI centers, pre-hospital thrombolysis, pharmacoinvasive therapy, and probably this will give us an opportunity to controlling the menace of STEMI in India as guided in the CREATE, the Kerala, and the STEMI project. Thank you so much.
Thank you very much, Dr. Rajiv Gupta, for his brilliant presentation and the brilliant data. I'll request Dr. Alexander Thomas to introduce the next speaker. Dr. Alexander Thomas.
Thank you, Dr. Chopra. And let me introduce Dr. Prabhakaran. I think Dr. Prabhakaran requires no introduction really to this August group because the work he's done in epidemiology and cardiology, I think, is huge. I think let us go straight on to the talk by Dr. Prabhakaran. Dr. Prabhakaran.
Sorry, I was muted despite using webinars day in and day out to get into this problem. Thank you, Dr. Thomas, for that very kind introduction. I will straight away get into my talk. I hope you're able to see my screen. Okay. First of all, thanks to Dr. Nitish Naik and others to have invited me to give this talk, and it's great to be amongst friends today. So I have been given a topic, will a dedicated program improve practices and outcomes? So when you are invited, you agree and you don't think about the talk till the day before. And suddenly I realized I had to give this talk. And but it's good that when you do it in the end, you come up with new ideas, and I'm going to present some of these. The first question is, in terms of STEMI care, what do we know? And Dr. Rajiv Gupta nicely summarized some of the things that are there. One, we have observed tremendous strides in improving survival after acute myocardial infarction. There have been advances in the devices and drugs. There are new concepts such as pre-hospital care, but we still face several challenges in terms of pre-hospital, hospital, as well as post-hospital care. So I would say that we are living in Charles Dickens' world. In The Tale of Two Cities, he wrote, it was the best of times and worst of times. Similarly, for acute myocardial infarction care, it's really the best of times and worst of times. You saw the contrast between Kerala AC's registry and the CREATE registry. And in fact, the biggest reflection is the ratio of STEMI to non-STEMI. Kerala is almost reaching the high-income countries because with development, the STEMI comes down and non-STEMI increases. So the question that has been posed to me is, can a dedicated program address these questions? So when I looked at it, what should the program consist of? How should the program impact acute MI care? One, first is the center organization. How do we organize care? And what are the dimensions of care? Patients come to the hospital, they're lost in the casualty because of competing other emergencies. So I think triaging and expeditious ECG recording and rapid access to reperfusion is the need. Second is reperfusion strategy. This is from the European Society of Cardiology, which says 5 millilitres less than 30 minutes from diagnosis, primary PCI less than 60 minutes from door to arterial access, and transferred patients door to door out of less than 30 minutes. We need in-hospital risk assessment, secondary prevention and discharge advice. Patient satisfaction also should be taken into account, pain control, communication and discharge information, and rehabilitation. So the first question that we want to ask is, in terms of hospital-based quality improvement interventions for ACS, is there evidence? So there's been a systematic review that was published in 2019, which screened more than 5,800 articles and identified 32 studies, 14 of them RCTs and 18 non-randomized controls. The interesting point was the in-hospital mortality was 2.1 to 4.8% in the intervention group versus 3.3 to 5.51% in the control group. And in-hospital discharge and medications were 10% higher in the intervention groups, but there was no significant difference in 30-day mortality. But several low-income countries were not represented in this review, low or low middle income. So then I thought we should look at examples from India. There are 4 major examples now: the Mission Delhi and the Tamil Nadu STEMI program. I think Tamil Nadu STEMI program will have an opportunity. Dr. Alexander is here and he will talk about it. But just to summarize, the Tamil Nadu STEMI program actually showed a decline in a lower mortality at the end of 1 year in the people who participated in the intervention component of the program. I'm going to largely talk about the Kerala ACS quick study, which was a follow-up of the Kerala ACS registry, which was presented by Dr. Rajiv Gupta, and a new study that we are embarking upon to address some of these questions. Okay, I'm going to leave out the Tamil Nadu program. The first one, I'm going to talk about the effect of a quality improvement toolkit on acute myocardial infarction in India, the ACS quick cluster randomized step-wise trial. So the background for this was the basis that programs for improving process and outcome measures for patients with acute myocardium are widely deployed in wealthy countries. It's not only about the treatment, but the process of care itself is very important in reducing mortality and improving survival as well as quality of life in post-MI patients. Randomized trials of quality improvement interventions in Brazil and China have demonstrated improvements in process measures, but were not powered to detect differences in clinical outcomes. This I mentioned earlier about the Kerala ACS quick registry, and we found that there are areas of improvement even in a state like Kerala, and therefore we embarked on this study. One problem with this study is you can't do an individual trial because there are ethical issues. You're trying to improve things about which we know are likely to improve. So we had to resort to a different kind of trial, which we call as a step-wedge design trial. So the study period was between November 2014 to November 2016. There were around 21,000 patients in 63 hospitals participated. Our primary outcome was 30-day major adverse cardiovascular event, and secondary outcome was health-related quality of life and microeconomic cost. In terms of the design itself, in the first 4 months, everybody is recruited. But the intervention is introduced only to a fifth of the people in the next 4 to 8 months. In the next 8 to 12 months, 2/5 of the people will have the intervention, 2/5 of the institutions, 12 to 16 months, 3/5, 16 to 20 months, 4/5, and everybody at the end of it will have the intervention. Now, this is randomization at the hospital level, so it has a complexity in terms of analysis because we plan to analyze at an individual level. In terms of how we selected the patients, we selected patients with acute myocardial infarction admitted to participate in hospital. It was a multifaceted adapted quality improvement toolkit based on the American Heart Association Get With The guidelines. The comparator was usual care, and the outcome, as I said earlier, was MACE basically, and the time course was 30 days. In terms of the toolkit components, it comprised of an audit feedback reporting mechanism to inform monthly quality improvement meetings for plan, do, study, act cycle, which is a kind of thing which is used in industries and large industries, car manufacturers and all that. So you sit, plan, then you do it, then you study, and then you act, you improve on it every time when you do that. Then we had standardized admission and discharge order sets and clinical pathways. We had patient education materials on diet, activity, and tobacco cessation. We had code and rapid response team training assistance. Every team which participated in this were trained in terms of how to quickly respond to an acute emergency in the hospital. So there was communication within cohorts. They spoke to each other in terms of how to improve this program. And in terms of the institutions, we had around 67% private institution, 14% government institution, and 19% semi-government institutions. I'm not getting into the complex details of this, but we, at the end of the study, we had 10,000 patients in the intervention, in the control group, and around 11,000 patients in the intervention group. And as you can see, the loss to follow-up was extremely low, and it was a very robust design. Baseline characteristics, there were no major significant difference except for some marked diagram. In terms of in-hospital and discharge, their in-hospital treatment, the beta blockers, anticoagulants, echocardiography, and thrombolysis, discharge beta blocker, discharge statin, discharge was all improved in the intervention group as compared to the control group. The 30-day MACE on univariate analysis showed an unadjusted VAR, which means there was an 18% reduction in the intervention group. It was largely driven by a decrease in the 30-day death. It was largely driven by the decrease in death, but in terms of reinfarction and stroke, there were no major differences. However, what happened was when we do these kind of analysis, you have to look at secular trends, what's happening in the community. Are there any changes at the policy level? So there were two policy changes that came in. The Kerala government introduced an insurance program and cost of the stents started coming down. With that, when we adjusted for those, actually there was no major difference. So we concluded that the in-hospital discharge medications improved, but the MACE rate did not improve. The intervention may have been effective in settings where the baseline quality of care is not high. In Kerala, for example, you have 95% aspirin and 90% statin rate. So in that, how much can we really improve? But there is a scope for improving in situations where you do not have such high levels of care. And we used a unique method called implementation science method, which improves causal influence for improving quality of care. Now, given this fact, we wanted to learn and see what are the things that can improve. Where did we go wrong? Sorry, I don't know why the slides are going on its own. So I finished with this slide. So we looked at assessment of studies of quality improvement strategies. I'm sorry, I don't know what is happening. The slides are going on their own. So I'll just summarize what exactly we did. We looked at a scoping review to identify what are the strategies in terms of improving care, and we found there are patient-related strategies, there are health system-related strategies, and there are strategies that involve multiple stakeholders, including technology. And so we are embarking on a trial called CQuick, where we are looking at all the three components, and this trial is just begun. In addition, as I was talking today, I realized that there are other things that we can do. We have started 3 telemedicine centers in Tamil Nadu, and we are expanding into multiple places. The PHFI telemedicine platform embeds electronic health records, point of care diagnostics, electronic clinical decision support systems, and numerous state-of-art digital technologies. So these are the technologies that are there. For example, we have a FDA-approved cloud-based 12-lead portable ECG, which can give you an instant diagnosis. One of the major delays is patients can go to a primary care, get an ECG done, go back, come back, and all kinds of things happen. So there's a big delay. The second thing is this is a device, a point of care device, which is AI enabled, but currently it does not do troponin T, and we are working on to add troponin T, BNP, and several other parameters. So this will be an addition which will come in another 6-7 months. Obviously, we have very high definition camera and an electronic stethoscope and a decision support system, all of which can help. So this is how we call it the cortex, and this is how it looks. But these clinics, telemedicine clinics, these are assisted telemedicine clinics where the nurses or someone is there, can actually help identify people with myocardial infarction, and pre-hospital care can be given quickly. So if I have to conclude, I think one of the things that we need to do is to think out of the box. We need to go beyond what we do in acute care, but we need to improve post-discharge care. We need to improve rehabilitation and several other areas. So as somebody said, technologies are reductionist, and science is also reductionist, that we look at every aspect of science in a reductionist way. I mean, we want to improve the LV function, we want to reduce LV clot, we want to improve survival, but ultimately we have to provide holistic solutions. So look at the process of care, and we need to create a program, and this is a great opportunity in terms of CSI organizing a STEMI conference where we can discuss, deliberate, and identify such programs. Thank you very much for this patient hearing.
Thank you very much, Dr. Prabhakaran, for a brilliant exposition. May I request Professor Rakesh Yadav, if he's there, kindly introduce the last speaker. Professor Rakesh Yadav. If he is not there, may I request Dr. Naveen Jamwal to introduce the next speaker.
Sir, after such wonderful talks, I think we need to put the icing on the cake, and for that I'll invite Dr. P.C. Negi, who is the professor and head of Department of Cardiology in Shimla, for his talk on pre-hospital thrombolysis, challenges for care. Dr. P.C. Negi, please, sir.
Slides, is the slide visible? Hello.
Yes, sir. Yes, sir.
Yes, sir. Good afternoon, and I thank organizers for inviting me to speak on this topic, which is pre-hospital thrombolysis challenges for the primary care. As has been already highlighted by the previous speakers, the burden of STEMI in our country every year, approximately 3 million people are affected with STEMI. Talking about the STEMI, there are two important issues. One is basically the pre-hospital delay, which has already been highlighted. Based on the data from the registries from our country, the pre-hospital delay ranged from 300 minutes to 780 minutes, which is much higher than what has been reported from the high-income countries. Second important issues is basically very suboptimum reperfusion therapy, which is much lower than the reperfusion the rates which have been reported from the high-income countries. So we have large unmet need of reducing the ischemic time and increasing the reperfusion therapy in patients with STEMI. The reduction in the mortality with the early initiation of reperfusion therapy is critically time dependent. Earlier is the initiation of reperfusion therapy after the symptom onset, greater is the risk reduction. It is particularly critical in the first 3 to 4 hours. And after 4 hours, the time-dependent reduction in mortality, it gets attenuated. So the patient presenting in the first 3 to 4 hours, we need to be very, very efficient in diagnosing the patients with STEMI and thrombolizing the patients to those who are eligible for thrombolytic therapy in order to maximize the reduction in the mortality. So there are a number of clinical trials which have been carried out to evaluate the efficacy and safety of the pre-hospital thrombolysis in patients with STEMI. One is the CAPTIM trial, where patients of STEMI presenting in the first 6 hours were randomized to pre-hospital thrombolysis or transferring them to the PCI-enabled centers, and short-term and long-term mortality were compared between these two forms of strategy reperfusion strategies. Patients who received the reperfusion therapy in the first 2 hours, mortality was significantly low in the thrombolysis arm compared to the PCI arm. However, when the reperfusion therapy was started after 2 hours of symptom onset, there was no difference between the two modes of reperfusion therapy. So therefore, time is very important component in how effective would be the reperfusion strategy, particularly thrombolytic therapy, in order to decrease the mortality. So PRAG-2 trial was another trial where patients of STEMI presenting within 12 hours of symptom onset in non-PCI hospitals were randomized to thrombolysis at the in the non-PCI hospital and were randomized to the transfer to the PCI hospital, and 30 days outcomes was compared. If you see the overall results, there was PCI was better than the thrombolysis mode of reperfusion. But when the data was analyzed in relation to the time from symptom onset to the start of reperfusion therapy, There was no difference in the mortality rate in patients who received the reperfusion therapy in the first 3 hours. However, those patients reporting after 3 hours, primary PCA was significantly effective in reducing the risk of mortality compared to the thrombolytic therapy. STREAM trial was another trial which basically enrolled patients of STEMI presenting within 3 hours and were randomized to pre-hospital thrombolysis or to the primary PCI by referring to the PCI-enabled centers. And 12 months out, the mortality outcomes as well as the safety outcomes were evaluated. So in this study also, there was no difference in the 12 months mortality between the two modes of reperfusion. However, as expected, the bleeding complications were higher in patients who received the thrombolytic therapy. So we can conclude based on the available evidence that pre-hospital thrombolysis and in-hospital thrombolysis within 3 hours after the symptom onset is as effective and safer as the primary PCI in reducing the risk of mortality. However, patients who presented after 3 hours, probably the PCI may be better mode of reperfusion than the thrombolytic therapy. There are a number of challenges of reperfusion therapy in our context. As has been highlighted by the previous speakers, that a large proportion of our population lives in the rural population, and which are basically cared. The health services are basically provided by the primary care hospitals, and these primary care hospitals are not equipped to make a diagnosis and deliver this the thrombolytic therapy. And we have also reported in our ACS registry that the proportion of patients who who are transported to the hospitals, the ambulance services are seeking a small percentage of patients in the range of 10 to 15%. And also the ambulance services are not equipped with the trained manpower and necessary logistics to deliver the thrombolytic therapy. So also one of the major important barrier in timely delivery of the reperfusion therapy is the pre-hospital delay. So large proportion of patients, they become ineligible for the thrombolytic therapy because they do not reach within first 12 hours. And it has been already highlighted that PCI-enabled centers are very small and they are mostly located in the big cities. So since a large proportion of the patients of STEMI population are living in the rural population, the primary PCI is very distant dream in our context. How we can translate the available evidences into practice in the Indian context, I think it is feasible. We can develop a kind of a spoke and hub model by establishing the regional networking of all the hospitals in the government as well as in the private sector in a defined geographical area where you have the tertiary care center with PCI facilities. So you need to develop the local networking of these hospitals under this tertiary care hospital and establishing the 24-hour by 7 teleconsultation services by linking with these hub centers. And also making, by ensuring the availability of the diagnostic tool, thrombolytic therapy, ECG monitor, and defibrillator devices at these spoke centers. And we also need to focus our attention or take interventions to decrease the ischemic time by taking initiative at the public level through public education to decrease the response time from the patients after the onset of symptoms and reaching the hospital. And we also need to take initiative at the system level by taking some kind of quality initiative, as Dr. Prabhakaran was highlighting, in order to decrease the time from first medical contact to the initiation of the thrombolytic therapy. So IGMC has an experience of pre-hospital thrombolysis. We are basically part of ongoing multicentric controlled clinical trial being coordinated by All India Institute of Medical Sciences, New Delhi for last almost 1.5 years. It started in March 2020. So this study is basically trying to answer whether the capacity building and providing teleconsultation and tele-ECG based decision support system could make any difference in the change of thrombolysis rate in the primary care hospitals or not. And secondly, to see whether the improvement in the thrombolysis, if it takes place, whether it impacts in hospital mortality in these patients. So we are implementing this spoke and hub model of care of STEMI patients in the district Shimla, having a population of 0.9 million. And we have basically selected one hospital, at least from each block. Practically from every block, we have one spoke center, and hub center is Medical College, IGMC, which is the situated in the other corner of the district. So patients with the suspected symptoms of ACS are basically evaluated by the healthcare provider in these spoke centers. And after brief clinical evaluation, ECG is being done, and ECG is shared in the WhatsApp group that we have formed with the panel of faculty from IGMC, as well as our DM residents and medical specialists, and who provide teleconsultation services 24/7 and help the healthcare provider interpreting the ECGs. And if the diagnosis of STEMI is made and contraindications are ruled out, and they are basically advised to provide thrombolytic therapy. We have provided them the thrombolytic agent TNK to these spoke centers from the project budget. And after receiving the thrombolytic therapy and the loading platelets, patients are referred to hub center, that is IGMC, whether they have successful thrombolysis or not. So in the transportation, we have not seen any deaths in the last 1.5 years. And this is in brief the results. Till date, we have identified about 450 patients of ACS. Majority of them were STEMI. Almost 80% of the ACS population were STEMI population. And if you compare the demographics and cardiovascular risk factors or the patients who visited the spoke centers, hub center, or non-hub centers, practically they are identical. Let me share you that almost 50% of the patients were basically treated in the spoke centers, and remaining 50% were treated in the hub center and the non-spoke centers. Non-spoke centers are basically few private nursing homes where they do not thrombolize the patient. They make a diagnosis where almost 9% of the patients reported to these the non-spoke centers, and ultimately I think the distribution was 50-50%. So one of the major the findings which we have noticed was the pre-hospital delay was significantly low, which was 220, median delay was 225 minutes compared to the 435 minutes of median delay at the patients who reported to the hub center. So there was a significant reduction in the pre-hospital delay. So more patients could be thrombolized. So one of the major reasons for pre-hospital thrombolysis is basically the ignorance of the symptoms. And lack of transportation and event occurring in the odd hour contributed very small percentage of the overall causes of the pre-hospital delay. So we need to really work hard how we can decrease the pre-hospital delay through the extensive kind of community level health education programs, creating awareness about the symptoms of ACS. And this shows basically the thrombolysis rate in the spoke center as well as in the hub center. The thrombolysis rate has significantly increased to 73.4% in the spoke center, which was 52%, because in hub center, large proportion of patients were out of window period because of late reporting and long traveling time. And when we analyze the time delay from the after reporting first medical contact to the initiation of thrombolytic therapy, it was 50 minutes in the spoke center and was almost 70% in the 70 minutes in the hub center. I think more centers with a high volume where the patient normally, takes time for patients to get evaluated, ECG being done, diagnosis is made, and the patients are referred to, shifted to the CSU setting. This is how the hospital delay is significantly high in the high volume center compared to what we have seen in the spoke centers. So we need to really take some kind of quality initiative, as Dr. Prabhakaran was stressing, because these are important delays. We are trying to decrease the ischemic time, but even if patient reaches these healthcare centers, system level delay is also one of the important factor contributing to the longer ischemic time. And 15% of the patients underwent PCI for the rescue PCI or as a primary PCI. We did not do routine pharmacoinvasive reperfusion because of the COVID. In the last 1.5 years, because of COVID, we did not undertake patients for routine angiography and PCI to patients who have received thrombolytic therapy at the primary healthcare center. This is the in-hospital mortality. Overall mortality is 9.2%, which is significantly still high. But if you compare the mortality rate in the spoke center as well as in the hub center, the mortality rate in the patients who were first treated in the spoke center was 4.9%, which was significantly low compared to what has been observed in the mortality in the hub center, which was 15.1%. Secondly, the mortality rate was significantly low in patients who received thrombolytic therapy in the hub center, while it was not different in the patients who received thrombolytic therapy in the spoke center. So ideal, the model of care for STEMI, we should aim to achieve a very empowered community where each one of them are aware of symptoms of acute coronary syndrome, so that the response time from the onset of symptoms to the activation of the emergency medical services should not take more than 5 minutes. And we should have efficient transportation system, preferably through the national ambulance services, where patients are quickly shifted to the primary healthcare settings, where patients should be thrombolized, and after thrombolysis, patients should be referred to the PCI center. Because as I said, these primary healthcare hospitals are not really trained. The healthcare providers are not trained to make a diagnosis of PCI, and also patients do not feel confident in getting these kind of high the treatment for STEMI patients for the high risk medical conditions in primary healthcare setting. And general tendency is that patients insist in referring the patients to the tertiary care hospital without realizing the impact it is going to have in terms of delay in the initiation of the reperfusion therapy. So we need to have a strong teleconsultation services where these primary healthcare center needs to be linked to the tertiary care hospital in a given region, so that the consultation services through the ECG-based decision support system or teleconsultation directly, both are important factors to gain confidence of the primary healthcare providers to make a diagnosis and start the thrombolysis, which is very time sensitive in the primary healthcare setting. So overall, we should aim to at least get the patient thrombolized in the first 2 hours. As I said, thrombolizing patients in the first 2 hours is as effective, maybe better, more effective in reducing the mortality compared to the primary PCI, which is not practically feasible to do primary PCI as a mode of revascularization in patients with STEMI in our context. So I would like to conclude by saying thrombolysis at primary healthcare services is feasible and safer, and it reduces the ischemic time. The hospital mortality rate is significantly reduced in hospital thrombolysis in the primary healthcare setting. And there's a need of upscaling the spoke and hub model at the country level to reduce the mortality rate because of STEMI patients. I think the STEMI Council of the CSI can play a big role because there are large number of members are there across the country. And each, I think with the collaboration with the state health services, we should try to develop these spoke and hub model at each state, at each district levels, so that more and more patients are diagnosed early and they are thrombolized in the primary healthcare setting, which we have demonstrated to be effective and safer. And also, we need to take some intervention to decrease the ischemic time by taking some kind of intervention at the community level as well as at the system level to further decrease the ischemic time and give the benefit of thrombolytic therapy to the larger proportion of patients with STEMI. Thank you very much for your kind attention.
Thank you very much, Professor Negi. I think it was a brilliant presentation and a beautiful data. The power and promise of pre-hospital thrombolysis, I think, is beautifully expressed. I request Dr. Iyengar and Dr. Alexander to give the final concluding remarks. Dr. Alexander and Dr. Iyengar, please.
Thank you, Dr. Chopra. I think we had an excellent session where we had the talks where both of great academic and practical value. And I think I will request Dr. Thomas Alexander to say more about it because he leads the STEMI project in the country. Dr. Thomas.
Thank you, Dr. Iyengar. I think we've had 4 very good talks today, and I think there's been a repeated emphasis on the need for a system of care or a STEMI network, because we've known all along that the total ischemia time is what is critical. And the door to balloon and door to needle times constitute usually a very small fraction of the total ischemia time. And I think the non-system and system delays in getting a patient to recognize the symptoms, to get to a medical facility where reperfusion therapy is available, are I think the most critical aspects of any STEMI system of care. The second is that we have seen in our data that the low-hanging fruit is really the shift in strategy from thrombolysis to pharmacoinvasive or primary PCI. And that's easy or much easier to achieve than reducing time, the total ischemia time. And I think by setting up a hub and spoke model, we can quickly get a patient from no reperfusion or thrombolysis standalone to a pharmacoinvasive or primary PCI reperfusion strategy, both of which would significantly reduce mortality. And I think these are important lessons that we've learned. And I think unless the governments, the doctors, that's cardiologists, all of us work together, it is going to be a very, very difficult task to implement a model like this in this country.
Thank you very much, Dr. Alingna Thomas. And let me express my gratitude to all the chairpersons and all the speakers and everyone for an excellent session. Thank you very much. With this, we conclude the session. And I'll request Dr. Nitish Naik to start with the proceedings of the next session. Thank you.
Thank you, chairpersons and speakers. Next, we move on to the second session for today, Optimizing Therapy in STEMI. For beginning this session, I'd like to invite the chairpersons, Dr. Arvind Kumar, Dr. C.B. Meena, Dr. Harminder Singh, Dr. Imran Ahmed, Dr. Justin Paul, and Dr. Nirmal Ghati to the session. And we have 4 speakers in this session with a time limit of 10 minutes per speaker. We'd again like to request the speakers to kindly adhere to the time limit. I'd like to request Dr. Harminder Singh to kindly open the session.
Good afternoon, friends, and welcome to this interesting session on optimizing therapy in STEMI. Now, we have 4 eminent speakers, and to set the ball rolling is beta blockers in STEMI, the current status. This talk will be taken by none other than Dr. P.S. Banerjee, who needs no introduction. He is a leading cardiologist and a leading member of CSI and has contributed immensely to the teaching of cardiologists all over the country and in Calcutta. So I'll invite Dr. Banerjee to give his talk. Dr. Banerjee, are you there, sir?
Yes, I'm there.
Thank you, sir.
Yes, I'm there. So, thank you very much, chairpersons, and all the members who are present in this meeting. So, I have to talk on the beta blockers in STEMI, the current status. Next slide. Now, we all know that the beta blocker is a wonder drug and is being used for a long period in different cardiovascular diseases like in acute MI, where the beta blocker therapy can reduce the risk of death when started early, and the evidence is seen in the STEMI. But in case of non-STEMI, of course, the evidence is only from the meta-analysis and the registry data, where there are no randomized trials to say that it is beneficial in the non-STEMI. Here we will discuss the role of beta blockers in STEMI. Now, he is the person, James Black, who invented propranolol in 1962 and got the Nobel Prize in 1988. Now, how it helps to reduce the ischemia by reducing the myocardial oxygen demand, increase the coronary blood flow, alter the myocardial substrate utilization, decrease the microvascular damage, and stabilize the cell and lysosomal membranes. And these are the different types of beta blockers commonly used in the clinical practice. The non-selective being the acebutolol, propranolol, partially cardioselective, atenolol, metoprolol, and highly cardioselective, nebivolol and bisoprolol. Now, coming to the role in the STEMI pre-thrombolytic era, what is the role of beta blocker? The Göteborg trial, one of the first randomized double-blind trial to demonstrate the beneficial effect of beta blocker on survival during the early phase of AMI. It randomized almost 1,400 patients, the metoprolol versus the placebo. Intravenous metoprolol was initially given, followed by the oral metoprolol, and patient treated within 12 hours of the onset of the ischemic pain, which showed that there is a lowering of the LDH level, 16% decrease in the index infarction, and 90-day mortality decreased by 36%. Now, role of STEMI again in the pre-thrombolytic era is another trial, Miami trial, where there is a significant decrease in the development of definite infarction and reduction in the tachyarrhythmia with the metoprolol, especially when being started within 7 hours of the symptom onset. and there was no statistical difference in the mortality percentage. So pre-thrombolytic era, the role of beta blocker evidence from all the trials available show the overall mortality reduction between 10 to 25%. Now coming to the role of beta blocker in STEMI, the TIMI-2B trial assess the effects of immediate versus deferred beta blocker therapy in patient receiving the IV RTPA. Now, immediate beta blocker produced no improvement in the left ventricular ejection fraction, nor reduce the mortality at the hospital discharge, both in the invasive and the non-invasive arms. However, the reduced reinfarction rate and recurrent chest pain noted with the use of beta blocker during the thrombolytic therapy. GUSTO-1 post-hoc analysis has shown that oral atenolol conferred a 5-fold lower mortality risk, and it is associated with decrease in the incidence of stroke, shock, and arrhythmia, but there is increased recurrent ischemia and reinfarction. Now, in the thrombolytic era, 2004 STEMI guideline by AHA and SEC recommended the use of early IV beta blocker in those undergoing fibrinolytic treatment. Doubt was raised from a review of the GUSTO-1 trial with atenolol, and 2007 issued a new guideline by SEC-AHA and took into the account the COMET study of the metoprolol. Now, this COMET study of the metoprolol has shown, show me the next slide, the previous, that the conclusion of this study has shown that overall metoprolol increased the risk of cardiogenic shock by 11%, chiefly during the first day of hospitalization, especially when given in the IV route. In acute MI, it may be better to start beta blocker therapy when the patient is stable and continue with the long-term therapy. So thereby oral therapy in the early stage should be preferred than the IV therapy. Next. Now, administer IV beta blocker if at all on day 0 to 1, if the patient has got associated hypertension, he has got sinus tachycardia or atrial fibrillation, provided the bedside echo shows the normal LV function. Avoid early oral beta blockers if there is evidence of heart failure, increased risk of cardiogenic shock like in elderly people, and many other risk factors like low blood pressure. And there is a relative contraindication for early beta blocker therapy if the patient presents with AV block starting from first degree to higher degree AV block and active severe reactive asthma. So these are the relative contraindications. If early contraindications are present, then re-evaluate the suitability of the beta blockers after 24 hours of the STEMI. So what should I do? That from day 2, benefit is seen on the reinfarction rate and ventricular fibrillation reduction rate. Start with the metoprolol 50 mg 6 hourly, can go up to 200 mg a day, and long-term use is strongly recommended to reduce the incidence of further ischemia, mortality, as well as the arrhythmia. Next. Now, role in STEMI, the Metocard CNC trial enrolled clip 2 or less in anterior elevation STEMI, and they have received metoprolol versus placebo during the first 24 hours. Again, 3 doses of 5 mg IV given 2 minutes apart, followed by the oral therapy 20 to 24 hours later. Now, infarct size assessed through the MRI in 5 to 7 days after the STEMI, and the conclusion was that pre-PCI IV beta blocker reduced the infarct size by 20%. Lesser the infarct size means better the LV function and post-MI in the PCI group. However, it only studied the anterior MI, not the other type of MI. So thereby authors say, although the important and encouraging, the results in the Metocard CNIC trial are probably not strong enough to warrant a change in the clinical practice of the use of beta blocker in patients with the STEMI. Then another trial came, early BAMI trial. It is again a double-blind randomized trial, and they have used CMR to assess the infarct size, and IV beta blocker was given pre-PCI. The primary endpoint was myocardial infarction size by CMR, and the conclusion was IV beta blocker administration did not significantly affect the ST segment deviation after primary PCI compared with the placebo. So there was no subsequent improvement in the clinical outcome with the early use of beta blocker administration in STEMI. So it is now well established for the oral therapy of the beta blocker. The Capricorn trial has shown the use of carvedilol in the post-MI patients, especially with the left ventricular systolic dysfunction. Now coming to the choice of beta blocker, use a cardio-selective one like metoprolol, carvedilol, or bisoprolol. Atenolol is not commonly used nowadays. Start with the low dose, go slowly to up-titrate the dose. If ongoing ischemia is present before primary PCI, some group recommend IV metoprolol or esmolol, but watch for bradycardia and hypotension. If hypertension is present, it is better to use the IV NTG rather than the beta blocker to reduce the blood pressure and also the ongoing ischemic pain. Next. So long-term therapy is the how long. The optimal duration of the treatment is not yet clear. Evidence supports the total duration of the treatment of 3 years, not much longer than that. When stopping, taper the dose. Registry data showed no difference in benefit between the beta blocker and no beta blocker groups at 2 years. May be better for those with the high risk of left ventricular systolic dysfunction and patient with the chronic kidney disease. In the high risk patient, longer duration of treatment is acceptable. So long-term therapy, how much? Clinical trials suggest that 200 milligram of dose daily of metoprolol is recommended, but this is not practical, so not used in the clinical practice. The best policy is to start with the lower dose and gradually up-titrate the dose as the maximum dose the patient can tolerate, and better to use the long-acting preparation. Now, the role of very early beta blocker in managing the STEMI is not very clearly defined. However, its role in preventing the arrhythmia in the post-MI is well established. The careful assessment of patients must be done before starting the beta blocker as per the guideline of the American Heart Association. Start beta blocker within 24 hours if the patient is stable and no contraindication exists. Beta blocker after STEMI reduce the overall mortality and non-fatal MI and sudden cardiac death. But of course, we require more and more data. As always, we have seen in the years to come that how much further information we can get with the beta blocker in STEMI. Thank you very much for your attention for this session. Thank you.
Thank you very much, Professor Banerjee, sir, for a very lucid and although a very age-old topic, but you have shown very systematically. Thank you very much. The next speaker is Dr. V.K. Chopra, and he's going to talk about the in thing these days, whether we should prefer ACE inhibitors or ARNI in post-MI heart failure patients. It's a very exciting topic, and I'll hand over to Dr. V.K. Chopra. I'll request Dr. Justin Paul to introduce the next speaker after Dr. Chopra. Thank you very much.
Good afternoon, chairpersons, and thank you very much for this invitation to speak on this particular topic. So ACE or ARNI for post-MI heart failure, where do we stand? We know that patients with MI are at high risk for developing heart failure as years go by. And these are 3 studies. On left-hand side, you can see that this is a study which was published in 2018, indicating that during a follow-up of 13 years, 10% of total participants develop heart failure. Among those where there was a clinical MI, the incidence was much higher at 31%. But even in those who had silent MI, the incidence was 17.7%. There's another study which was published in 2018, which showed the incidence of heart failure among patients hospitalized for heart failure MI varied from 14 to 36%, and it increases the odds of in-hospital mortality. And a third study, which was published earlier in 2009, also showed a high incidence of post-MI patients developing heart failure. So why does it happen? As we know, after myocardial infarctions, there are arrhythmias, loss of muscle, There is cardiac remodeling, which leads on to ventricular dilatation, hypertrophy, and formation of discrete collagen scars. And with this progression, ultimately, the people end up with heart failure. The onset of heart failure stimulates neuroendocrine activation. Initially, these are adaptive responses, but in course of time, they become maladaptive and they lead on to all the adverse effects. And indeed, suppression of these renin-angiotensin and sympathetic nervous system has been documented to demonstrate a significant improvement in patients of heart failure. The third arm, that is natriuretic peptide, was for a long time could not be utilized for various technical reasons, but we know that ARNI was developed, which was a combination of sacubitril and valsartan, and that resulted in elevation of natriuretic peptides, which resulted in significant benefit. And we are all familiar with Paradigm trial, the landmark trial, which was published in 2014, which indicated that in patients of chronic heart failure, there was a 20% reduction in hazard ratio with a number to treat only 21 and a very strong p-value. This firmly established its place in management of heart failure. And not only was there improvement in patients of heart failure, hospitalizations and death, but also certain cardiac deaths were significantly reduced in patients of heart failure and reduced ejection fraction. So why is that? We'll come to that a little bit later. As far as the patient is concerned, for that patient, quality of life parameters are important. And this is a sub-analysis of Paradigm, which was published in 2017, which indicated that all quality of life parameters improved significantly when the patients were on sacubitril valsartan as compared to enalapril. Now, we know that patients with NYHA class 2 are at high risk of sudden cardiac death. The patients of NYHA class 3 and 4 are going to die of progressive heart failure. But in NYHA class 2, 1 in 2 heart failure patients with NYHA class 2 experienced a sudden cardiac death. And therefore, since there was a significant reduction in sudden cardiac death also, it becomes necessary that even patients early in the course of their disease, when they are not in advanced heart failure, they are likely to benefit by the introduction of ARNI. So this much is about the chronic heart failure. There was another trial by the name Pioneer Heart Failure, which was published in patients which were hospitalized for acute heart failure. And the primary endpoint was change in NT-proBNP from baseline. And we know that change in baseline, change in NT-proBNP translates into better outcomes. So here, as you can see, there was a significant improvement in NT-proBNP with sacubitril valsartan as compared to enalapril. And this translated into 46% reduction in risk of composite of serious clinical events in hospital patients as compared to enalapril. Further, this was driven mainly by reduction in rehospitalizations for heart failure. The other parameters were not so much benefited, although the composite of serious clinical events was significant with a 46% reduction, but main driver was rehospitalization for heart failure. There was another study by PROVE-HF study. So that gave us some idea about the mechanical aspects of it. And we learned from this that ejection fraction improved by 33%, end diastolic and end systolic volumes reduced significantly, left atrial volume index reduced, and therefore these results were consistent across all subgroups, which included ACE, ARB, naive, and newly diagnosed patients. So there's a strong mechanistic reason why these drugs work, and they give the benefit that have been shown. Similarly, another study which was published last year by Mirek also showed similar findings with a reduction of end diastolic and systolic volumes and left atrial volume. And again, this potentiated the previous study that these are mechanistic effects which translate into very, very significant and clinically relevant clinical effects. Based on this, the 2019 guidelines of heart failure by European Society of Cardiology mentioned that sacubitril valsartan is recommended as a replacement for ACE or ARBs to reduce the risk of heart failure, hospitalization, and death in ambulatory patients with HFrEF who remain symptomatic despite optimal medical treatment with ACE, beta blocker, and MRA. The American guidelines went a little bit further and they took out this bit and they strongly recommended that sacubitril valsartan should be the first choice in this group of patients. Initiation of sacubitril valsartan rather than ACE or ARB may be considered for patients hospitalized for new onset of heart failure or decompensated CHF to reduce short-term risk of adverse events and to simplify management by avoiding the need to titrate to ACE first and then switch to sacubitril valsartan. Because these patients are already at high risk for events, there's no need to check plasma concentration of natriuretic peptides. So the thought earlier was that first patients should be on ACE or ARB, and once they have tolerated, as was done in a clinical trial, then only they should be shifted onto ARNI. But over the years, as we have gained more and more experience, people are very comfortable in starting with this drug as a first drug itself. Of course, watching the blood pressure and other parameters. Now we know that renal dysfunction is a very important component in heart failure. So should we worry about renal dysfunction? So these are the effects of sacubitril valsartan. Since BNP levels are increased, we know that BNP increases GFR through the efferent arterioles, vasoconstriction of the efferent arterioles, and relaxation of mesangial cells, and inhibits renin secretion. Also, acting in proximal tubule, they prevent sodium reabsorption, and they also reduce post-glomerular resistance. And also in collecting duct, they reduce sodium reabsorption. So you can see that there are various mechanisms by which they improve GFR and they help the patients as far as renal effects are concerned. So does it really translate into clinical effects? Yes, we saw in Paradigm heart failure trial that as compared to enalapril, the decline from baseline GFR at 48 months was much slower with sacubitril valsartan as compared to enalapril, indicating that it has got a renoprotective effect also. What about the side effects? The discontinuation of renal adverse events were lower in sacubitril valsartan as effect was most pronounced in patients who already had CKD. So that means in these patients, there was a very significant p-value. People without CKD also benefited, but not as much as people with CKD. So many times there is a hesitation in using this in patients of CKD. That should not be so, because there is a strong data available that this is even more useful in this group of patients. What are diabetes? Although non-diabetics also benefited, but the benefit of sacubitril valsartan was larger in HFrEF patients with diabetes than those without diabetes as far as GFR was concerned. So even more important in diabetics that we should keep them on ARNI rather than on ACE inhibitors. So the summary of renal data from Paradigm heart failure was that it had a favorable renal and cardiovascular safety profile compared to enalapril. Sacubitril valsartan was associated with significant reduction of CV events in patients with and without CKD. There was a lower risk of post-hoc composite renal outcomes, significantly slower decline in GFR independent of CKD at baseline, and this effect was even more pronounced in diabetics. There was a modest increase in urinary albumin creatinine ratio at 1 month and 8 months. However, worsening of UACR was associated with a higher risk of the pre-specified composite renal outcome in enalapril group. Rate of GFR was slower with sacubitril valsartan, as I've already shown. So indicating that not only are they beneficial in heart failure, but also in renal parameters. So summarizing, I would say that initially when the drug was introduced for a couple of years, there was a lot of resistance, a lot of hesitation in the minds of people. Should we be using this drug? Are ACE inhibitors not good enough? They have a strong vasodilator effect. They result in more hypotension. But we saw in Paradigm trial that although hypotension was more because it is a stronger vasodilator, yet the rate of discontinuation of drug was not statistically different than enalapril. It is more renoprotective. The incidence of hyperkalemia is less with ARNI as compared to enalapril. And therefore,
sir, could you save some time, please? I think we are exceeding time.
Ultimately, we have to use our judgment and decide what needs to be done. Thank you very much.
Thank you very much, Dr. Chopra. It was indeed a very enlightening talk. Next to discuss with us the appropriate thrombolytic therapy for a country like India with multi-faceted healthcare systems and people who can afford differently. I invite none other than Dr. P.C. Rath, a doyen of interventional cardiology, who has developed the interventional cardiology along the Coromandel coast down south all the way to Bangladesh and beyond, to talk on thrombolytic therapy. Choose the best thrombolytic therapy. Dr. Rath, the podium is yours.
Yeah, thank you, Dr. Justin Paul, for a nice introduction. Good afternoon, the chairpersons and participants. Can you just put the slide? The best thrombolytic agent in STEMI. That is the topic I have been given to speak. So, hello, can you hear me?
You are audible, sir. You are audible.
So why go back to thrombolytic therapy in the current PCI era? That's because we are going through ongoing COVID pandemic, and the logistic of being primary PCI is very different in this time. You all know about it. Pharmacologic therapy has shown that it's equally effective in all primary PCI patients except patients with cardiogenic shock. Availability of cath lab in the right time within 120 minutes is really difficult in the Indian scenario. And now we are promoting telehealth solution remote areas where we are promoting thrombolysis in the ambulance itself. So that is why we feel thrombolytic has a big role nowadays. Now, STEMI guidelines state that acute vital infarction within 12 hours, we should treat by reperfusion therapy. Guidelines from ACC, AHC, and VSC agree that primary PCI is the gold standard for reperfusion treatment in STEMI if delivered within 120 minutes of diagnosis. Beyond that, you don't get the benefit. But this is possible, but this is not possible. Fibrinolysis should be performed with the fibrinogen-specific agent like tenecteplase or ready as soon as possible within 10 minutes of STEMI diagnosis, preferably in pre-hospital alongside other adjuvant therapy like anticoagulation and antiplatelet. Thrombolytic agent that we have already is the first generation urokinase and streptokinase. Still, streptokinase is very widely used in India and a lot of developing and underdeveloped countries because of the price constraint. And LDPase is no more used in heart condition. They are more into CV and all these things. So we have in third generation tenecteplase, antiplase, and others are not available. Now, advantage for this tenecteplase is just give a bolus dose, but its problem is you have to titrate it according to the weight of the patient. Tenecteplase, we have 2 doses you can give it. Fixed dose, no need for any titration, and altipage and streptokinase you have to keep in infusion. Comparing all these 3 drugs, tenecteplase, altipage, and tenecteplase, I think immunogenicity is there's a tenecteplase. All 3 do not have any, but tenecteplase has got more fibrin-specific activities, and plasma half-life is 20 minutes. And PIA high resistance is more, that means more effective compared to retiplase and antiplase. The ideal thrombolytic agent is a rapid acting, and in this tenecteplase fits in. It should be high efficacy in terms of both 60-90 minutes vessel patency. Tenecteplase scores over others. Low incidence of adverse reaction, particularly bleeding and stroke. Both tenecteplase and retiplase are okay with this. Low reocclusion rate, again, tenecteplase scores over others. Easy to administer, again, bolus tenecteplase. Simple dosing is probably retiplase is better because you have fixed dose to half an hour interval you give it. but tenaciously you have to titrate according to the weight. Good long-term effect and clinical outcome, it has been shown in tenacioplase, was cost-effective is always stuck up. So tenacioplase in brief, the only single bolus thrombolytic agent available commercially. The only thrombolytic proven to be equivalent to RT-PCR regardless of patient's subgroup. Fast and easy to administer within 5 to 10 minutes in a bolus dose. Optimal efficacy through tailored weight-adjusted dosing. Fast acting, reduce risk of bleeding complication when used with STEMI. Increase resistance to PI compared to RT. So this is the way you are dosing according to weight. If it's less than 60, 30 mg, and probably if the weight is more than 90, 50 milligram is according to the weight you titrate. Clinical trials, we have some from Andhra Pradesh that represent publication 2008. Prospectively, they analyzed 100 patients from June 2016 to 17, and this is the conclusion. CST, this was overall CST resolution of tenacioplase was 92%. If the patient presented within less than 3 hours, it was 94%. More than 6 hours, it was 84%. And ST resolution also overall was 94%. So in conclusion, they concluded that the study reinforces the efficacy, safety of tenacioplase in patients. This study also confirmed the importance of early thrombolysis. And this is resolution was 93%, 50% if there are within 90 minutes if the patient present, then 91%, and overall resolution is 97%. This is another study from published in that is Indian Heart Journal. Is a multi-center study. Iyengar and all published in 2013, and large 15,222 patients. Indian connected case. This is the overall thrombolysis. This is the overall 95.43%. If the patient presents within 3 hours, is 96%. Than 3 to 6 hours, 96%. More than 6 hours, 85%. This is a successful thrombolysis. So in this study, this is another presentation study presented in Association of Physicians India by Shem Du, SSI Iyengar and others. They did a multi-centric observation study with 7,668 patients, and from January 2017. This was the result. Overall rate of achieving CST by tenacioplase was 93.34%. 93% patients had chest resolution. Overall 91% had 50% resolution, still at 90 minutes. 53% died, mortality was 0.69%. The incidence of bleeding was 1.77%. Stroke without ICH is 0.18%. And intracranial hemorrhage was 0.38%. So they concluded that overall rate of achieving CST was 96%, and the finding of this study further reinforced the safety and efficacy of indigenous tenacioplase in Indian patients presenting with STEMI. And in conclusion, I can say that timely primary PCI is not always feasible in routine Indian clinical settings. Pre-hospital thrombolysis is an important strategy to minimize time to pre-hospital, and early thrombolysis in India would be a suitable option. Tenacioplase is the most fibrin-specific single bolus thrombolytic and best pre-hospital and early thrombolysis in a single bolus injection. Pharmacoinfusion approach using pre-hospital or in-hospital thrombolysis followed by PCI within 3 to 24 hours is effective and more feasible than primary PCI, except in cardiogenic shock. Cardiogenic shock, obviously, the primary PCI is definitely much better. Pharmacoinfusion therapy can help cater to larger patient population in India and have immediate access to primary, those who do not have immediate access to primary PCI. thrombolysis is more practical and feasible during this COVID-19 pandemic, and that's because of the logistics of and the early stage of this COVID-19 also, their patients are in very hypothrombotic state, so probably doing the primary PCI in these patients may have more complications. Thank you for your attention.
Thank you, Dr. Rath. That is indeed a very wonderful, crisp talk. Dr. Imran, would you like to introduce Dr. Panja?
Hello.
You are audible.
Yeah. It's an extremely important topic we are discussing upon, and now we move to the part of when thrombolysis to when thrombolysis has failed, was what to do. And Dr. Manohar Panja needs no introduction. He has been my teacher too. So I would request Dr. Panja to kindly start his lecture. Over to you, Dr. Panja.
Thank you, Chairperson, and present ladies and gentlemen. My subject of talk, field lies in STEMI, particularly management and diagnosis as a whole. Therefore, the next slide. Next. Now, first, influence of coronary thrombosis outcome after PCI, which is data from Mayo Clinic. You see, if the MACE is high in presence of thrombosis, lower procedure success, and low flow, slow flow phenomena because of embolism, high mortality rate because of thrombus, high persistent STCM elevation, and longer hospital stay. That is the statistic. For the incidence of failed thrombosis, and Dr. Roth has already spoken the success. I talking the failed thrombolysis, you see, patency rate is the 15 to 40% minimum, and failed to achieve the normal myocardial perfusion, 60 to 75% cases. Now, what is the mechanism? Very burning question in our mind. First thing is the genetic differences. Second is the circulating factor like fibrinogen, lipoprotein, thrombin, antithrombin ratio, and mechanical factor, the atrial pressure proximal to the coronary occlusion, and increased myocardial wall stress, and huge thrombus burden, lesion complexity, residual stenosis after initial perfusion, and subintimal hemorrhage. These are the factors responsible for failed thrombosis. Now, what is significance of the failed thrombosis? Failed thrombosis means associated early death and the gross LV dysfunction. Gastro trial also to prove, apart from the meta-analysis, shows the TIMI3 flow at 4 to 6 weeks, the 3.7, a TIMI2 flow, and the mortality is 7%, but 0 to 1 TB flow, mortality 8.8%. Now, diagnosis of failed thrombolysis, first thing, non-resolution of the chest pain. But excluding if the morphine, some cases, patient getting chest pain may not be there. But some cases, again, there is the pericarditis may be responsible chest pain. Overall, if there is non-resolution of the chest pain, definitely you have to think there are particularly the failed thrombosis. Second, ECG also, there is the non-resolution ST segment to fall by minimum 40% or more within 90 minutes. And on the ECG, there is reperfusion arrhythmia absent, that is also indicating particularly of the failure of the thrombolysis. And cardiac markers, troponin, and the CPKMB, myoglobin ratio was post and pre-thrombolytic, everything it is increased in case successful angioplasty, but failure of increase, sharp increase, all this biomarker then indicating that is the failed thrombolysis. Now, diagnosis other ways, myocardial perfusion, the ideal method of diagnosis due to thrombolytic therapy, due to myocardial contrast echocardiography is the emerging diagnostic strategy which assess the microvascular perfusion by myocardial contrast echo, very, very promising. And finally, the gold standard, angiography is the gold standard, we can assess the TIMI3 flow, whether grade 2, grade 1, or it is the TIMI3 flow is very important assessment of the failed thrombolysis. Now, regarding the management, repeat thrombolysis and additional antiplatelet, white as well as the Manse, this shows definitely after another thrombolysis, but by the new agent, then enough benefit for opening of the infarct-related thrombus and resulting improved. If we do the new antiplatelet, particularly TNK nowadays, improve the LV dysfunction and reduce the mortality. And TIMI 14 trial also showed combination abiximab with the ATPase is very efficacious and best TIMI-3 flow achieved by the combination study, and it is 72% TIMI-3 flow. That is why upgradation of the abiximab upgradation is coming up for the management of failed thrombosis. Now, role of percutaneous intervention, PCI. The GASTRO-1 study shows improvement lymphatical function by 30 days, and mortality also improved if you do the PCI after the failed thrombosis. TIMI-5 study shows that is not a beneficial at all. Rescue trial, you see, this is very important. This suggested improvement LV function and composite endpoint, reinfarction, death, stroke. Is also drastically reduced if you do the rescue trial. Carl, my friend, also pointed out possibly there should be either combination and PCI along with the GP2B3 inhibitor, very useful to reduce the mortality and improve the LV function. Finally, the CREATE study, this is a very important study. Here, the CREATE study, the rescue angioplasty versus conservative or repeat thrombolysis. They taken the 427 patient, and when patient treated thrombolytic, and after 90 hours, if there is no resolution of the no resolution less than 50% ST segment, then you can define the failed thrombolysis. If you treated by the repeat angioplasty, either TNK, retiplase, LTplase, that is also very important. Rescue angioplasty routinely you have to do the angio and select a cassette, revasculation, and conservative treatment. We treated by the heparin for 24 hours. Primary endpoint, composite death, reinfarction, stroke, and severe heart failure is observed within 6-month follow-up period. Let us see. But in cases the rescue angioplasty REACT study shows the survival of the death, MI, stroke, heart failure, everything survival rate of the rescue angioplasty 84%, comparatively the conservative repeat angioplasty hardly the 70%, and the repeat angioplasty had the 68.7%. Therefore, PC rescue angioplasty is beneficial for the survival rate more than 8.6%. Now let us start the TIMI-5 study, and there's some for the mortality, particularly the conservative criteria red color is 45%, rescue angioplasty 33%, if you consider stroke, MI, heart failure. And rescue study, in case of conservative treatment, only 16% reduced, and rescue shows a 6.4% reduction of the heart failure and death. This is important. But Mir also compared the three, the conservative, rescue as the primary. So there is, if you do the PCI, the rescue angioplasty, there is not too much significant versus primary angioplasty versus rescue angioplasty. Now, during the procedure, if the huge thrombus, definitely you have to absorb the clot, and it is particularly presence of LAD, huge thrombus. And coronary bypass surgery may be needed if the failed thrombolysis, if it associated limb stem disease with multiple vessel disease, but not complete revascular not done by the angioplasty. That cases you have to do the culprit vessel dilatation whenever is possible. That delays, stabilize the patient, delays the surgery later on, reduce the risk. That is beneficial that CBG to become later on. So new direction, new thrombolytic therapy. And second thing is very useful, low dose combination of the neothrombolytic with the GP2B, very useful. And intra-aortic balloon pump is very efficacious to enhance the treatment of the failed thrombosis. Early thrombolysis and angioplasty for all selected cases, rescue angioplasty done, reduce the mortality and as well as improve the ejection fraction. So this is one of my patient, thrombolytic failure, total occlusion of the right coronary artery and guidewire cross. And then you see, we are successfully managed by the angioplasty, and after export catheter given, after that finally you are given the stent, very successful angioplasty is done, even in the failed thrombus. Finally, last slide. Yes, next. Last slide. In conclusion, ladies and gentlemen, failed thrombolysis, first thing, the diagnosis, if the non-resolution chest pain, ECG also non-resolution ST segment, and enzyme kinetics, there is no surprise of property and CPKMB and myoglobin ratio, or myoglobin particular post and pre-thrombosis ratio also reduced. So these are the diagnostic criteria. Apart from contrast echocardiography is very, very useful to detection, assessment of the microvascular circulation. Of course, coronary angiography, which assess the TIMI3 flow, particularly by angiography, is gold standard. Regarding therapeutic option of failed thrombolysis, repeat thrombolysis by the newer agent, particularly TNK nowadays, very useful, and glycoprotein 2B3 inhibitor with the help of epistemab, FT5 tyrosine also very, very important. That is why in the thrombolytic era and in the case of the STEMI, the upgradation of the GP2B3 will be coming up. An intra-aortic balloon counterpulsation is very, very useful to management of thrombolytic failed thrombolysis, and rescue angioplasty, very, very useful. I already demonstrated. Anyhow, combination GP2B3 inhibitor along with the PCR, very, very important issue to improve the mortality and improve the LV function as a whole. Thank you very much indeed.
Thank you, sir, for ending it well before time and very nicely summarized. I would now request Dr. Arvind Kumar to introduce our next speaker. Dr. Kumar, are you there?
Yes.
I think the speakers are over. Am I right? It's a discussion.
So we can have it's a discussion for the thing.
Yeah.
So I would last Dr. Panja has spoken on a very important topic. Sir, would you like to say something on if suppose we are doing a rescue angioplasty and it's so important in this case, whether we have any preference for the whether radial route or femoral route? What message would you like to send here?
Of course, I used to do the radial route. There is no thing. Of course, depends on those femoral person, they can do the femoral. There's no problem at all. But anyhow, in that situation, I prefer to do the radial approach. Real world study now, radial approach, even if primary PCI is accepted.
I think there's a very valid point Dr. Panja has brought out. Though there is no significant difference as far as radial versus femoral as per the latest studies, but in a case where failed thrombolysis, it may be more safer to go for the radial route than a femoral route. I think there's a very valid point, sir.
Yeah.
I have a question to Dr. Chopra. Dr. Chopra, you spoke very nicely on ARNI and its role in post-MI. Now, how early in post-MI failure you will not hesitate to start? A patient who's lysed in a non-PCI setting and who has clinically successful lysis, but however, because of delayed presentation, he has LV dysfunction and is in heart failure. Now he is in day 2. Would you like to start him on ARNI or would you like to wait? Dr. Chopra, are you there? Oh, Dr. Chopra?
I think to unmute.
Okay. Now, maybe I'll ask a question to other panelists can please take over. If are there any questions from the audience? Now, Dr. Chopra,
the criteria which were given for, is Dr. Chopra there? No. See, in the trials, the criteria for starting ARNI has been given very clearly. If the systolic blood pressure is more than 100, patient is not on any increasing doses of diuretics. All the inotropes are coming to almost close, and that is the time one has to introduce the ARNI. If we do before that, we might harm the patient by precipitating hypotension or renal dysfunction.
Dr. Singh, I mean, just have to participate in the thing. So mention current data, you mentioned that is as soon as the patient is stabilized for heart failure, you can switch back to the ARNI just prior to the hospital discharge.
Yes, sir, that's what I meant, sir.
Yeah.
So a person who's, say, failed thrombolysis or patient is in heart failure, as long as he is on IV diuretics and inotropes, we should avoid ARNI. But once he is stabilized, he is being shifted to the ward. All these things are out. That is the time to start ARNI, or at least before discharge, we must start.
Correct.
So I have a question for Dr. Rath, probably. He talked very nicely on choosing the best thrombolytic therapy. Now, we are in a country where, patients hardly, sometimes, particularly in the peripheries, are not even able to pay a couple of thousands for ICU care, and where all the governmental free care is not always available. So what is the role of streptokinase in our STEMI care systems?
Yeah, it's 80-90% in India acute MI streptokinase is used. With the patency rate, success rate is less, around 50%. And complications, severe, bleeding complications are more. You have to accept the fact that the benefit, at least there is some benefit without doing anything. So if you really give streptokinase in right time, where the patient cannot afford, then there's definitely benefit. 50% at least patency rate is achieved. And that's being all these ambulances and telehealth services everywhere. This is being used.
Sir, isn't it not very rather unpleasant drug to use in pre-hospital thrombolysis? Because you have to give it over 1 hour. There are significant chances of hypotension. There can be allergic reactions. So I think in pre-hospital thrombolysis, streptokinase should come much lower down. We should prefer tenecteplase because of the safety and ease of giving.
That is acceptable, but the practical logistic is different. Many places is not available, and you have only the streptokinase available. Cost is a major issue.
Dr. Roth, to support you,
I request you to just have a look at these charts. If you look at the mortality of streptokinase versus comparators in all the major studies, except for Gusto, in everywhere else, it was statistically equivalent. If you look at the hemorrhagic strokes in the fibrinolytic trials, in fact, streptokinase fared better than comparator. So my poser is, if streptokinase fares reasonably well, if a healthcare system can afford only streptokinase, we are not talking about pre-hospital thrombolysis. We are talking about thrombolysis in health centers which has an acute ICU. I have a feeling that we should equip our centers and train them to use streptokinase. There is a lot of hesitation, as you rightly pointed out. But those of us who are diagnostics in cardiology are very familiar with streptokinase. But the newer generation cardiologists and physicians are not used to streptokinase. They may hesitate. So I think it may be an important drug not to be thrown away.
Yeah, Dr. Paul, you are perfectly correct. Though the tenecteplase or alteplase improving the patency rate, early patency rate and early mortality, but eventually 8 to 12 hours, the patency rate, streptokinase versus tenecteplase are everything the same. New study is there, equal. You rightly point out.
And in fact, in STEMI study, what we did, in fact, it was a pharmacoinvasive study where we used streptokinase in our institutions. So when you are using streptokinase in a pharmacoinvasive scenario, the role of late occlusions or immediate late occlusions are taken care of in such a system.
I think it was extensively used in Tamil Nadu and Kerala.
Yes, sir. It was study. I was the PI of TN study of the public center. We used streptokinase in all our pharmacoinvasive patients. In fact, the entire TN study was using streptokinase predominantly.
Dr. Kastin, what I like to make a point that as regards the use of the thrombolytic therapy in country like India, where the tenecteplase or the other drugs than the streptokinase were very costly. So, and these are not very available freely in the periphery like subdivision or in the district level. And majority of the patients are receiving streptokinase. So the thing is, to be practical, unless it is urban area, majority of the patients are receiving streptokinase, and although the recanalization rate is less, but still the patient gets some benefit even if there is a 50% recanalization, the myocardium gets some amount of blood, so myocardial salvage will be established to some extent. So you also think about that.
That's a very, very valid point. What I was more concerned was, when a patient often reaches a private hospitals in periphery, they are often offered a pharmacoinvasive package or connected place, which they are not able to afford, but they are not offered cryptokinase as one of the options available to them. So many patients come to us with a late reperfusion because they are not able to afford the treatment offered to them.
Yes, but you don't know the myocardial perfusion rate.
Dr. Panja.
Yes, please.
Time to sum up, I think.
I think so. We are running late, so we would request to.
On behalf of everyone, I thank all the participants for excellent talks and all the delegates who have attended the session. Thank you very much, everybody. Back to Dr. Nitish, sir. I request the organizers to introduce the next session, please.
Thank you, chairpersons and speakers. Next, we move on to the next session, challenging situations in STEMI. I'd like to welcome the chairpersons for this session, Dr. Charan Lanjevar, Dr. Hemlata Tiwari, Dr. Raghav Bansal, Dr. Dayasagar, and Dr. Dayasagar Rao, and Dr. Yashpal Sharma. I would like to request Dr. Dayasagar Rao to kindly present the session.
Okay, good afternoon to everybody. This is Dr. Dayasagar. This next session is going to discuss about the various complications of acute myocardial infarction, ranging from rhythm disturbances like atrial fibrillation and conduction disturbances like bundle branch blocks and complete heart block, and embolic episodes like occurrence of a stroke or a systemic embolism, or the presence of a clot in the LV apex with all its complications. I think just to discuss more about it, can we have the first speaker, Dr. Balbir Singh?
Hello.
Is he available? Dr. Balbir? Is Dr. Balbir Singh available for a talk?
Can we have the second talk by Dr. Narasimhan first, and Dr. Balbir Singh will be joining in later.
Okay, can I request Dr. C. Narasimhan to talk about the conduction disturbances in acute MI and their management? Dr. Narasimhan is a senior cardiologist at AIG Hospital in Hyderabad, and he's going to tell us more about the conduction disturbances, frequency and management of heart blocks in STEMI. Dr. Narasimhan.
Thank you very much, sir. And I would like to thank the CSI for the kind invitation. The structure of the talk would be, when you decide about pacing for bundle branch block, it's important to understand the location of myocardial infarction, and also to determine whether the block is infrahisian or suprahisian. This is important because if it's a suprahisian AV block, symptoms are very important. Hemodynamic stability and whether it's symptomatic or not. Whereas it's if an infrahisian AV block, despite the patient being relatively asymptomatic, you would consider inserting a temporary pacing during a course of a STEMI. And what are the steps of initial management and long-term management in the course of a STEMI? This is important, a cartoon to understand the blood supply of the conduction system. The AV node is predominantly supplied by either the right coronary artery or the circumflex. On the other hand, the left anterior descending artery supplies the infrahisian portion of the bundle branch block. Why is this relevant? Because if you have occlusion of right coronary artery, AV node is involved, and the conduction disturbances are very often suprahysian. On the other hand, the bundle branch blocks and the AV blocks that happen in the setting of an anterior wall infarction are related to LAD occlusion, and they are infrahysian AV blocks. What are the clues? The clues are when you have a prolonged PR interval or Wenckebach cycle length happening, periodicity, they suggest suprahysian AV block, and they are often associated with a narrow QRS, and they are relatively well tolerated. Unless symptomatic, we need not consider inserting a temporary pacing. On the other hand, if you have a wide QRS and the PR interval remains normal and patients develop 2-to-1 AV block, they are the ones who are likely to develop sudden AV block, like in this bottom panel. You have a left bundle morphology with a relatively normal PR, 2-to-1 AV conduction. Even if this patient is relatively asymptomatic, it's prudent to insert a temporary pacemaker. So first, let us look at inferior wall myocardial infarction. You may have first degree AV block. Second degree AV block is predominantly Wenckebach periodicity is seen, and high-grade AV blocks, 2-to-1 or more than that, are often associated with a narrow QRS. Something similar to this, and you may have 2-to-1 or a complete AV block. Generally, the escape is narrow QRS escape, and most often they resolve completely with revascularization. And approximately 11% of these AV blocks may persist, needing a pacemaker, but more in those associated with concomitant disease of conduction system disease or multivessel coronary artery disease. What about conduction disturbance in anterior wall myocardial infarction? And these patients, they can present with first degree AV block, but it's very uncommon. It occurs when the patient has previous conduction system disease or when he has progressive conduction system disease in elderly person. And high grade AV block or greater, like CHB or malignant, run a malignant course, and they indicate a very proximal disease of the septum, and they have a poor prognosis because of a large myocardial infarction that is associated. Occurs in about 3% of patients with anterior MI, and they can be very abrupt, especially in patients who are non-revascularized. And the escape rhythms are often very wide in QRS, and they tend to be unstable, leading on to VT and VF. And more often, they indicate a large area of myocardial infarction. So how do we manage these patients? If you have relatively asymptomatic and benign arrhythmias like sinus bradycardia, first degree AV block, and Wenckebach blocks, they don't need any treatment. If you have persons who are symptomatic due to this, you may try an atropine to see whether the hemodynamics stabilize. If there is no response, you may have a temporary pacemaker inserted. So whenever you have a person with a complete AV block in the setting of an acute myocardial infarction, try to localize the myocardial infarction, or very often you have the information already from ECG, echo, or angiogram. And this is important because if it is in the setting of an anterior wall infarction, then any degree of AV block, you tend to have a very low threshold for inserting a temporary pacing. Whereas if there is an inferior wall myocardial infarction, you look at the patient and see whether it's hemodynamically stable or unstable. If a patient's blood pressure is well maintained and he is revascularized appropriately, very often these blocks spontaneously resolve and you need not consider a pacemaker, and just a careful, watchful waiting is good enough. But if a person is unstable, hypotensive, frequent arrhythmias, short non-sustained VTs happening, then it's prudent to insert a temporary pacing. What is the level of AV block? If it's most often, if it's nodal, you need to consider patient's symptom. If it's infranodal, very often they almost always need a temporary pacing. If it's nodal, you can try atropine or some theophylline in some situations. If they resolve, well and good. If they don't, and if the patient is unstable, continues to be unstable, you should insert a temporary cardiac pacing. Most important step is to revascularize these patients, because revascularization itself may help to resolve the conduction system disease. And the AV block generally resolves after PCI in most of these patients. Very rarely, if the PCI is delayed and there is an extensive necrosis of the conduction system, then you may consider inserting a pacemaker prior to discharge. This is the AHA-ACC recommendation for temporary pacing. If it's asystole, symptomatic bradycardia, which includes hypotension in the setting of second-degree AV block, unresponsive to atropine, alternating or bilateral bundle branch block, or if you have a left anterior fascicular block or posterior fascicular block in the presence of an RBB of a new onset, new or intermediate age bifascicular block, or second degree AV block, these are all class 1 indications for temporary pacing. Class 2A indication is indeterminate in origin, RBBB with either an anterior or posterior fascicular block, RBBB with first degree AV block, left bundle branch block, which is new or indeterminate, incessant VT for atrial or ventricular overdrive pacing, recurrent sinus pauses unresponsive to atropine, and these are all indications. Class 2B bifascicular block of indeterminate etiology, new or age intermittent isolated RBB. Generally, this we don't consider inserting a pacemaker unless the patient is hemodynamically stable and has exhibited a transient AV block. So indications for temporary transvenous pacing is essentially complete heart block, alternating right and left, or right bundle alternating with left LAFB or posterior fascicular block, new onset bifascicular block with PR prolongation, symptomatic bradycardia, unresponsive to atropine. And we have a very low threshold if the patient has any form of ventricular tachycardia. The classic paradigm is torsades with prolonged QT, but it can be just even a monomorphic VT because it necessitates the use of an antiarrhythmic therapy, which is going to further slow down the conduction. And so it's prudent to just insert a temporary pacing, simultaneously start on antiarrhythmic therapy. Important issues in treatment: please avoid in these kind of patients, avoid using beta agonists in acute myocardial infarction and AV block like dopamine, dobutamine, epinephrine, because they tend to worsen the ischemia and worsen the block. Anterior wall infarction infraescient block is unresponsive to atropine. Paradoxically, there can be a worsening of AV block. So please do not use atropine in this setting. Atropine by vagal withdrawal can precipitate VT and VF and also worsen the AV block. Narrow QRS escape in inferior wall myocardial infarction. If the hypotension continues despite correction of the AV block, you need to rule out concomitant volume depletion and RV infarction, which may be responsible for the problem. What about long-term management? Now, in the setting of an anterior wall infarction, if a patient has high degree AV block or the same alternating bilateral bundle branch block, you should consider inserting a pacemaker. A regular pacemaker may be detrimental because RV pacing may be detrimental. If there is no cost constraint, it's better to insert a CRT before discharge. Inferior wall infarction, on pacemaker, patients have a persistent AV block for a long duration. You may have to insert a pacemaker, but it's unusual. When it persists beyond 1 week, just to discharge the patient, you may put a pacemaker and discharge the patient. So heart blocks can occur both in the setting of inferior and anterior wall myocardial infarction. Location of MI, type of AV block, and the escape rhythm hemodynamic stability are important factors which you should consider before considering a strategy to inserting a pacemaker. Reperfusion is the key to prevent and manage heart blocks, and this needs to be concomitantly addressed. Minority of patients will need long-term pacemaker in the setting of an acute MI. I think I will stop with this, and thank you very much for the kind invitation.
Thank you, Dr. Narasimhan. We will go on to the next talk where a patient who is on DAPT needs surgery, and how do we manage these patients? Can I request Dr. Mukherjee to present his
Dr. Balbir Singh has joined the session, so if we can have his talk
sure.
As the next talk.
Fine. I think you can request Dr. Balbir to present his data. Atrial fibrillation in acute MI.
Thank you, Dr. Rao. And my talk is on balancing the risk between ischemia and bleeding in a patient who has STEMI and atrial fibrillation. Now, this combination will happen to all of us, happens because both common disorders. STEMI has to be balanced because in STEMI you don't want ischemia. In atrial fibrillation, you're going to give anticoagulants and there will be bleeding. First thing is that there is the impact of, so AF is associated with a poor outcome at 1 year in form of major events such as death, reinfarction, and heart failure. Myocardial infarction in patients who have an underlying atrial fibrillation. So that is the other part. So maybe on anticoagulant, still they have more non-STEMIs and STEMIs. So AF can bring down blood pressure, can worsen ischemia, can be destabilizing, and is there, but surprisingly well tolerated in many patients. So we know from the guidelines that ticagrelor has become a standard of care in many patients who have STEMI. And what do we do when the patient has atrial fibrillation and STEMI and needs anticoagulation? Data on ticagrelor is good. Now let's look at the presence of risk factors for a stroke and anticoagulation or no anticoagulation in these patients. So if we have a low risk patient with 0 Schwartz in male and 1 in female, or 1 in male and 2 in females, and you see the difference is huge. This green and red suggests that just one risk factor added in the Schwartz score increases the risk of stroke. So these patients need anticoagulation. Schwartz 0, 1 and compare it against no AF, you clearly see that without AF has a better prognosis than with AF. So I already showed you that. Now, if the patient undergoes an angiography, it could be 0 vessel disease, 2 vessel disease, 1 vessel disease. If it is 0 vessel disease versus 1 or 2 or 3, you can see the risk of stroke or thromboembolism is almost similar, whether it's whatever the degree of cardiovascular disease is there. Even 1 vessel disease carries a high risk of stroke, TIA, or thromboembolism because CAD is the independent risk factor for stroke. So it becomes clear that anticoagulation is going to be the mainstay in these patients. So if we balance the risk of thrombosis to bleeding, we realize that patient has non-valvular atrial fibrillation, there's increased stroke risk. Patient has ACS, so there's increased myocardial ischemia. He undergoes a PCI, there's increased risk of thrombosis. With PCI, we need antiplatelet agents. And with AF, we need antithrombotic agents, which both could cause bleeding. So oral anticoagulation therapy in patients with myocardial infarction, a meta-analysis published by Salim Yusuf clearly showed that if you anticoagulate and give aspirin, there is higher bleeding. But if we look at moderate to high intensity oral anticoagulant and aspirin versus aspirin alone, you see the kind of mortality curves hugely different. So combination of oral anticoagulant and aspirin did far better in these patients than aspirin alone in preventing a stroke or mortality. So anticoagulation and antiplatelet is going to become the mainstay of treatment of these patients. What happens is that in the RELY trial, if we add aspirin and clopidogrel or aspirin or clopidogrel with dabigatran 110 or 150, you see no antiplatelet has less bleeding, but once you add an antiplatelet, the bleeding becomes high, particularly 150 group. And same happens with warfarin. If you add one agent or two agents of antiplatelet agent, you get bursts. So no antiplatelet with anticoagulation has the least bleeding. So we kind of now understand that both antiplatelet and anticoagulant are going to be essential in these patients, but we have to balance the risk. A perspective provided by the North American registry suggested if a patient undergoing PCI for STEMI, radial access, use the lowest effective dose of aspirin, minimize DAPT duration, go on SAPT as soon as possible. Preferential use of clopidogrel over prasugrel or ticagrelor. In patients treated with VK, target INR to the lower therapeutic range, maybe around 2. In patients treated with NOAC, use the lower effective dose of that NOAC. Routine addition of PPIs and avoid the use of NSAIDs. These are guidelines from North American update on 2016, which kind of summarizes of what literature is showing. What about warfarin and ticagrelor as a triple alternative in acute coronary syndrome? So it's going to be dangerous in terms of bleeding, and but the stent thrombosis can be reduced significantly. Let's look at some of the trials. The REDUAL PCI looked at dabigatran 150 milligrams twice a day plus a P2Y12 inhibitor, mainly clopidogrel, or 110 dose, or warfarin with aspirin and P2Y. Now this was an imbalance because you don't see aspirin here and you see aspirin added on to warfarin group. So it came out clear that dual dabigatran 110 milligram twice a day compared to warfarin, you see a probability of an event quite remarkably reduced with this group of medicine. So it came to a conclusion that 110 or 150 milligram of dabigatran was far superior to a triple warfarin therapy. And the results of the secondary endpoint also suggested that there was no extra ischemic risk by giving just dabigatran with one antiplatelet agent compared to 3 drugs such as warfarin, clopidogrel, and aspirin. So there was no extra addition of an ischemic event, but there was a marked reduction in the hemorrhagic complications. As a result, we understand dabigatran dual therapy compared with warfarin therapy. These are the favoring dabigatran, acute coronary syndrome, elective PCI. So ticagrelor is still not what we really understand as to what should be done with ticagrelor, because the data in these trials using ticagrelor does show that there may be some extra benefit in ischemia, but the problem is there is more bleeding risk. So the number of patients included in this trial on ticagrelor have been small. So to give a conclusion whether you can use ticagrelor is very difficult. But suppose a patient undergoes a left main stenting with STEMI, it wouldn't be a bad idea to give ticagrelor aspirin for a short duration with a NOAC for a short time and then withdraw it. So this was a beautiful trial, Augustus trial, which looked at patients with atrial fibrillation having an ACS, and they were given P2Y12 inhibitor for 6 months. And randomized between apixaban 5 milligrams twice a day or VKA to keep INR between 2 and 3. One group received aspirin, received placebo. All the groups had clopidogrel on, same as VKA. So they were balanced groups. And the primary outcome was a major bleed. Secondary outcome was a death, hospitalization, or an ischemic event. So let's look at what are the ischemic outcomes of VKA versus apixaban. There was no difference, you can clearly see. But the stroke risk was reduced with using apixaban compared to warfarin. This was mainly driven by the hemorrhagic strokes which were reduced. Hospitalization reduced again by apixaban. What about the ischemic events? So if you look at the ischemic events, this is a little bit of a worry that if you add aspirin, the stent thrombosis rate is lower than if you don't have aspirin on board in these patients. So it is not a bad idea to give aspirin for 1 month when you have the maximum risk of stent thrombosis, and then avoid aspirin and go on to single antiplatelet agent. So you give aspirin, clopidogrel, and apixaban for 1 month, reduce it to aspirin, drop aspirin at 1 month, continue clopidogrel and a NOAC after that. So you can clearly see the death and ischemic events were reduced in this group, not statistically significant, but numerically significant. But the stent thrombosis just bordering to significant. So one has to keep that in mind. If we put the meta-analysis of all the 3 trials, the Pioneer, AF, PCI, and Redual PCI and Augustus trial, you look at major bleeding favors DAPT. That means aspirin dropped. Stroke risk is the same. Myocardial infarction slightly higher, slightly favors use of aspirin also. But stent thrombosis is in the red, telling us that we have to think of giving aspirin for at least 1 month when the risk of stent thrombosis is high, and then you could withdraw that. What about NOAC versus VK? You can see the major bleeds are less, the intracranial hemorrhages are less, the rest all are same. So telling us that probably a NOAC is a better idea in these patients, using triple antiplatelet aspirin, clopidogrel during the acute phase, and dropping aspirin as soon as we can do. So omitting aspirin clearly is the message that as soon as possible you could get rid of aspirin and continue with clopidogrel and NOAC, preferably apixaban, because the trial was done very elegantly looking at those 2 groups. What about other agents, clopidogrel and ticagrelor and prasugrel? You can see the number of patients. In clopidogrel, 4,000 patients. Ticagrelor, 277 patients. 51 patients in prasugrel. Very difficult to draw conclusions as to can we replace clopidogrel with ticagrelor in some patients. I think it's very difficult to say with the kind of number of patients that we have. But the data suggests that there is not much difference in the bleeding with these agents, but it needs to be tested in a bigger trial. Only then we'll be able to say what happens in these patients. What about temporarily omitting anticoagulants early after stenting with acute coronary syndrome patients today? So what happens is that the risk of cardioembolic stroke will go up once we drop these oral anticoagulants, try to favor with the modern DAPT instead of TAT. So for example, if you think that I can handle this situation with ecosprin and prasugrel because the patient had a STEMI and I want to think it's a complex PCI, I want to give the most aggressive DAPT and omit the anticoagulant, what you end up is having higher strokes, which is not desirable. So anticoagulation is a must in these patients if the SHATS class.
So we are running out of time. Can we please?
I'll just show the last slide, then stop it. So in conclusion, I would say that one needs to understand that the guidelines are very clear. Guidelines suggest that ACS with atrial fibrillation needs anticoagulation with aspirin, with clopidogrel, and drop aspirin at 1 month in these patients, and then continue for 1 year aspirin and anticoagulant, and after 1 year, just anticoagulation is all that is required. Thank you very much for your attention.
Is Dr. Mukherjee ready with his talk?
Yeah, just a minute. Is my slide visible?
Not really.
Okay. Is it okay now?
No.
They're not. I think we'll have to share the screen. Somebody has to Somebody has to unshare the screen, the previous speaker.
Yeah, I think so.
Yeah, and then only you can share the screen. Whosoever is handling the data in the background, I think they should do that.
It come now? Because I've already clicked on that option.
No, it is still low. Yeah, now it is available.
Yeah, okay. Let me go to the slide view then. Okay. Good afternoon, everybody. So what I'm going to talk about is a very common problem that we encounter post-myocardial infarction, that some of your patients might need surgery within the next year or so. Now, Dr. Balbir has already talked about oral anticoagulants in patients who have already suffered from STEMI. So what I'm going to do, I'm going to put some filters on my issue. Filter number one, the patient of STEMI had undergone a PCI with a DES. Patient is not beyond the 1 year window. It's not an emergency surgery. It's a non-cardiac surgery, and the patient is not on WAC or NOACs, so that I'll get a comfortable playground to play. Now, look at these guidelines. We had very rigid recommendations way back in 2011 from the ACC and the Australia, New Zealand guideline also. So they were very rigid. What did they say? They told that if you want to have an elective non-cardiac surgery, so if you have done a PCI with a DES, it's a big no if DEAP has to be continued. If you are planning PCI, it's not yet done, you go for a POBA or a BMS and then go for DAP for a period of 4 to 6 weeks. Now, when you go for an urgent surgery, so you may skip this and you may hold the oral antiplatelets, go for surgery and restart the antiplatelets. So that was the recommendation. But these prior recommendations were at a time when you had the first generation stents. The newer generation stents have got much lower chance of thrombosis, and they need shorter DAP duration so that you can take off DAP pretty earlier and go for surgery. Now, as you know, this is the latest trial in this field, the master DAP trial done with Ultimaster stent. That is 1 month only of DAP therapy. And you saw that the event rate were not increased in patients in whom you took off these oral antiplatelets early after 1 month. Maybe we are not going to be as heroic as the master DAP trial and take off the antiplatelets so early, nor we are going to be as rigid as the previous guidelines. We are going to take our lesson from what these guidelines teach us. ACC guideline 2016, ESC guideline 2017, the Canadian guideline 2019, the Thrombosis Canada, and the latest, the Japan's guideline, the Japanese Cardiovascular Society in 2020, and let's listen to what they have to say. Now, there are 3 important points to consider when you want surgery in a patient of DAP post-PCI. 1, what surgery does. 2, what DAP continuation does. And 3, what DAP discontinuation does. Answers to issue number 3 is very easy. Take off DAP, there will be chance of thrombosis. Answer to question number 2, what DAP continuation does, more bleeding. Answer to question number 1 is very tricky. So forget about the oral antiplatelets, the risk of thrombosis and the risk of bleeding. Surgery per se is a pro-inflammatory and pro-thrombotic state. So that surgery per se will increase the chance of inflammation and thrombosis in both the stented segment as well as the entire coronary vasculature. And this is for this reason that even if you don't put in a stent, even if you go for POBA, you have to have a waiting period for about 1 month, during which you don't want to have surgery. Now, this is the latest guideline. I like this particular figure from the Japanese Cardiovascular Society. And you see that at the top, there is a red band. That is in the first 1 month. We don't go for surgery. So the rigid recommendations about 1 year has been brought down to 6 months in the latest guideline. So the two questions, red? Why you don't go for surgery so early? And why do you take the liberty of doing surgery a little bit earlier against the previous recommendation? To answer these two why, let us see at what time after PCI you are free to do surgery. So which trial has given you the info? Without a comparator arm, you go for finding out from the registry at what point of time the risk of surgery post-MI flattens out. And if you have a comparator arm, as you see, this is the only Kaplan-Meier curve that I'm going to show you. This is from the Danish registry. In the population of Denmark, you see there are 3 groups of curves. The violet one at the top, that is surgery done 1 month post-PCI, versus the matched controls who did not have PCI. In the center, the red lines, patients who had the surgery post-PCI after 2 months, rather 1 to 2 months, versus matched controls of the population of Denmark. And at the bottom, the 2 pairs of the blue hatched and the blue solid lines, that is those who had surgery 2 months after PCI, matched with the matched controls. So there the surgery was done after 2 months. What is the result? In the top 2 curves, they're widely separating. That is, if you do the surgery within 1 month of PCI, so there are hell and heaven difference between the comparator arms. In the lower 2, if you do the surgery after 2 months, you see that the blue lines are hugging each other. The red lines, that is 1 to 2 months, are intermediate. So what does this curve teach us? Number 1, don't ever go for surgery unless you are compelled to do so 1 month after PCI. Number 2, don't be so scared as in the previous guideline and wait for 1 year after PCI or condemn the patient to receive a POBA or a BMS if you want to have an earlier surgery, earlier than 12 months. Now, this is how to handle the antiplatelets in the perioperative period. Just remember 357, that is the minimum period of discontinuation to surgery. It is 3 for Tika, 5 for clopidogrel, and 7 for plasogrel. To be exact, it will be 3 to 5, 5 to 7, like that. So that is the period of the P2Y12 interruption prior to surgery, and you can re-add after surgery. Now, surgeries are of various types. Not all surgeries carry the same bleeding risk. Not all surgeries carry the same thrombotic risk. So it all depends upon the permutation and combination of the bleeding risk vis-a-vis the thrombotic risk. And at one extreme, you can have patients with very low surgical risk and very high thrombotic risk. In those cases, you can continue both aspirin and P2Y12 inhibitor during surgery. On the other side of the spectrum, it's a very risky surgery involving a lot of bleeding risk and a low thrombotic risk. In that case, you discontinue both aspirin and the P2Y12 inhibitor perioperatively. And other surgeries, you lie intermediate, so you take your own decision. Now, 2 very important issues. Are we going to judge the window for surgery by platelet reactivities testing? Or are you going to be rigidly following the 357 waiting period? Second issue is, do you want to have a bridge after TAP discontinuation in the perioperative period? Now, this is a very important top article in a Korean journal in which they mention that overall, the preoperative platelet function tests seem to be having a higher negative predictive value than positive predictive value, meaning that the patients found to have a normal platelet function do not exhibit increased bleeding risk went on DAPT. As you all know, that platelet function test to assess the adequacy of antiplatelet activity has drawn a blank. But the other way around, when you are going to assess whether the patient is fit for surgery based on the normalization of platelet function, maybe this article carries some sense, though it might not have been reduplicated in many studies. But this is a food for thought. Now, the perioperative antiplatelet bridging. In the latest Japanese Cardiovascular Society 2020 guideline, as well as in the European Society guideline 2017, they talked about a bridge during, it's not mandatory, but you may consider a bridge during the perioperatively. In the Japanese guideline, they considered GP2B3A inhibitor bridge, but their preferred bridge was cangrelor in their guideline. And regarding the bridging with heparin, it's a big, big no. So this is all about the way you're going to do surgery, how you're going to handle the antiplatelet agents in the perioperative period, the timing of surgery being brought down compared to the previous guidelines. So with that, we can have a crispy take-home message. Non-cardiac surgery after STEMI in patients with PCI. Surgery itself is a pro-inflammatory and pro-thrombotic situation. Number 2, weigh the risks of bleeding and thrombosis. 3, consider the urgency of surgery. 4, try to delay the elective surgery to the max as per the latest guidelines. 5, individualize the plan for perioperative antiplatelet therapy because all patients are not the same. All stents are not the same. In fact, all stentings are not the same. You do a clot and crash in one case, and you do a full toss RCA small lesion in another case. So there the risks are different. And lastly, all surgeries are not the same. So you have to take your individual decisions after all. Thank you all for your patient listening.
Thank you, Dr. Mukherjee. I think we'll go on to the last and final talk by Dr. Shanmuga Sundaram. He's going to talk about occurrence of a stroke in a patient with acute MI. How do we manage it? What takes the precedence in the management? Dr. Shanmuga Sundaram, the senior cardiologist and at Chennai, he's going to tell us more about the management of acute stroke during STEMI. Dr. Shanmuga Sundaram.
Good evening. I think, the event manager has to, quit the screen. Yeah. The issue of managing someone with STEMI and acute stroke is a complex issue because we need to protect two important vital organs at the same time. The issue becomes more complicated because of the rarity of the situation, and the guidelines do not recommend anything very firmly. If you look at the cause of strokes, 88% is caused by ischemia resulting in infarct, large vessel occlusion, lacunar infarct, cardioembolism, and cryptogenic stroke contribute roughly equally for ischemic strokes to happen. The large vessel occlusion can be cardioembolism, thrombus in situ forming on top of an atherosclerotic plaque, or vessel-to-vessel embolism. If you look at the old data, people who are admitted with ischemic stroke, roughly 1% develop myocardial infarction within the first 3 to 5 days of the event. The occurrence is much less in people with hemorrhagic stroke, 0.3%, and simultaneous acute coronary syndrome and stroke is much, much more rare even, 0.009%. But if you look at the contemporary data, this is a retrospective analysis from the national inpatient sample from US from 2003 to 2014. 8,64,000 people with acute ischemic stroke, 1.6% manifested myocardial infarction, 80% non-STEMI and 20% STEMI. Over a period of years, the occurrence of myocardial infarction in people with acute ischemic stroke keeps increasing. But another fact which is emerging is the proportion of people with the STEMI seems to be coming down over a period of time. In-hospital mortality is threefold and hospital stay is 50% longer. If somebody develops myocardial infarction on top of acute ischemic stroke. The predictors are old age, CKD, mechanical thrombectomy for stroke, and pre-existing CAD. What is very disturbing is, in such people, angiography was performed in 7% and PCI was performed in just 2%, when the odds ratio for in-hospital mortality was much lower if you do a PCI. Look at from the other perspective. People who are admitted with acute ischemic stroke, when myocardial infarction, how many of them develop acute ischemic stroke? The same number, 1.6%, developed acute ischemic stroke when they get admitted with myocardial infarction. Again, the mortality is 2.5 times more. Angiography was performed in lesser number, and PCA was done in much smaller number. If you look at the mechanisms, it can be broadly classified into non-synchronous and metasynchronous. Non-synchronous, STEMI preceding the stroke, hypotension in the event of a large MI, AF occurring with acute MI, presence of an LV thrombus which can embolize, post-thrombolysis. Generally, we expect bleeding into the brain after thrombolysis, but one can get ischemic stroke as well because of the procoagulant milieu created by thrombolysis. And post-primary PCI, roughly 1% develop stroke, either thrombus aspiration or an aortic plaque could be responsible for embolic stroke. The second half, the stroke preceding STEMI, it could be neurogenic stenting, it could be Takotsubo cardiomyopathy. Sometimes thrombolysis done for stroke also have ended up with myocardial infarction. Metasynchronous or simultaneous, this hyperacute cardiocerebral infarction could be vascular, aortic dissection needs to be ruled out, vasculitis, vasospasm, COVID-19 and post-COVID-19 status seem to be emerging causes for metasynchronous event, affecting both the heart as well as the brain. Cardiac, atrial fibrillation or thrombus in somebody with poor LV due to dilated cardiomyopathy or ischemic cardiomyopathy could end up with multiple emboli, some into the brain and some into the heart, could result in metasynchronous event. Now, what is the issue involved in managing such people? If you need to protect the brain, if you are aiming at thrombolysis, we are sure that if it is done within the first 4.5 hours, the neurological outcome is better. But the dose recommended for stroke is relatively lesser than that for STEMI. And if thrombolysis is done for stroke, neither heparin nor antiplatelet could be given for 24 hours, according to the guidelines at least. If PCA is given priority, the potent dual antiplatelet therapy and parenteral anticoagulants might increase the chances for hemorrhagic transformation of the cerebral infarct. How to go about? You give priority to the most affected organ and act within the shortest time window possible to protect the organ, one of the two. Brain is more vulnerable than the myocardium. Time window is much shorter for protecting the brain, less than 4.5 hours. And it is also possible for one of the two events being milder than the other. You can modify the decision accordingly. And restoration of blood flow to the brain as well as to the heart can be achieved both by pharmacological lysis as well as mechanical intervention. We need to quickly evaluate a patient with stroke. You don't need to do sophisticated coagulation test. We need to do a blood glucose to rule out hypoglycemia. Need to do only a non-contrast CT, which is good enough to rule out intracerebral blood bleeding, and go ahead with IV thrombolysis if it is indicated. And we need to have an assessment of clinical severity estimation. NIH score is the best. Anything less than 5 is minor stroke, and anything more than 20 is major stroke. If someone is admitted with STEMI and CT shows hemorrhagic stroke, the medical management, you can't give antithrombotics, you can't give antiplatelets for some time. And emerging data indicate that at least single antiplatelet therapy can be started a week to month after the bleeding into the brain. Maybe you may have to be happy with administering beta blocker, ACI, and MRAs if hemodynamics permits. Now, if it is an ischemic stroke, once hemorrhage is ruled out, if it is acute ischemic stroke, the first responsibility is to rule out these 3 conditions because the management is going to be quite different. One is aortic dissection, the second one is vasculitis, and the third one is COVID-19 status. Now, it is an acute ischemic stroke due to large vessel occlusion. The stroke less than 4.5 hours and MI less than 12 hours. Look at the hemodynamics. If hemodynamic instability is there, do an emergency PCI. Maybe 12 hours later, you can do an endovascular treatment for stroke. If it is hemodynamics is quite stable, and if brain takes priority, administer intravenous thrombolysis, alteplase 0.9 milligram per kilogram body weight, with or without endovascular therapy. With the amount of thrombolysis administered per stroke, if ST resolves and the myocardial infarct pain gets relieved, you can wait with medical management and think of intervention sometime later. If there is no pain relief and if ST doesn't resolve, you need to consider early PCI. I'm sure that we will have somebody with large MI, for example, a large anterior wall MI with a small ischemic stroke, NIH score less than 5 with no disabling symptoms. We can shift our priority to the heart, do primary PCI if it is a PCI capable hospital, or give thrombolysis as per STEMI in non-PCI setting. And you can give antithrombotic treatment as well as dual antiplatelet therapy because the stroke is a smaller one. If the MI is small, the ischemic stroke is larger, administer thrombolysis at the recommended dose, mechanical thrombectomy if needed, repeat imaging maybe at the end of 12 to 24 hours to rule out hemorrhage. If there is no hemorrhagic transformation, you can start antiplatelet drugs. But there is limited data for early initiation in contrast to what the guidelines recommend. This is a study from Korea. Registry data seems to indicate that less than 24 hours of IV thrombolysis for stroke, if antiplatelets are started, it's appeared to be safe, and the clinical outcomes seem to be better with early initiation. And some of the patients had received antiplatelet as early as 12 hours after thrombolysis. If there is a large stroke, and if there is a large area of hypoattenuation as indicated by CT brain, there is large amount of brain tissue which is irreversibly injured. You need to be happy with medical management with single antiplatelet drug because thrombolysis is not going to be effective. It may cause more bleeding, and PCI with antithrombotics and dual antiplatelet therapy may be harmful. So you can give single antiplatelet therapy and go ahead with the medical management. From STEMI guidelines, there is no firm recommendation of how to manage this issue, but stroke guidelines indicate that people who have concurrent ischemic stroke and acute MI treat with IV alteplase to improve the cerebral ischemia. It can be followed by percutaneous coronary angioplasty and stenting if indicated. I'm sure at times, medical practice is more of philosophy than science. I think managing STEMI with stroke is one such situation. We are yet to have official recommendations how to manage this issue, but it is my personal view. to assess the degree of ischemia in the brain as well as in the heart, give priority the one which is worst affected, and act accordingly. Thank you very much.
Thank you, Dr. Shanmugasundaram, for your excellent presentation of a difficult topic. So, are there other chairpersons there accessible to the meeting?
Yes, I am Dr. Hemlata Tiwari. I have a question to Dr. Mukherjee. Dr. Hemlata Tiwari, I am Dr. Hemlata Tiwari. I have a question to Dr. Mukherjee.
Yeah,
please go ahead, madam. Please go ahead.
Dr. Mukherjee, I have a question. You know, if a patient has undergone PCI 8 years back, and for past 6 years, he has been on ecosprin, and now he has to undergo surgery, inguinal hernia, bilateral, and cholecystectomy. And now what should be the recommendation? We should stop ecosprin completely, or we should give some bridging therapy or some precautions?
Actually, the patient, I just didn't get your question. The patient was on PCI with stent.
PCI was done, one single artery, single vessel disease, one
single
stent
vessel disease. Okay, fine. So basically,
and he was on ecosprin for past 6 years.
Yeah.
So now he has to
basically,
undergo surgery.
Yeah, if the patient has a surgery, so I'm just coming to a question. So if the patient wants to have a surgery even within 1 year, still you can continue ecosprin. So if it is more than that, so you can jolly well carry on ecosprin. Now you can ask what are the trials that have supported it out. Now truly taking off ecosprin and putting the patient on ecosprin, there are only very few trials. One of them was the POISE 2 trial in which ecosprin was continued in patients, but the POISE 2 trial was not a dedicated trial for PCI patients, and that trial proved to be negative for aspirin. However, if you took the few patients who did undergo PCI, there are very few amongst them, and a reanalysis of data in those patients from the POISE 2 that showed that there was a positive effect of aspirin. So your question will be, unless it's a very dangerous sort of surgery like intracranial surgery or all that. For the vast majority, about 90% of the patients, they can jolly well get the surgery done on aspirin.
On aspirin. But if the anesthetist is not ready to continue ecosprin, then
that's a very tricky situation, because we find it day in and day out, because even for a tooth extraction, we write patient can continue. However, the dentist say, no, I'll discontinue. So I told him that finally the Maharaja is your dentist. Whatever he said, you have to follow. But my advice would be, you continue aspirin, because in dental extraction, whatever the bleeding might be, it can be tackled by a suture only.
That's right. And another point, is it better to give ecosprin or some bridging therapy?
Actually, for P2I12, we need a bridge, or we talk about a bridge. For ecosprin, they don't talk about the
no
bridge.
bridging is required.
Guys
It
don't
is
talk about
safer to continue with aspirin and have surgery rather than. That's right. Thank you, Doctor.
Hi, thank you for the excellent session. We'd like to move on to the next session of debate because of paucity of time.
I am Yogesh Verma. I am on the line for the next session.
For the punch and the counter punch, the debate session, I'd like to invite the chairpersons, Dr. Ajay Bhatnagar, Dr. Amar Khan, Dr. Deepak Sharma, Dr. Smith Srivastav, Dr. S.K. Prashar, and Dr. Yogesh Verma. Because of medical reasons, Dr. Ponder will not be joining us today, and Dr. Praful Kerkar would be handling both the punches and the counter punches for the first debate. I would like to invite Dr. Deepak Sharma to begin this session.
Thank you very much. Can you hear me?
Yes, sir.
Am I audible?
Yes, sir.
Yes, audible.
Yeah, Dr. Sharma here. Yeah, it's very unfortunate that Dr. Bhandari is not here, indisposed. We wish him speedy recovery. We have Professor Kalkar with us today, so he'll be punching and counter punching with right and left both, right hook and left hook. So Dr. Kalkar will decide which one he wants to punch first. Is it Tiger Killer or copydogger. I think we should start straight away because we're behind the studio. So can we start straight away, please?
Yeah, thank you so much, chairpersons. And may I share my screen now? Yeah. Okay. You cannot share screen is what this says. 1 second. I am on a gallery view and I was trying to share my screen. Can the organizers let me share the screen, please? Well, at the outset, let me thank, they've started the time also. I do not know. Okay, here we go. Share and...
Yes.
1 second, you can see me and... So, here goes. Am I audible and can you see my screen?
Yeah, it's
okay. So as requested by Dr. Nitish Naik, a very close friend who was involved with me in the writing of the guidelines for CSI during this COVID pandemic, the STEMI guidelines, as also I was closely associated with him. Let me congratulate him at the outset, closely associated with him during the conference CSI 2018 that we held in Mumbai when he was a joint secretary for it, for the chairman then. So I have been requested to not do exactly punch and counter punch, but to wear two hats, or rather I might say wear a turban first. My worthy opponent, Dr. Gurpreet Wander, is unfortunately not well, but let me wear the turban first and then I'll wear the hat. So that the topic itself is very interesting and it's not exactly a debate. It's actually two different propositions that are there. One is that I will load with clopidogrel. Let me speak about that. The topic is so relevant to our country where thrombolysis is the norm, right? If at all you have to give reperfusion. In the CREATE registry, 60% of the patients got thrombolysis. Less than 10%, by the way, get PCI. And there's a vast majority out there who don't even get any reperfusion. So very relevant topic. So let us see what do we have as evidence for my worthy opponent. The evidence for clopidogrel, 1 second, I don't know why I'm getting all this taskbar up there. I'll get it down. Okay. Yeah, so evidence for clopidogrel comes from actually two trials. One is the CLARITY trial and the COMMIT trial. The CLARITY trial was a TIMI group trial, TIMI 28, comes from the respectable Eugene Braunwald's group. Very prestigious trial, but just about 3,500 odd patients, all less than 75 years of age, presenting within 12 hours, already received fibrinolysis, aspirin, heparin, and then randomized to clopidogrel versus placebo. Now herein, mind you, the clopidogrel was given as a 300 milligram loading dose, followed by the maintenance dose, which is the practice today for everybody less than 75 years of age. And what was it? Meaning the primary outcome was different. It also looked at IRA patency and stuff like that. But the secondary outcome, the 30-day outcome, which is so relevant in practice, is a 20% relative risk reduction between the placebo arm, which was on top of aspirin arm, that is, and the DAPT arm, wherein 20% relative risk reduction in the composite of hard endpoints, CV, death, myocardial infarction, and the need for urgent revascularization. As also, so this is what it was. And that DAPT therapy benefits STEMI patients treated with fibrinolytic therapy became very evident since then. And the second trial, okay, and this was without causing that major bleeding, the safety, whether it was major bleeding, minor bleeding, intracranial hemorrhage, immediately on the day after, through the day after angiography till 30 days, you can see the p-value not significant at all, which means that clopidogrel on top of placebo did not cause, compared to placebo, did not cause any excess bleeding. So perfect way to get into the guidelines. The second trial was the COMMIT trial, where 45, which was way too large, 45,000 patients coming from, however, with a pinch of salt, coming from China. That is, if I were to debate this topic, but presenting within 24 hours. And here, surprisingly, there was no loading dose, just 75 milligram added on top of aspirin. As also, these patients were representative in the sense that non-specific specific fibrinolytic therapy in the form of urokinase given in a vast majority of patients. And what did they show? Not only that the death, MI, or stroke, the primary endpoint was, you call, down by 9% relative risk reduction. But also, this is up to 28 days since randomization. But also importantly, unlike the CLARITY trial, there was a mortality benefit, a 7% relative risk reduction in mortality too. Small wonder then that clopidogrel made it to the guidelines. Mind you, both these trials are from year 2005. Since then, we have come to know what are the limitations of clopidogrel, and newer P2Y12 inhibitors have come on the market scene, but all tested out against primary PCI or pharmacoinvasive strategy. So the safety outcomes again in COMMIT were similar in the sense that no added extra, no excess of bleeding. And in an editorial, people went on to write that the additive antiplatelet effect on clopidogrel on top of aspirin may help shift the balance in favor of a sustained reperfusion rather than reocclusion. We all know close to 30% of fibrinolyzed STEMI patients would get reocclusion, and that's why the concept of pharmaco-invasive therapy, that is, get them as early as possible within the first 24 hours, irrespective of symptom class, irrespective of what is the bedside reperfusion parameters, that you want to do an angiography and open the IRA. So patent IRA, open artery hypothesis, came forth with these two trials, and that's why. But one very fascinating and unexpected observation in COMMIT was that the benefit of clopidogrel as emerged, just one tablet given, mind you, in COMMIT, as early as the first day. And when given without a loading dose, we all know it takes several days for clopidogrel to reach a steady state antiplatelet effect. So that is so much for the turban that I was wearing. And now let's go to the hat. And the topic is not about loading with ticagrelol or otherwise. It is about a very philosophical concept as to have the open artery hypothesis. Can we, with fibrinolysis, give as an adjunctive therapy ticagrelol rather than clopidogrel? And based on CLARITY and COMMIT, the guidelines give a class 1A recommendation to clopidogrel, but they are silent on ticagrelol and prasugrel. They don't say it's a class 3 recommendation along with fibrinolysis. Then why not use it? Why are we slave to these guidelines is what I would ask of my worthy opponent. Why do we have to file guideline recommendation always? And when we talk about these guidelines, and there was a good editorial by Kohn in the context of a patient of heart failure, but it's very relevant to us. The best physician for a patient is he or she who would provide individualized care rather than slavishly follow the guidelines. Today's recommendation may be outdated tomorrow. Mind you, these trials are from 2005. Today we are 15, 16 years later. As also, we need to innovate is what he tells. He says again, very relevant, and that's what I'm going to embark upon. Most of the therapeutic advances incorporated in current guidelines are a product of a deviant behavior that violated traditional practice. So can we violate guidelines here and indulge into deviant behavior? Let's talk about loading with ticagrelol along with fibrinolytic therapy rather than clopidogrel. And such deviant behavior we do come across. We do get patients who have received, thanks to the propaganda of ticagrelol, such patients. And there is evidence of use of ticagrelol given as a loading dose. 44 patients with STEMI who had received full dose of fibrinolytic agent within 6 hours of the onset of chest pain received aspirin and off-label ticagrelol. It's possible that these patients were supposed to have gotten transferred for primary PCI and therefore they got it, but they got it. And when they underwent angiography at a median of 61 hours, the patent IRA hypothesis was very much there. 80% of the patients had either TIMI-3, 50%, or another 30% TIMI-2 flow. There was, mind you, no in-hospital MACE. 2 patients died at 30 days related to heart failure, where only 3 out of these 44 had minor bleeding, and there was no major bleeding. Again, the fear of bleeding with a more potent agent not really seen. So this is what, when you glean data, you can individualize. We clearly know from pharmacokinetically that ticagrelol is way too superior to clopidogrel. That is because clopidogrel is limited by its delayed onset of action. It has a large inter-individual variability in its platelet response. It has irreversibility of its inhibitory effect. And moreover, it requires two-step activation process being a prodrug, and it is susceptible to interference of genetic polymorphisms and drug-to-drug interactions. And advantages are clearly there with ticagrelor, which has got a rapid onset of action and more intensive P2Y12 inhibition, which on top of it is also reversible, which was the proof of the pudding lies in the major trials, right? And what is it? 18,000 patients of ACS in the plateau trial clearly showed us there was a 16% relative risk reduction, almost a 2% absolute risk reduction with ticagrelor on top of clopidogrel in these ACS patients in terms of the cumulative primary endpoint of CV, death, MI, and stroke. That is there, that was there for everybody to see. And importantly, hazard ratio for major bleeding, not statistically significant, 1.04. So the lines virtually meeting each other. Minor bleeding may have increased, but no major bleeding compared to clopidogrel. And were there STEMI patients in this? Very much. There was a pre-specified analysis in a 7,544 patients who had STEMI. Again, the similar outcome as the overall trial that I spoke about in the previous slide. But there was one caveat here, that fibrinolysis given in the past 24 hours was an exclusion criteria for the trial. So if fibrinolysis was given earlier than 24 hours, then it was fine to take these patients. Why? In the context of fibrinolysis, we need to understand that platelet reactivity is heightened. And that is why we want to give a second antiplatelet agent. Now, this is data randomized trial for PCI, early PCI in first 24 hours, clopidogrel versus ticagrelor. But you see at the baseline, these are patients who have received fibrinolysis. At the baseline, they have a high platelet reactivity, cutoff point being PRU, that is P2Y12 inhibitor reactivity unit of more than 208. This is eventually randomized to ticagrelor arm, but a vast majority of fibrinolized patients from our pharmacoinvasive trials of this kind, randomized data-wise, we come to know that there is high platelet reactivity, which within the first 2 hours with ticagrelor, the PRU has gone down into 50s, correct? And clopidogrel still high on platelet reactivity. 24 hours later, consistent, you can see strong and consistent rapid platelet inhibitions shown in red dots with ticagrelor till pre-discharge, and with clopidogrel, just about that we talked about, it takes long for clopidogrel to build up its antiplatelet activity. So there is this pharmacological funda as to why we want to test out ticagrelor. And to address this safety about giving ticagrelor instead of clopidogrel in patients who had received pharmacological thrombolysis, a large trial was conducted. Of course, mind you, the sponsor was AstraZeneca for this trial. And in this trial, patients with STEMI who had undergone fibrinolytic therapy, 3,800 odd patients randomized to ticagrelor, usual loading dose followed by maintenance and clopidogrel, and treatment was given as early as possible, not later than 24 hours, which was seen in the plateau trial. So early patients, and what did they find? And the follow-ups were done at 7, 30, and 12 months. And what did they find? And very important characteristics wise, unfortunately, it was not absolutely early within the post thrombolysis. It took about a median of 11.5 hours in both the arms for ticagrelor loading to be given. But this is on top of clopidogrel. Almost 90% of the patients in this trial had received at the time of their fibrinolysis loading dose of clopidogrel 300 milligram or so, or even more than 300 milligrams. So going by that, we would have expected bleeding, but no. The primary endpoint, I told you it was a safety trial powered to look at safety, and bleeding at 30 days, kissing lines here, absolutely no difference, non-inferiority proven compared to clopidogrel. Giving ticagrelor post-fibrinolysis at least giving that a median time of 11 hours, no problem. And even if you were to split this 11 hours into the early 4 to 8 hours, what do you find? And whatever the definition of bleeding, in the trial it was STEMI major, you look at Plato major or Bach type 3-5 types of bleedings, what do you find here? Absolutely p-values not significant for major bleeding between clopidogrel and ticagrelor. So ticagrelor on top of clopidogrel, even in post-fibrinolytic patients, as early as 4 hours, does not cause any excess bleeding. Then why are you fearing bleeding? It was not powered, I told you, this trial for looking at efficacy endpoints, which were again not different between the two groups, if at all a trend towards being lower in the ticagrelor arm. And this was seen at the 30-day findings as well as late as 1 year later also. With ticagrelor, there was no difference in the efficacy endpoints. But to look at efficacy endpoints, typically they pooled an analysis of treat and plateau. Plateau STEMI patients were there. I told you so many 7,000 odd STEMI patients were there. They took those, they took the 3,800 patients in the treat. And what did they find? That it was positive for composite of efficacy endpoints as well. And it was so also for recurrent ischemia, TIAs, and arterial thrombotic events. So what did they conclude on the basis of this pooled analysis of treat and plateau? That ticagrelor 90 milligram BID plus aspirin reduced the risk of MACE at 12 months compared to clopidogrel 75 milligram plus aspirin with no statistical heterogeneity in these trials. So then what about the real world evidence? A large registry from Canada, Vital Heart Response Registry, where again patients who 1,426 patients who had received fibrinolysis and then were supposed to undergo a pharmacoinvasive strategy, 396 of them were switched to ticagrelor and they were content compared with the ones who were on clopidogrel. This was at the discretion of the physician what to give. So to say, they were obviously guideline-wise all received clopidogrel, but switched to ticagrelor. And on switching to ticagrelor, you see no increase in bleeding on top of clopidogrel. As also efficacy endpoint-wise, this vital response registry shows there is efficacy when you give fibrinolysis, switch to ticagrelor, and then look at efficacy endpoints at 30 days and 1 year. And what do you find? 1 year later, clear benefit with ticagrelor. You have the number of MACE events with ticagrelor. As also all-cause mortality, there is no benefit here, but recurrent MIs you prevent with this switching to ticagrelor. So therefore, switching patients from clopidogrel to ticagrelor as early as within 24 hours resulted in reduced recurrent ischemic events at 1 year compared to maintaining patients on clopidogrel therapy. And finally, I would say, I have convinced you, I hope, enough that do not fear bleeding. And this is what actually was meant for my worthy opponent, a very close friend, Gurpreet Singh Wander, jo dar gaya for bleeding, samjho wo mar gaya. And dar ke aage jeet hai. So let me conclude by saying ticagrelor is the future. Thrombolysis remains a major problem. Thrombolysis remains the reperfusion therapy, and what to load with remains a problem for STEMI patients in India. We believe that, of course, being a purist again, we believe that a randomized controlled trial may be at the behest of CSI. Now that CSI is what you call indulging in lot of registry data at least, or maybe people should really, small centers should start this and we should run this kind of a registry trial, ticagrelor versus clopidogrel as adjunct to fibrinolysis. And until such trial is convinced, and thanks to this debate, thanks to this invitation by my friend, Dr. Nitish Naik, I have really also learned a lot by gleaning all the data. And I, for one, am willing to switch to ticagrelor, if not to load with ticagrelor when thrombolysis is the only choice in my STEMI patient. I hope I have not eaten away too much time wearing both the hats, and I'm happy to take any questions. Thank you so much. And shall I stop sharing?
Yeah, you actually stuck to time. You covered both the topic in excellent time. So I think we have some time for discussion. I think my co-chairpersons will have some questions or comments to make.
Sure.
I think you have very clearly said that ticagrelor is definitely more helpful and much better as compared to the other drug also. So this, and does it also prevent the difference in the stent thrombosis, I hope, over a period of time?
It does. It does. Meaning I did not really, because I was not talking about primary PCI as such, but pharmacoinvasive strategy. Our colleagues from down south, I'm a part of the STEMI India group also. They have also shown that. And I showed you one small study wherein if you look at the angiographic evidence, even before you have embarked, when you've taken up your patients for the primary strategy, for the pharmacoinvasive strategy, within the first 24 hours, when you are given thrombolysis, on top of a P2Y12 inhibitor, if you look at ticagrelor group, that was of course an open label study, wherein they saw that the patency was as high as 80%. Fibrinolysis plus this. Now to dissect out, vast majority of our patients receive streptokinase, whether basis on the ASCENT-3 trial, which was with anticoagulation and streptokinase, or 2B3A inhibitor apixaban with streptokinase, there was a problem in bleeding. So we always wonder whether streptokinase will give bleeding. In fact, when we resort to pharmacoinvasive strategy, we all talk about if you're doing it within the first 6 hours, and if you are on streptokinase, you want to go the radial route and not try and do it in the latter part of the first 24 hours rather than within the first 6 hours. But these are all uncalled for things. We are happy to take patients on whatever kind of antiplatelet they are on. And only ticagrelor allows us to do it. I'm very confident that if we run some such trial, we'll be happy to use ticagrelor because we do not want re-occlusion. That is what it is, isn't it? Following thrombolysis.
Thank you, Dr. Praful. That was a fantastic disposition.
Hello.
And we really thank you for your excellent talk. And I think so, I feel very tempted now to give ticagrelor after listening to you.
Well, we academic institutes should at least come together, and maybe we should run some kind of a data, maybe an open label data also. But we must try it out because I'm convinced there is no fear about giving a ticagrelor along with this. Because within the first 24 hours, there is so much data that you have given clopidogrel. On top of that, you have loaded with ticagrelor. We do that, isn't it? So why not just with fibrinolysis? Only we can't give out wrong messages outside to the community at large, because a lot of them receive thrombolysis in the community and come to us also. So if we try and tell load with clipot without really conducting some kind of a study, we try and tell the world at large that load with ticagrelor, maybe that's not the right way of going about things.
Dr. Kerkar would
thank you so much.
early offset with ticagrelor.
We need to mute Dr. Dr.
Kerkar, mute Dr. Das.
Yeah. Go ahead, Mr. Verma.
Early offset with ticagrelor be also an advantage while loading these patients before thrombolysis. Early offset, because ticagrelor offers
if you remember, there is an Atlantic trial which talked about pre-hospital loading with ticagrelor. Of course, they dissected it out, and there was not really any extra benefit when they first did the angiography as such. Okay, but that was just ticagrelor. Here, you want to give fibrinolysis, even if there are high on platelet reactivity kind of patients, yet we can then block it with ticagrelor, and you will block it more efficiently. There is enough pharmacological data to show that it is superior to clopidogrel because of its rapid action. I totally agree with you, Dr. Verma.
Thank you. So we move on to the next topic. I think so because of want of time. And I would request Dr. Amal Khan and Dr. Yogesh Verma to introduce the next session.
Right. Okay.
Next session is with Dr. Aditya Kapoor. We will talk on P2Y12 inhibitors in primary PCI, and I will only use ticagrelor. So far, the foregoing discussion, Praful Kerkar has already clearly delineated everything. I think he has covered a lot of Dr. Kapoor's. And before handing over the speaker to Dr. Kapoor, I would like to make only 2 comments over and above Dr. Kirkar, that in the initial phase of ticagrelor, there are some complaints from different patients of shortness of breath. And that may be a problem, number 1. And number 2, another issue is we have data of using ticagrelor for more than 12 months even with Pegasus to continue to another 1.5 years or more or like that. And I would request Dr. Kapoor to highlight these points as well.
Thank you, sir. Am I allowed to share my screen because the host?
Yeah, go on.
So I'll just. Is my screen visible now?
No.
So as Dr. Amal Khan rightly said, Dr. Praful has been like Jasprit Bumrah. He has just cleared the way for me, and thanks, Nitish. So we all know that these are the 2 agents available to us. Irreversible is prasugrel and ticagrelor is reversible. They are rapid in action, more potent, more reliable, less inter-individual differences as compared to clopidogrel. So I'll cover these 5 issues quickly in the time allotted to me. First of all, we all know that tica and prasu are both potent agents. How do they behave in patients high on clopidogrel platelet reactivity? This was the first data set pharmacodynamic comparison of tica versus prasu in patients of acute coronary syndrome. Guys who had high on treatment platelet reactivity when they were given both drugs. This was actually a crossover trial. Tica had a stronger platelet inhibition.
May I interrupt? I cannot see your slides. I don't know if the
Your
rest of the world can.
Only the screen one can see, Aditya.
Sorry?
We can only see your screen.
Dr. Kapoor, share your screen.
We can't see your slides.
I'll go again then.
Yeah.
Are they visible now?
No.
So
No,
please
the slide
open
is
please
not
open
visible.
this open the presentation, sir.
Just try to that.
So I'll share screen again.
No. Oh, it's right now. No.
Are they visible now?
No.
No, sir.
No,
I
not
think you
yet.
have to first open the slide, then try sharing the screen, sir.
This is slides not visible till now.
Okay.
So he has to click on that particular topic.
Are they visible now? No.
Yeah. Yes. Right now.
Yes, sir. Just put it on presenter view, sir. Yeah, perfectly fine, sir.
Sorry for the glitch. So I'll go again. We have 2 agents which are available to us under discussion now. So prasugrel, ticagrelor, they are both more potent than clopidogrel. Onset of action is faster, more reliable effect, and lesser inter-individual differences. My brief in the next few minutes would be to compare these 2 drugs, and then I'll hand over to Dr. Sandeep, my dear friend. First of all, we all know both agents are pharmacodynamically superior to clopidogrel. What about patients who have high on treatment platelet reactivity? This was one of the first data sets of pharmacodynamic comparison of tica versus prasu in patients of acute coronary syndrome. And when patients were given both drugs, this was a crossover short study. It was found that ticagrelor had better inhibition in terms of platelet inhibition. And when this data set, there were entire meta-analysis was done. The endpoint was high on treatment platelet reactivity. It was found that the effects of ticagrelor were a shade superior to prasugrel, especially in patients of STEMI. In fact, maintenance dose of ticagrelor 90 BD did better than prasu 10 milligram in terms of degree of platelet inhibition. So the first carry-home message, although both agents will effectively treat high on treatment platelet reactivity, ticagrelor probably provides us a shade better, stronger platelet inhibition in such patients. Second, the clinical data set. We have 3 trials. I'll just briefly cover them. The Prague 18 was the first such data set in patients of STEMI undergoing primary angioplasty. This was primarily an endpoint analysis at 7 days. Intended follow-up was 1 year. And the study was terminated prematurely for futility because there was no difference in 7-day or 1-year endpoint. So this was a neutral trial, and remember that at least 1/3 of these patients in this trial had actually switched to clopidogrel at the end of the follow-up due to economic reasons.
The total trial, which was a Canadian observation analysis, 10,000 STEMI patients randomized to primary angioplasty with thrombus aspiration versus angioplasty alone. And the composite ischemic endpoint, in fact, in this observational analysis, TICA scored over clopidogrel and prasugrel in terms of reduction of the ischemic endpoint. And the stent thrombosis were also reduced with ticagrelor at no increased expense of bleeding. So the second important data set, this Canadian observational analysis, found that TICA was actually superior to prasu and clopidogrel both. And then the major trial, we all know the ISAR React 5 patients of acute coronary syndrome, out of which 40% were STEMI, and prasugrel completely outscored ticagrelor in terms of reduction of ischemic endpoints without any significant increased risk of bleeding. And the entire endpoint was driven by reduction in myocardial infarction. So the ISAR React taught us that prasu was perhaps better without increasing bleeds. So I'll just spend a few minutes on this important trial. What have we learned from this? There were minor limitations. It's an open label trial, telephonic follow-up, lower than expected event rates. They were expecting the prasugrel arm to have about 12% event rate. It was only 7%. But 4 important learning points in my view, which Dr. Praful also said we should tease out the data from trials. Intention to treat analysis, which is a well-accepted methodology. But in this particular trial, it might have distorted the results. If you see actually discharge on medicines and actually patients taking the index drug at follow-up, nearly 1/3 of the patients were not taking either TICA or prasugrel at follow-up. So if you do it by intention to treat analysis, you have an absolute difference of 47 events, which was in favor of prasugrel. However, if you go by on-treatment analysis, that is the guys who are actually taking the desired drug, the event difference is only 21 events, which was not significant, just a borderline significance. That is number 2. Observed bleeding rates. The observed difference was about 15 events, and prasugrel was thought to be non-inferior. But if you see, about 1% in the TICA and about 11% in the prasugrel arm was actually excluded from analysis for reasons unknown to us. So whether or not this would have converged or diverged the curves of bleeding in away from prasugrel, we are not sure. And lastly, the primary composite endpoint. We all know if the driving component is an objective measure like death, the legitimacy of the composite measure remains intact. Although myocardial infarction, which was one of the composite endpoints, is a good endpoint, we are more interested in observing a reduction in the type 1 or atherothrombotic MI. So if you actually tease out the data of the ISAR React, the primary reduction was by reduction of these periprocedural infarcts. So these are important 4 points to remember about ISAR. And we all know the guidelines now at present tell us that both prasu and TICA can be chosen over clopidogrel, but the guidelines actually do not make any distinction as to which agent should be chosen. So I'll just briefly show you this meta-analysis, 3 meta-analysis and 3 important registries before I close. This is the data from the Hong Kong registry. Meta-analysis, cardiovascular mortality was reduced both with prasu and TICA as compared to clopidogrel, which is expected. Major bleeds were more with prasugrel. This data set from Navracis group, primarily Canadian and Polish data, meta-analysis found that only ticagrelor reduced cardiovascular and all-cause mortality. Both TICA and prasu reduced the stent thrombosis risk. And very interestingly, when these guys excluded periprocedural MI, that is type 4 MI, from all the trials, and this included the Prague and the ISAR React data as well, there was reduction of myocardial infarction both with prasu and TICA. And this is the latest meta-analysis by Ray, a head-to-head comparison, and again including all the trials, including the Prague and the ISAR. Both prasu and TICA were associated with similar outcomes and bleeding events. If you look at the registry data, the Danish heart registry, the composite endpoint was reduced both with TICA and prasu at no increased expense of bleeding. The Swede heart registry, again, TICA versus prasu, there was no significant reduction in the either the MACE or the net adverse cardiac events, including the bleeding endpoints. So although meta-analysis are complex to analyze heterogeneous patient population, my carry-home message would be from these trials, both are more effective. We all know that in comparison to clopidogrel. However, ticagrelor has a slightly higher rank probability for reducing cardiovascular death and all-cause mortality as compared to prasugrel. Evidence at present suggests no significant difference, notwithstanding the ISAR React data between prasu and TICA. In my opinion, the good effects of prasugrel perhaps get slightly offset by the higher bleeding risk at the moment. If you look at the utilization rate of P2 Y12 inhibitors across the world, even after publication of all these data, this is European data where Tika, of course, outscored prasugrel, and the NCR data from US, if you see in the last few years, the utilization rates of clopidogrel and prasugrel have gone down slightly, while Tika has climbed up. So my messages or my impression, ISAR React would it change my clinical? I would say that it's a good trial. But again, as Dr. Praful also mentioned, these are two strategies which are available to us. In my opinion, that's my personal opinion, recognizing the limitations and the slight caveats of the ISAR React, I would not perhaps consider it sufficient at this point of time to alter my treatment strategy. In fact, I would introspect and say that this, I would study how the future clinical trials are shaped. The methodology of trials need to be more introspected into. Patients with STEMI, we all know they need a rapid, urgent, and effective blockade of the P2Y12 receptor inhibitor. They are also a group which are potentially at greater risk of side effects from these new therapies like bleeds. Guidelines, of course, do not make any distinction which agent is superior, but real-world data suggests that Tika is perhaps the most frequently used inhibitor as of now. Prasugrel is a good agent, but it needs a definite trade-off between decreasing ischemic risks and increased risk of bleeding. So future trials will need to definitely incorporate objective, clinically relevant composite endpoints when these trials are designed as a head-to-head trial. Briefly, cost, because that is a major issue. So I just pulled out data from major industry players. This is Prax and Tracita, which capture 83% of the market share, and these are the brands of ticagrelor. Because they use it BD, over a month, it would carry a difference of over 1,000 rupees. And over a year, it would carry a difference around 10,000 rupees. But if you see, this is a Markov analysis or cost-effective analysis of both drugs in patients of ACS available from Hong Kong. In fact, if you look at the incremental cost-effectiveness ratio, it is slightly in favor of ticagrelor, probably because meta-analysis also suggests that there is a slight more risk reduction in all-cause mortality in patients of ACS with Tika. But of course, both drugs are available to us. In my opinion, I would go for ticagrelor. Last slide. Prague 18 neutral. Total trial Canadian data in favor of Tika. ISAR React strongly in favor of Prasu. Guidelines again neutral. They recommend both. Meta-analysis registry data world utilization rate slightly skewed in favor of ticagrelor. High on treatment platelet reactivity, off-target effects like inhibition of adenosine reuptake, which improves coronary blood flow, endothelial function. I don't know how much clinically relevant it is, but it is a pharmacodynamic effect which is there. Of course, dyspnea happens here. Higher bleeding risk. Cost, I already discussed. The cost effectiveness in Markov models have been found to be showing that ticagrelor is a good cost effective agent. So in my opinion, notwithstanding the strong ISAR React data, these other data sets combine to tilt my opinion, my scale in favor of ticagrelor. Thank you.
Thank you very much for the, can you hear me? For the nice
Yes, sir.
talk. Yeah. There's no doubt that prasugrel enhances platelet inhibition as in phase 3 Triton TIMI-3A trial. And also data from the principal TIMI 44 confirmed prasugrel is a potent inhibitor of platelet aggregation in the setting of scheduled CCI. But the question remains that more potent platelet inhibition translates into a reduction in the atherothrombotic events clinically. That's the question. Can you see me, please? Can you hear me?
Yes, sir. Yeah.
Yes, loud and clear.
Is it clear? Can you hear me?
Yeah.
Okay. So I think considering the merits and efficacy of prasugrel, there would be a need not for generalization, but more for individualization of therapy, considering the age of presentation of the patient, risk factors, especially diabetes, previous history of cardiovascular events and cerebrovascular events, and also more important, the facilities to manage bleeding complications must exist. Thank you.
Okay, we should proceed to Dr. Sandeep Bansal.
Thank you.
Council available?
Council
available?
Yes, I'm here.
Then you can start your deliberations and slide presentation.
Yes. Good afternoon.
I think at the end of the session,
can you see my slides?
Yeah.
Yes.
Hello.
Yeah. Yes.
Can you see my slides, please?
Yes, we can see.
Okay. Good afternoon, and thank you very much. And my friend Aditya has, talked so much. He's actually largely compared the two drugs. The issue here is not really comparing two drugs. We are talking of a particular situation, that is primary PCI. So perhaps I will come to the same conclusion by using the same data, maybe some few different things. So if we look at the history of dual antiplatelet therapy, these are the various trials that we know of in which besides aspirin, 4 different agents have been used. Now, we also know that the 2 major trials that were conducted on both prasugrel and ticagrelor are the Triton and the Plateau trial respectively. Both actually showed that there was a reduction in the primary endpoint. In fact, a 16% reduction in case of Plateau and a 19% reduction in case of Triton TIMI 38 trial, but both were in comparisons to prasugrel. But when we look at these in the Plato trial, only 37% of patients were actually on were ST elevation MI patients, and even fewer than that were actually undergoing primary PCI. Likewise, in the Triton TIMI 38 trial, it was only 3,500 patients who were ST elevation MI patients. So we need to remember that whatever evidence we have in ST elevation MI, which is the topic, and in that too, the subgroup of primary PCI, we have very few patients. We have approximately a third of patients, or less than 40% of patients in either of the trials comparing with clopidogrel. So it has been seen, as I said, in the subgroup of 2,400 patients in prasugrel versus clopidogrel, there was no advantage. And likewise, in the group of 7,500 patients in the Plato trial who were STEMI patients, there were no advantages. But the thing doesn't end there. The angioplasties that were done in these trials were not essentially all primary PCIs. We need to understand that the topic here is basically primary PCI. Even in ICER REACT, as Dr. Aditya Kapoor so emphatically pointed out, only 40% approximately were STEMI patients. In fact, we also must understand that the major advantage, you've seen these 2 graphs showed in ICER REACT, it was seen that it had a greater efficacy and it also had a greater safety, the prasugrel. But the major advantage actually came in the subgroup of non-ST elevation MI unstable angina. It did not come in the ST elevation MI group. Even in the ICER REACT, the advantage was seen in the non-ST elevation MI. And that is one of the reasons why the European Society of Cardiology in their 2020 guidelines recommend the usage of prasugrel in non-ST elevation MI over the over ticagrelor, whereas in case of ST elevation MI, as again Aditya very elegantly showed, you have a choice between ticagrelor and this. Now, when we look at the Prague 18 study, we need to understand again that this was perhaps one trial. Can we ask them to? Okay. So we need to understand that this Prague trial was perhaps the only trial which came closest to what our topic of debate is, because 90% of the patients were ST elevation MI patients in this trial. There were 99% of the patients who actually underwent primary PCI and not a delayed or other type of PCIs. The other thing is that we normally use prasugrel after the coronary anatomy has been identified. That is what we've been taught. But in this particular study, it was seen that you could actually safely load prasugrel in the patients who were going for primary PCI. So it was being loaded. However, it was noted that there was no advantage of one drug over the other, and it was terminated prematurely halfway through, actually, when just 1,200 patients had been covered, although it was designed for 1 year. There's been more real-world data. There is a RENAMI registry, which is over 12,000 patients. Again, it has been seen that prasugrel is perhaps more advantageous in the STEMI patients, but in case of STEMI patients, if you use prasugrel versus look at prasugrel versus ticagrelor, there is really no advantage. So why is it? So following in the issue which carries the Prague trial, there's an editorial and which clearly says that the uncertainty remains. This is because this is the number of patients who have been studied. And given the present circumstances, if we want to get to statistical significance in terms of equivalence or superiority, the number of patients that we need to have is 55,000 patients to prove a 10% difference, and at least a 7,500 patients with ST elevation MI to show a margin of 30%. So that kind of studies, that kind of trials, a 55,000 patient trial, which is closer to the possible difference between the two drugs, that kind of trial has not been done, and it also seems to be not possible. And that is the main reason why we currently believe that the two drugs are equal. So in conclusion, I would like to say that no trials establish the superiority of ticagrelor over prasugrel or vice versa in the setting of ST elevation MI patients undergoing primary PCI. We should try and use the data for which we have evidence. I mean, I did not go into details of the Triton-TIMI 38, but the gist point that came out of Triton-TIMI 38 was that the greatest mortality advantage was in what kind of patients we have. Typical middle-aged male patients, diabetic, with a large anterior MI, with or without left ventricular dysfunction, undergoing a primary PCI. That is the category of high thrombotic risk and low bleeding risk patients where perhaps prasugrel has a clear advantage. If we really want to see whether there is a difference between the efficacy of the two drugs or not, we have to do a very large trial. The most significant, a very significant point, I actually learned from my teacher, Professor Devedi, who now heads the KGMU. And he said both the trials, remember both the Prague trial as well as the ICER-REACT trial were actually sponsored by the makers of ticagrelor in a bid to show that there is a superiority of ticagrelor but both the trials could not show that. So let us conclude by understanding that we need to use both these drugs in the proper clinical perspective based on the clinical profile of the acute ST elevation MI patients that we say. The evidence so far does not prove the superiority of one over the other. I thank you for your kind attention. Thank you very much. If there are any questions or comments.
Thank you, Dr. Deep Bansal, for the extremely excellent talk. Because we're running short of time, we would like to wrap up this session and move on to the next session. We thank you for the talk and we thank the chairpersons for the support. For the next session, STEMI in shock, I'd like to invite the chairpersons, Dr. Ajay Chaurasia, Dr. Venkat S. Ram, Dr. Manoranjan Mandal, Dr. Neil Bordoloi, Dr. Praveen Jain, Dr. Sarita Gulati, and Dr. Surinder Deora. I would like to invite Dr. Ajay Chaurasia to kindly begin the session. Can we please begin the session, sir?
Can I request Dr. N.K. Das to please share the slides?
Yes.
Dr. Das, can you hear me?
First, you need to remove the slide sharing.
Yes, sir. We'll just do that.
Yes. Are my slides visible?
Visible.
We can see the slides, sir.
Okay. Am I audible?
Yes, you are audible.
Yes, yes.
It was 12 minutes. Now it has been reduced to 9.5 minutes. Okay. My topic is hemodynamics of cardiogenic shock, impact on clinical decision making. And it's a very interesting topic in the sense that it's a very, very common one, but very difficult to manage at the end of our career. It's very difficult, I tell you. Why it is so? Let us know some of the aspects why it is so, especially considering the various facets of the hemodynamic aspects. Now, as you know, that shock is a syndrome characterized by decreased tissue perfusion and impaired cellular metabolism. Cardiogenic shock is also the similar condition where there is a low blood flow phenomenon. And mostly it is defined in different ways, but when the systolic BP is less than 90 and mean arterial pressure is less than or equal to 60 and systolic, then one should consider that the patient has gone for cardiogenic shock. This is very, very important because of the fact that as we are discussing in the last session, that's AMI is another condition which is very, very important in producing the cardiogenic shock. And they are mostly complicated with different types like cardiogenic shock, heart failure, arrhythmias and all. And the incidence actually has not changed over so many years and is associated with 40 to 60% 30-day mortality. It's huge. And that's why the shock trial actually gave us a light that the total or early revascularization improves the long-term survival, especially in preventing the cardiogenic shock. But having said all this, the mechanism or the pathophysiology is a complex one. These are some of the etiological conditions of cardiogenic shock. Out of this, actually, most important one is definitely the myocardial infarction, and second is of course the ventricular dysfunction, whether it is right, left. There could be other conditions like ventricular rupture, acute mitral regurgitation, and acute aortic regurgitation post cardiac surgery cases. SCAI defined the cardiogenic shock in different stages like A, B, C, D, E. And I am not going into the detail of it, like it could start with a low risk and then it could go to the extreme where there is maximum chance of mortality. And as you can see on the right-hand side panel, that the overall cohort showed very huge mortality in the hospital as compared to the cardiac intensive care unit mortality. Why the difference is because when the patient is admitted in the intensive care dedicated for cardiogenic shock management or revascularization or all other facets, then the mortality gets reduced. Now, why understanding of CS physiology is helpful? Because it gives us the clarification on implications of various valve closures, pulmonary and LV unloading, implications of myocardial energetics, why not everyone requires LV unloading during ECMO, and several other factors. Well, whether there could be escalation, whether there could be de-escalation, and whether we should use more of pulmonary arterial catheter or not. And the cause of all the maladies are due to this particular aspects, that you see the different mechanisms raising the LV EDP and causing hypoxemia, ischemia, progressive myocardial dysfunction, hypotension, coronary perfusion is compromised. And ultimately, there could be a reversible phenomenon because of the fact that there is systemic inflammation. Inflammatory cytokines are increased, and they actually they cause the multi-organ dysfunction with acidosis and electrolyte imbalance and all, and ultimately there could be very catastrophic results. This particular slide is very, very important for everyone. This is a pressure volume loop, and in our student life, this had to be learned by heart. And because of the fact that the filling pressure, ejection, then the outflow pressure, and then outflow tract pressure, all these are actually shown here, and how they change over time, and how Laplace's law and Frank-Starling law are applicable in different conditions, right from the normal to the abnormal situations, and how the PCWP increases and how the ejection fraction decreases. All these are actually very much implicated here. And you can see that there is a ventricular vascular coupling, and they are actually defined as the preload when the ventricle gets filled, and ultimately the pressure rises, and that pressure rise can ultimately give rise to the aortic the ejection, and ultimately I would request everyone to mute themselves. And similarly, when the pressure gets increased, there is afterload mechanism, which again influences the whole process of ejection and output mechanism. Now, herein again, one more factor is applicable, that is the cardiac energetics or myocardial energetics, which is responsible for contractility, and ultimately they can result in alteration of the different dysfunctions, whether it is systolic dysfunction when the output is very less, and pressure is also less in LVP as well as in aorta, and there could be diastolic dysfunction when the LV EDP is raised, and there could be lowering of both the LV pressure, systolic pressure, as well as the aortic pressure, and there could be manifestation in the form of acute pulmonary edema. Now, in acute left ventricular failure, actually, there is this outward phenomenon, that is, they are shifted to the right. This loop is shifted to the right. That's why the pressure, the pulmonary capillary wedge pressure gets increased because of the rise in the LV filling pressure, and there is abrupt reduction in LV contractility, and CPP can be normal or increased. Baroreceptor activation occurs with heart rate increase, then systolic venous systemic venous return is also compromised, and thereby there can be influence on the right ventricle itself, and thereby the right ventricular pressure volume curve is compromised. And similarly, pressure volume relations in shock due to isolated RV failure is very, very interesting. This occurs mostly in the inferior myocardial infarction, where there is gradual rise in the right ventricular EDP, and thereby it compromises the ultimately ejection and contractility, and ultimately the LV filling pressure gets reduced because there is no output to the left ventricular side. And thus, the abrupt reduction in right ventricular contractility raises the CPP, capillary wedge pressure normal or can be decreased. LV underfilling leads to decreased cardiac output and BP, and baroreceptor activation increases the various sympathomimetic actions. Now, there is a condition where there is acute biventricular failure and the pressure volume relations gets compromised in both the ventricles. And here is actually abrupt reductions in both LV and RV contractilities. CBP increases, PCWP can be normal, increased or decreased, and baroreceptor activation increases, heart rate, and other factors are coming into picture. Now, this is a condition where actually there is rise in the the pulmonary capillary wedge pressure, and there is pulmonary edema, which is also known as congestion. And on the right hand side, it can cause the systemic congestion. Now, based on this, there could be 4 conditions like left-sided congestion, combined left and right-sided congestion, then only right-sided congestion, and of course the normal one. And there are relationship between all these combinations where there is hugely high mortality with biventricular failure and also in left ventricular failure as compared to the right ventricular and euvolemic cardiogenic shock. Now, invasive hemodynamic assessment and classification of in-hospital mortality risk among patients with cardiogenic shock are very, very much prominent here in this slide, because in MI, there could be very much increased mortality as compared to the heart failure. But however, in both biventricular failure in both the conditions, they are very high as compared to the right ventricular and left ventricular type of this cardiogenic shock. Now, understanding the hemodynamic and energetics of different therapeutic options is again very important. You have to consider whether you are going for pharmacological therapy or device therapy. And the whole concept is dependent on the hemodynamic aspects. Now, there are few conditions like where we may have to resort to the pharmacological therapies, especially the inotropes like amrinone, milrinone, then dobutamine, then vasopressin, and of course noradrenaline. Then all these have got some amount of mild increase in cardiac output effect, and there could be some reduction of the LVEDP reduction. However, the cons are more. There could be manifestation of atrial and ventricular dysrhythmias and inducible ischemias. And in fact, the conclusion was that the mortality rate gets increased in hospital patients receiving the inotropes as compared to the diuretics and vasodilators to the range of 10 to 14%. And so for the devices therapies are concerned, there are different types of device therapies, like from the right ventricle, there could be impeller right ventricular device, tandem heart device, and also ECMO device. And similarly on the left side, there could be ECMO, then IABP, impeller, and tandem heart device. Now, why there is variability in the response to therapeutics for cardiogenic shock? This is important because the hemodynamic response to different devices and drugs are not same, and degree of LV and RV compromise also not same. Sorry, and short-term recoverability of RV and LV function are also different. And there could be alteration in the SVR and PVR, volume status, mitral regurgitation and TR. All these factors actually, they play a huge role in the hemodynamic side, and they play a huge role in the more response or less response of the various devices like ECMO. There is, though it has helped a good many patients, but what are the hemodynamic changes that has been shown here? That there is increase in
sorry, sir, the time, we are running out of time, sir. If we could just conclude.
So if we are running out of time, then I am not going to describe about the various various aspects of the ECMO, then transvalvular pumps like MCS or IAB, this impeller. This is a case which has been presented in the NIC, where impeller was given in both the chambers, right ventricle as well as the left ventricle, and the patient was bailed out. And there could be difference in the cardiogenic shock, and the right-sided support can be given with adequate support, and you may have to take the help of the additional methods, whether you are using ECMO. To ECMO, you may have to use the diuretics as well as the other methods like impeller, or even in the right-sided heart failure, if it is sucked because of the left ventricular failure, you may have to add the impella over and above the ECMO. And if the ECMO is being used, then you might have to use the various other methods. So these are some of the slides. I'm not going into the detail of it, but the conclusion of my talk is that one must know the hemodynamic concept so that you can better manage the patients with the various devices that are available today. And of course, the drug therapy is still there, but there is less effect with the drugs. So that's why the question of the device therapies are very, very important to be known. Thank you very much for patient hearing. Over to the chairpersons.
I'd like to invite Dr. Arup Das Biswas for the next talk.
Good afternoon. Please allow me to share the screen. Is it visible now? Okay. So thank you very much. But as I understand, the time is short. I'll be cutting off the initial slides. Yeah, I am going for this. Is it okay now? Okay. So without wasting any more time for the introduction, I'm going straight into the topic, that is whether there is any role for thrombolysis in cardiogenic shock in STEMI. Now the issue is, I'll be skipping some slides because they are dealing with mainly with epidemiology, mechanism, etc. Now the issue is rather historical, because by this time it has been documented that intervention is better than thrombolysis in the setting of cardiogenic shock in the context of STEMI. And the main thing is early and adequate perfusion. Now, as far as appropriate perfusion is concerned, it is better achieved by intervention. And why? That is due to the fall in perfusion pressure, and the thrombolytic drug cannot reach the culprit area where the thrombus is because of the very low coronary perfusion, diastolic pressure, etc. And the drug concentration is very low there. Now, whether we can do something better with IABP support? Yes, it has been shown in certain trials and studies that IABP assisted thrombolysis maybe can help. But for the role of thrombolysis, I'll have to refer to mainly to the historical slides from 1919's historical studies and data, because nobody is nowadays comparing between thrombolysis and intervention. They are rather comparing the different assist devices. Now, to go back, I'm going for the initial Gusto 1 trial experience, and what happened there we have to see. And this was to evaluate incidence, temporal profile, and 30-day outcome in patients with cardiogenic shock undergoing contemporary reperfusion treatment. Contemporary, mind you, it is of the 90s. So what we can see here, that majority of patients develop shock within 48 hours. So according to the Western data, the patients develop shock when within the hospital. But what is our Indian experience, that many patients come much late and they are in shock during presentation. So often we don't lose the opportunity to prevent or early recognition of development shock. Whatever it is, you find here the TPA did better than other thrombolytic regime. And patients treated with accelerated RTPA therapy were significantly less likely to develop cardiogenic shock than patients treated with other regimes. So the main role of the thrombolytic therapy is appropriate and early establishment of flow, and that can prevent the incidence of shock. So the days of thrombolysis is not yet over, but only one has to remember it has to be done early in an appropriate time. So late arrival has to be prevented at any cost. And in the larger group of patients who develop shock during the initial hospital stay, the streptokinase and heparin strategy. So streptokinase probably in certain trials it have shown when the shock is already developed may have some age over RTPA, but I am not going to advocate for that reason streptokinase in shock. It has got its other own limitations. So because cardiogenic shock occurred most often after admission and with the recurrent ischemia and reinfarction. So there are certain signals that this patient may go in shock. We can pick up them and go for preventive strategies, and the early thrombolysis may prevent their onset. And fewer patients treated with RTPA develop shock. This is an important message to remember. Yet those developing shock at the same high mortality. So here is the report that dismal, once the shock is developed, perhaps thrombolysis is not going to help much. Only angioplasty was associated with significant lower mortality rate. And the other thing that has come out of the analysis of a report from the shock trial registry, and you all know the shock trial registry, I'm not going to describe that. So what was the finding? It was 2000 presentation, not 1995. It was that patients receiving thrombolytic therapy had significantly lower mortality than those not receiving thrombolytic therapy in the overall cohort, and that is significant. So this is important to remember, and this benefit was independent of IABP use. I'm not going into the plus and minus points of IABP, whether this should be used or not, what are the limitations, etc. That would be discussed by my subsequent speakers. Now, in each of these subsets, patients who underwent revascularization had lower mortality than those who were not revascularized. So revascularization has a better role. And fibrinolytic therapy, when used in patients with AMI without shock, decreases shock onset and also prevents shock. So this is a vital fact, as it is known that shock development occurs after 6 hours of presentation. So we have to find out this spot and start thrombolysis. And these 6 hours are crucial for institution of therapy and can play a role in the prevention of cardiogenic shock. The role of thrombolysis is more in prevention rather than therapy. And the shock trial results registry showed that patients in coronary cardiogenic shock in STEMI treated with thrombolytic therapy had lower in-hospital mortality than those who did not receive it. So it is better rather than with nothing if the patient presents, of course, within the thrombolytic window. And those selected for IABP had a lower in-hospitality mortality than those who did not receive IABP. So maybe IABP allowed a better coronary perfusion with the thrombolytic therapy. So the lowest mortality rate was observed with the treatment of thrombolytic therapy alone, followed by revascularization. So this brings in way some role of pharmacoinvasive therapy as well, which could be the probability of therapy in our country. So the conclusion of the shock trial registry is that thrombolytic therapy, IABP, and revascularization by PTCA CABG was associated with lower in-hospital mortality rate, but the final outcome, 6 years outcome, has not been of that hopeful in all these situations. Subsequent trials and subsequent data analysis showed for hospitals without revascularization capability. So this is very important for those patients who cannot have revascularization by intervention or other means, or in centers where it is not feasible, a strategy of early thrombolytic therapy and IABP, followed by immediate transfer for PTCA or CABG may be appropriate. Unfortunately, we live in a country where immediate transfer facilities is also not available in majority of the situations. So what is the Indian scenario? Just this is not focused to the shock situation. It is a generalized data. So what has been the data of Victor Solomon and others is that I'm not going into the details of statistics. Their finding is the strategy, that is pharmacoinvasive strategy, may successfully alleviate the logistic or geographical barriers of primary PCI in the treatment. So primary PCI is the treatment of choice, particularly in the backdrop of shock. But in a developing country like ours, pharmacoinvasive and even thrombolytic therapy has to be given a due consideration. So to conclude, in India, we don't have interventional facilities in the majority of the centers. They can't even be transported or transferred to a PCI capable center within due course of time. So we are left with thrombolysis. Whatever benefit it can give, let it give. Early appropriate thrombolysis may prevent development of cardiogenic shock in STEMI. In some cases, pharmacoinvasive therapy supported by IABP, and however, IABP should not be taken lightly. Only in indicated cases it has to be done, and transfer to an equipped center may be considered. But once it has been developed, that is, shock is developed, the result of thrombolysis is not good, and outcome of post-MI shock is still grave in our country. So thank you for a patient hearing. I end over and stopping sharing over to the organizers.
Thank you, sir, for the excellent talk. Next, we invite Dr. Kaul to discuss about the ping pong in the guidelines regarding revascularization in cardiogenic shock.
Can I share my slides? Are my slides seen?
No, sir.
Are my slides seen? Hello?
No, sir.
No?
Share screen. Kindly click share screen.
Slides are not visible.
Just a minute. I had, minimized them.
Share your screen.
I had already, kept them minimized. I don't know why other things are coming. I think if you just give me a minute, I'll just leave and come back in a minute.
Also, what we could do is, sir, we could request Professor Dr. Ashok Seth to show his slides till it gets sorted out. Would that be okay, sir?
Yeah, from me, that's perfectly fine. I think we should do
We'll
that.
just check with Dr. Kaul.
Can you see my slide now?
So not yet, sir.
I don't know what's happening. So,
So Upendra, I'll go in and
I think
I'll
let
do
Ashok go and then I'll present.
Okay,
Fine.
so we can just change that order.
Okay, we change the order.
So I'm going to share my screen now. Okay, and let's hope it works. Can you all see my screen? Okay, so I think I'm just going to time myself, and I hope I stick to time. So I'm going to talk about mechanical circulatory support and cardiogenic shock. I think it's a very important area that we have to address in this session of shock and STEMI. Well, I have my problem because my slides are not advancing, even though you saw that. Yeah, so here it is. It's advancing now. So the clinical presentation of cardiogenic shock is a syndrome which either the patients are warm and dry, warm or wet, which means they're congested, they've got jugular venous dilatation, they've got ascites, or they could be hypoperfused with cold sweats, cold clammy skin, dizziness, oliguria, narrow pulse pressure. The worst ones, of course, are the cold and wet ones. Those are the ones with the highest mortality. And therefore, when we actually address cardiogenic shock and STEMI, we need to understand that the systolic pressures are fine. Then, of course, we have the options of diuretics and vasodilators because these are not cold and wet patients. The cold and wet patients, we may consider vasopressors and inotropes, but actually that's the patients we start thinking of mechanical circulatory support. Now, we must remember that the earlier we get in with mechanical circulatory support, the better it is for the patient, because cardiogenic shock is a spiral. It's a downward spiral. We need to understand that low cardiac output relates to poor end organ perfusion, poor coronary perfusion, onset of ischemia, further end organ damage, progressive myocardial dysfunction, proceeding to death. And we all have seen this. Patients continue to get lactic acidosis, they get worse and worse, they have a renal shutdown, they have hypotension, they have ischemic symptoms, and gradually the spiral is very difficult to get out of. And we need to reverse the spiral very early on. And that's the whole reason for understanding the pathways to mechanical circulatory support to enable myocardial recovery. Now, I must emphasize right in the beginning, if you really, I think I would urge you all to go through these two documents, which I'm going to show you right here. The SCI Clinical Expert Consensus on Classification of Cardiogenic Shock, which is very important to define which stage the patient is and therefore define his subsequent therapy, especially with mechanical circulatory support. And truly hot off the press from the American Heart Association this year is the invasive management of acute myocardial infarction complicated by cardiogenic shock, and a kind of important document to understand and go through. I think I won't go through this algorithmic approach for an acute myocardial infarction patient complicated by cardiogenic shock, but just to let you know that the moment the inotropes start getting increased and the patient does not have a mechanical complication, it therefore means that we've got to start considering mechanical circulatory support. And the mechanical circulatory support and choice is dependent upon, we must remember that it's a teamwork, there is experience involved into it, persistent hemodynamic and electrical respiratory instability, despite initial measures, which portend to mechanical circulatory support. High-risk coronary anatomy is another one, and of course, severe LV dysfunction. Of course, if we have a low level of operator or team institutional experience with the device, anatomy is prohibited, then of course we have another options in our mind. But revascularization as fast as possible is a must. Just want to tell you about the slide on the left side, that the more we increase the vasopressors or inotropes, the worse is the outcome of the patients. And that's been clearly demonstrated well in the past. Of course, we now actually do emphasize that lactates are an important measure of prognosis. And actually, if And the second thing is a great emphasis on cardiac power output, which is measured in watts, but it's actually a derivative of cardiac output and mean arterial pressures. Now, we know that if lactate starts increasing and goes beyond a particular level, you can actually have a major mortality with cardiogenic shock following an MI. And these two factors are closely watched in every patient who goes through this. And that's why I think we've got to start emphasizing in those two documents what has come through is our clear watchful eye on when to introduce mechanical circulatory support. By the way, I just want to say that there are 4 types of percutaneous short-term mechanically circulatory supports, which are, I would say, 3 in our hands: intra-aortic balloon pump, impeller, and ECMO. Tandem heart is rarely used in our country, so let's just dwell on the remaining 3. We well realize that intra-aortic balloon pump is a weak percutaneous mechanical circulatory support. It does decrease afterload, it decreases myocardial oxygen consumption, but provides a very small amount of cardiac output to the tune of 1 to 2, less than 0 to 1 liters a minute. On the other hand, we need to understand that impeller decreases filling pressures, decreases LV wall stress, LV work, myocardial oxygen consumption is decreased, and provides anywhere from 3.5 liters with an impeller CP to a 5 liters of flow per minute with the impeller 5. ECMO is an extremely valuable tool, but we must understand that it's non-physiological. While it supports oxygenation and while it can actually support the heart, it increases preload, it increases afterload, it increases LV stress, it increases LV work. It actually is working against the left ventricle muscle, though it provides tremendous support. In fact, in general terms, one would say, how do you actually then decide? Okay, of course, this is very important to understand that the easiest and the simplest and universally available and easily applicable is intra-aortic balloon pump. And of course, impeller is easy to use, is not too difficult to use, has still got a low learning curve, but is an expensive device. And ECMO, not so expensive device, is an extremely difficult device and non-physiological device to use. So clearly, ECMO is a survival issue. When the patients are in a cardiac arrest, ECMO resuscitation needs to be instituted. Intractable ventricular arrhythmias, practically saving for death is what ECMO is for. But if there is left ventricular dysfunction leading to hypertension and cardiogenic shock, impeller therapy could be the treatment of choice if finances do permit in our country. So here's what these provide. You can actually see the variety of the benefits of the various devices. Is impeller 3.5 is a good to go option for high-risk PCI and cardiogenic shock, and VA ECMO is the option to go for cardiac arrest requiring biventricular support. And perhaps this image gives you the fair example that if you've got right ventricular and left ventricular dysfunction, it only has to be a VA ECMO. If you've got a left ventricular dysfunction, impeller works essentially extremely well with a CP or a 5. If you have predominantly a right ventricular dysfunction, you can actually have a right ventricular impeller support as well. And of course, you can have a bi-impeller support as well for right and left ventricular dysfunction, but usually one goes for VA ECMO. Of course, if you've got a pure refractory respiratory failure, it's usually a VV ECMO. And I think this sums up very well the ways to go for a mechanical circulatory support. Just a word about intra-aortic balloon pump. It's been unfortunately shot down a bit too much. I think there is merit in intra-aortic balloon pump. We all have used it. We've all seen benefits of it. It was the IABP SHOCK 2 trial, which unfortunately caused the death knell of balloon as far as guidelines were concerned. And because it did not show any benefits at 30 days follow-up in cardiogenic shock patients compared to medical therapy, it was taken off the STEMI or cardiogenic shock guidelines and relegated to a level 3, to a 3, which was mean not to be used, is not routinely recommended for cardiogenic shock. But truly there was a fallacy. There are enough small data to suggest that non-randomized, but still there is randomized data to suggest if you use intra-aortic balloon pump prior to PCI, and remember in SHOCK 2 study, 95% of the people were treated with PCI, but the balloon pump was inserted after PCI. But if you insert it prior to PCI, you actually do have benefits in terms of survival. And that's been seen in a number of studies. Coming to Impella, an extremely useful device, has physiological benefits by increasing cardiac power output, increasing mean arterial pressures, and decreasing left ventricular end diastolic pressures and volumes. Also works on the microvascular system, increases coronary perfusion, and the beneficial balance of oxygen demand and supply. Of course, we've got a variety of Impellas at our disposal, and I think you'd perhaps remember the fact that the first case in Asia of Impella was myself in April 2007, and was in a patient with cardiogenic shock who was flown from Jaipur in a cardiogenic shock after STEMI, and then with an ejection fraction of 30%, arterial pressures of 77/52, and an Impella was inserted, and triple vessel revascularization was done in this patient on Impella, and then left main stenting was done, and this patient survived and went home after 10 days and lived for much longer. And we were the first ones to demonstrate a live case of Impella ever to the main arena of the TCT in 2007. Those are the first ever demonstrations of Impella to the TCT main arena as well as the cardiac center. And that was done at 10 o'clock at night from here. And it was said to be the most beautiful demonstration of treacherous cases, if you can call that a beautiful demonstration. Just take you through that we reintroduce Impella. And this is how we actually use in cardiogenic shock. Here's a 75-year-old diabetic male who comes with cardiogenic shock following STEMI, is on a ventilator, has cardiac arrhythmias, and then in a day or two starts recovering, but still is on heavy doses of inotropes. Obviously, such patients need immediate angiogram, and what this demonstrates is severe calcific triple vessel disease. The LAD has been the culprit lesion, but there's been LV dysfunction because his ejection fraction is 20%. And then you need to revascularize these patients immediately on table on the Impella, and you can see that rotational atherectomy of the LAD followed by stent implantation, rotational atherectomy of the circumflex followed by stent implantation, V-stenting of the left main LAD bifurcation is performed, and then following that, the RC is also rotablated and stented, and this patient lived and just got discharged in 10 days' time. We want to talk about just one more aspect, and that is you need ECMO, and you need to get better and better at ECMOs. And ECMO is no more a surgical domain. It's an interventional cardiology domain. You need to be able to do ECMOs in the cath lab crashes and in acute MI situations. For example, here's a lady who's exactly a day post thrombolytic therapy for RC infarction. She's previously had an LAD infarction. She comes onto the table, and this is a right coronary artery. And during this right coronary artery PCI, after a balloon inflation, you have a slow flow phenomenon, which is absolutely a no flow phenomenon. Patient starts sinking on the table. A stent is implanted, gets worse slow flow, and there is no way one can actually improve that microvascular circulation. At that stage, an aortic balloon pump is considered. The patient still has some pressures. Treatment is done. Patient is sent back to the CCU, has VT, cardioverted, bradycardia, TPI inserted, balloon pump inserted, CPR done, return of spontaneous circulation, and soon is in pulmonary edema. It's florid pulmonary edema. The FiO2s go to 100, PEEP of 14. She's hardly oxygenating. PaO2 is 45. This is the sort of patient who immediately needs to go onto ECMO, which is what we put on at 3:30. Following ECMO, her lactates, which has gone up to 12, start gradually coming down. But then you need to understand the management of ECMO. We've all got good at ECMO. Of course, it's led by my colleague, interventional cardiologist, but we all have actually got better and better at inserting and managing ECMOs, and shows LV dilatation, ejection fractions is 25 to 30%. The patient went into renal failure, was dialyzed. And then as we go on, we need to understand, yes, I'm going to finish. We need to understand that problems do come in. We had to convert into VAV ECMO. We also had to actually put an intra-aortic balloon pump to decrease afterload. But these are the solutions when one puts in ECMO that one has on top of the mind. And over a period of 4 days to 5 days, the patient gradually improved from that situation. This is that patient while she was on ECMO following a crash, following a STEMI in the cath lab. And this patient then recovered. After 72 hours, showed an improvement. Her acute kidney injury recovered. Her echo gradually improved to a 45% ejection fraction. She was gradually weaned off from a VAV ECMO to a VV ECMO, which was weaned off 2 days later. She was discharged 3 days after and continues to do well 3 years after this event. So no patient deserves to die without a careful throat-to-stomach circulatory support, especially cardiogenic shock following STEMI. I must emphasize, and you clearly need to develop STEMI teams in each of our centers who work together. And this is a team which constitutes multiple specialties for a teamwork to be able to save lives in this clearly devastating disease process, which has a mortality of 60 to 70% unless picked up early and unless treated efficiently. Thank you very much for your attention.
Well, thank you very much. Let me see if my slides work now. Well, good. So after this wonderful, thought-provoking lecture by Ashok Seth, who is a very good friend and very good teacher, I'm going to talk about something basics about cardiogenic shock. Because the guidelines of the management of cardiogenic shock have been changing, as the topic says, that ping pong in the guidelines. We know that cardiogenic shock represents basically an inability to heart to maintain effective cardiac output. It results in marked end organ perfusion deficiency, which leads to hypotension, tachycardia, vasoconstriction, pulmonary and systemic venous congestion, altered sensorium, acute liver or kidney injury, and lactic acidosis. Now, it is the commonest cause of cardiogenic shock is myocardial infarction, ventricular failure. But we should always remember that mechanical complications like a ventricular septal rupture or a mitral regurgitation because of mitral valve tearing, free wall rupture can also be associated with this. Then there are some non-infarct related causes of cardiogenic shock like myocarditis and decompensated heart failure, and sometimes in our country, severe long-standing valvular heart disease. The definitions of cardiogenic shock have been, variable, but one of the best definitions in which is accepted these days is the European Society of Cardiology Heart Failure Guidelines. Systolic blood pressure less than 90 millimeters, associated with clinical signs of hypoperfusion in the form of cold extremities, oliguria, and then lab manifestations of hypoperfusion in the sense metabolic acidosis, elevated lactate, and elevated creatinine. But one of the most accepted and the best and most logical classification is from SCAI, which came in 2009, which classifies post-myocardial infarction states into stage A. That is, the patient had an infarction, is at risk, but has no sign of any lack of perfusion, and one has to be watchful so that the person doesn't go into cardiogenic shock. B is the beginning. That means a patient who has clinical evidence of relative hypotension, tachycardia without hypoperfusion. So this is the sign again where the chances of averting or aborting cardiogenic shock is high. C means classical cardiogenic shock has set in. Patient has manifestations of hypoperfusion and has got requires interventions, inotropes, pressor support, or maybe ECMO, as Ashok was saying, and is, revascularization has to be done. And these patients typically present with relative hypotension. D, unfortunately, is a deteriorating situation at a patient who is similar to category C, but is getting worse in spite of your aggressive management. And E means extremis. That means the patient is confused, circulatory collapse, and has multiple organ deficiency. And this is the stage where, one has to be extremely aggressive, very high mortality, and a team approach with the ECMO and other kinds of supports are necessary. Now, cardiogenic shock over the period of time, as you can see, that overall incidence has come down to around 8% after myocardial infarction. At the same time, cardiogenic shock developing at admission has gone up because of patients presenting reperfused early, and then still cardiogenic shock comes in some of them, and this is about 6%. And cardiogenic shock developing during the hospitalization has significantly come down because of early reperfusion and very good, watchful expectancy in managing these patients. And the mortality rate of cardiogenic shock, unfortunately, as you can see, has not become very significantly improved, whatever way it comes, whether the patient comes with cardiogenic shock or develops cardiogenic shock in hospital, mortality is closely hovering around 40 to 45% in spite of many, many efforts. Although the very aggressive treatment which Ashok was discussing is going to certainly reduce it, provided it is available in many centers. That is the reason one really wants to shift these patients to centers which are adept in managing cardiogenic shock with all the complications. And as you know, the treatment of cardiogenic shock, the mortality has been close to 50%, but recently with the aggressive usage, the survival has increased to about 75 to 77%. Now, early revascularization in acute myocardial infarction complicated by cardiogenic shock is very important. And as you can see in this particular very important study, the early mortality, 30-day mortality is not very different except in the relatively younger people, but 6-month mortality is significantly down in these patients, whether they are less than 75 or more than 75. And this benefit persists at 12 months and even at 6 years, which Thiele's long-term studies have shown. So this has become a class 1B recommendation in 2019 guidelines. Revascularization cardiogenic shock, if the delay is there, this is a detrimental outcome. Immediate transfer to a tertiary care facility is very important. As has been discussed in one of the previous lectures, fibrinolytic therapy has no solid data, but if there is no way out, then thrombolysis, and then if you have a balloon pump or something to stabilize, but the patient has to be shifted to a higher center. One comes to revascularization with multivessel disease in cardiogenic shock. And as we know, 70 to 80% of patients have multivessel disease. And we know that multivessel disease has higher mortality. Current guidelines recommend early PCI depending upon the anatomy, whether PCI or bypass surgery, depending upon whether he or she can be revascularized. Until recently, the recommendations were complete revascularization, which seemed to be logical, but culprit shock study changed this view. And these are the culprit shock studies, again, by Thiele, who has the maximum published work and experience in this field. What are the pros for complete revascularization? That it leads to better improvement of the jeopardized myocardium, improvement in the clinical outcome. But what are the downsides? Immediate multivessel intervention may lead to more ischemia. You're handling those vessels which are not actually involved in the cardiogenic shock, and you're giving a lot of volume, contrast, and leading them into very often renal impairments, acute kidney injury. Now, significant clinical benefit of culprit lesion only strategy has been shown in the culprit shock study with a reduction in the primary endpoint of 30 days mortality or renal replacement therapy, with 46% with the culprit lesion only versus 55% if you do immediate multivessel angioplasty. So there's at least a 6% improvement if you handle only the culprit vessel. It is mainly driven by absolute 8.2% reduction in 30-day mortality. And these benefits are consistent and sustained at 1 year with an absolute reduction in the mortality. So routine immediate multivessel PCI in cardiogenic shock should not be done, and it is a class 3 indication. Now, type of revascularization, it depends upon what kind can be done. At least 1/3 of the patients in the shock trials underwent bypass surgery, but with improvements in the techniques of angioplasty and support systems, bypass surgery is currently performed in less than 5% patients in the trials and registry. Now, access, if possible, a radial access, but I think it doesn't matter so much when you have to, support the patient, put a balloon pump or ECMO and other things, then you obviously use multiple sites of entry, and then groins also come in. But in culprit shock, radial access was used only in 19% of patients. What about intra-aortic balloon pump support? It has already been discussed by Ashok that this particular study, actually Thiele's study, suggested that it has no role. And it was also suggested by other studies that, in the beginning when it came, it did show some promise, but most of the trials showed that the benefit is minimal. But at the same time, as you know, we have this facility available easier than the other high-end therapies. So I don't think it is gone as a therapy. It should be used. And then after stabilizing to whatever extent you can stabilize, because it does reduce afterload, it does improve the coronary perfusion, then the patient should be shifted to the higher center so that the patient is shifted without much acidosis and in a better shape. And this is the algorithm which I think Ashok already showed, that when a patient comes with acute myocardial infarction, patient has stable BP, stable perfusion, revascularized, and you minimize the chance of getting a shock. But if the patient comes with hypotension, he has got low BP, he has got malperfusion, consider vasopressors and inotropes. But if the primary problem is hypoxia and acidosis, consider intubation. Diagnose the cause of shock immediately, define the hemodynamic, which is very important, left heart study, right heart study, and echo. If there are mechanical complications, a surgical consult immediately, and then consider early mechanical cardiac support, which already Ashok has discussed in great detail, that factors that favor early mechanical support is persistent hemodynamic impairment, high risk coronary anatomy, and severe ventricular dysfunction. But there has to be a caution, but there's a low level of operator experience, institution is not experienced. This is not going to help because this needs a strong and institutional support and a team. Revascularization of the culprit vessel obviously has to be done. And then once the patient has been stabilized, whatever way you have treated, you should be shifted to the This has already been discussed that if there's basically a left ventricular problem, Impella. If there's a right ventricular problem or a biventricular problem, you can consider Impella in both the sides and also ECMO. Refractory respiratory failure, again, we know ECMO. So let me give you some take-home message. Acute myocardial infarction and cardiogenic shock is a complex clinical entity. It remains prevalent and is a major cause of death after myocardial infarction. Early invasive management by way of revascularization influences the outcome and the mortality. Optimization of the therapy, multidisciplinary team, inter-hospital transfers to places where the management can be, done efficiently with a team is always to be preferred, and one doesn't have to stand on the prestige that I will not shift a patient, I will manage himself, because management needs a lot of teamwork and experience with the support devices. Approaches to multi-vessel coronary artery disease include the inertia, include the criteria for selected application and timing of multi-vessel PCI. Culprit vessel PCI is always better than handling all the vessels in this particular situation. And application of targeted temperature management in patients who present with resuscitatory cardiac arrest include optimal management. So management strategies should also always include bleeding and vascular complications, which can ruin a procedure after working very hard. It's a pity that if the patient is lost because of excess site, exsanguination and other things. So anticoagulant management, parameters for monitoring the mechanical support devices, and interplay with vasoactive drugs therapies is extremely important. And this cannot be taken lightly. So thank you very much for a patient hearing, and sorry for causing some delay in the proceedings of the program. Thank you very much.
Thank you, sir, for an excellent disposition, and we had some 4 fantastic talks on STEMI in cardiogenic shock, the most difficult of subjects to handle in clinical practice. And I wish as I would that we could have continued to have some further discussions on these all four very pressing issues. Because of paucity of time, I'm forced to move on to our next session. I would like to thank all our speakers and chairpersons for being there with us during the session. And I would now like to move ahead to an equally important session, the clinical conundrums in STEMI, the master class 1. And we have some very eminent speakers and a very eminent chairperson panel. And I would like to invite our chairpersons, Dr. Bhalachandra, Dr. Banerjee, Dr. Datta, Dr. Bhandari, and Dr. K. Professor K.C. Goswami to take over the proceedings.
Yeah, good evening. I think it's a very heavyweight session because it is chaired by the past president, the president-elect, the president of the Delhi chapter of CSI, and of the speaker is no less than our current president. So it's a very, very important session. So without wasting much time, let me go to the first speaker, that is Dr. Shantanu Guha for the heart failure post-STEMI. It's a very important topic because even though the cases may be less, but still how to approach this at the. Dr. Shantanu is here?
Yeah, I'm there. Just let me start sharing my screen. Mr. Chairperson, sir, and dear colleagues. At the beginning, let us go to first to the incidence of the heart failure post-STEMI. In the GRACE registry, it was seen that around 13% had heart failure on admission, another nearly 6% had heart failure during hospital stay. The Spencer et al. Showed that it is around 20% at admission, another 8 to 9% had heart failure during the hospital stay. But subsequently, beyond 2000 or 2001, there is a decrease in the heart failure incidence and mortality as shown in the Danish study and the MIDA study. This slide shows a similar thing from 2004 onwards. There is a decrease in the incidence of heart failure complicating STEMI. What are the risk factors? Age, female sex, history of previous MI, hypertension, diabetes, low GFR, increased heart rate, and atrial fibrillation are the important risk factors for that. Looking at the pathophysiology, myocardial injury produces early remodeling, late remodeling, and neurohumoral activation, activating sympathetic nervous system and RAS. Early remodeling leads to LV dilatation and wall thinning. Late remodeling leads to scar formation, and ultimately, in totality, leads to the remodeling of the myocardium. Risk of CV death and heart failure, it decreases as the time passes. MI is the strongest risk factor for heart failure. It triggers immediate myocardial necrosis, prompt reactive mechanism that lead to heart failure development and progression. The size of the MI and the timing of revascularization determine the risk of heart failure and mortality. And the highest risk is in the immediate post-MI phase. And as the time passes, the risk decreases. This is a very good slide from Jack, where in the PCI era, they have divided those who remodeled into early remodeler, midterm remodeler, and late remodeler, and they compared it with those who did not have any remodeling. There is no difference in survival. But the heart failure hospitalization is more in those who had a remodeling than those who did not have. So LV remodeling is not the primary factor which determines the prognosis. It is the systolic function as well as the improvement thereof is known to be the most important predictor of survival. This is an algorithm showing the diagnosis and assessment of heart failure after MI. With the symptoms of heart failure, look for the history of MI or with definite imaging evidence. The physical examination shows features of heart failure. Look at the abnormal ECG and the chest X-ray showing pulmonary congestion. look at the elevated natriuretic peptides if it is there, and then look at the echo, abnormal cardiac structure and function. If it is there, then look for the triggers and classify them into these three groups and initiate treatment. One thing what we must remember is the failure per se can alter the absorption, distribution, metabolism, and the excretion of the drugs. Absorption because of the gut edema and decreased GI motility due to hypoperfusion. Distribution of the drugs gets altered in plasma proteins because due to the hepatic impairment and increased volume distribution. Metabolism in the hepatic congestion may lead to decreased metabolism and higher plasma levels of hepatically metabolized drugs, and renal and hepatic impairment may lead to alteration in the excretion. The time-dependent therapies for post-MI heart failure at the very beginning, the immediate target should be reperfusion or primary PCI in STEMI patients. Early revascularization is the only way by which you can improve the survival in patients with cardiogenic shock. Early initiation of the ACE inhibitor during the first 24 hours is mandatory in stable patients. 40% of the survival benefit is conferred in the first 24 hours. Avoid beta blockers for the first 24 hours in patients with ongoing heart failure because of the risk of increasing failure or cardiogenic shock. But reevaluate the eligibility of the beta blocker therapy throughout the hospitalization and initiate them. Aldosterone antagonists should be started within the first 7 days of index MI because the benefit is accrued if it is instituted within the first 7 days. It is a time-dependent fashion. It is also critical to titrate doses of medications, including the ACE inhibitors and beta blockers, to optimal levels in the post-discharge period. This slide shows almost a similar thing. Beta blockers early within 24 hours of high dose beta blocker is harmful and should be avoided for MI patients in heart failure or high risk of cardiogenic shock. Defined as age above 70, SBP below 120, sinus tachycardia more than 120, and heart rate below 60. ACI should be administered within the first 24 hours, as I've already said, and we get the information from SAVE-AIR and the TRACE trials. MRA should be initiated within the first 7 days. We get the information from FSS and Albatros. Early revascularization as soon as possible is the only therapy proven to reduce mortality in MI patients presenting with cardiogenic shock. In the setting of MI, routine use of IABP is not indicated to reduce infarct size or to manage cardiogenic shock, as has been discussed just before me. Coming to the relief of chest pain, very important thing is routine use of opiates is not recommended like the earlier recommendations. It has been given a class 3 recommendation because it has been shown to increase mortality. Nitrates are recommended in patients with symptoms of heart failure and SBP above 90 to improve symptoms, and oxygen is indicated in those with pulmonary edema and saturation below 90 to maintain above 95. Regarding ACE inhibitor, I have already said the survival benefit of ACE inhibitors. ACE inhibitors, and if not tolerated, ARB is indicated as soon as hemodynamically stable for all patients with evidence of EF below 40 and heart failure to reduce risk of hospitalization and death. Valsartan is an alternative to ACE inhibitors in patients who have clinical signs of heart failure and or EF below 40%, particularly in patients who do not tolerate ACE inhibitors. This is a slide showing the survival benefit in SAFE, TRACE, and the AR trial and compared it with the Valiant. Valsartan preserves 99.6% of the mortality benefit of captopril. And MRA is recommended in patients with heart failure and EF below 40 with no severe renal failure or hyperkalemia to reduce the risk of cardiovascular hospitalization and death. Know it from Albatros and FSS trial, mostly from the FSS trial. Beta blockers is recommended in patients with EA below 40 and or heart failure after stabilization to reduce the risk of death, recurrent MI, or hospitalization for heart failure. Other beneficial drugs like diuretics, loop diuretics are recommended in patients with acute heart failure with symptoms and signs of fluid overload to improve symptoms. If they are not only effective, they may be combined with thiazide type diuretics. Antithrombotics post-MI DAPT is recommended and is usually given as per the institutional protocol. A Chinese consensus study has showed that ivabradine should be considered in patients, in symptomatic patients with EF below 35 in sinus rhythm and a resting rate above 70 in post-MI patients who could not tolerate beta blockers. Non-invasive positive pressure ventilation like CPAP or BiPAP should be considered in patients with respiratory distress, that is rate above 25 and saturation below 90 without hypotension. Intubation is indicated in patients with respiratory failure or exhaustion leading to hypoxemia, hypercapnia, or acidosis, and if non-invasive ventilation is not tolerated. Mechanical circulatory support short-term has been very well dealt by Ashok. Short-term MCS should be considered in patients with cardiogenic shock as bridge to recovery, bridge to decision, or bridge to bridge. Further indication include treatment of the cause of cardiogenic shock and long-term MCS or transplantation. IIBP is not routinely recommended in post-MI cardiogenic shock. This is a very important thing, management of hyperglycemia. We should keep the blood sugar below 200 and aggressively lower it. It seems reasonable to avoid thiazolidine, DIANs, and DPP-4 inhibitors. Decisions regarding metformin should be individualized, and it is reasonable to continue SGLT2 inhibitors and GLP-1 agonists. Regarding ARNI and SGLT2 inhibitors, Paradise MI trial compared ARNI with ramipril in patients with heart failure or high risk for that. There is no difference in the primary endpoint or in the components of the primary endpoint between the two arms. So ARNI did not result in a significantly lower rate of CV death, heart failure, hospitalization, or heart failure requiring treatment in the OPD when compared with ramipril. The safety and tolerability of ARNI in this AMI population was comparable to that of ACE inhibitors. Regarding SGLT2 inhibitors, there are some very important trials like IMPACT MI trial with empagliflozin and DAPA MI trial with dapagliflozin in heart failure patients post-MI are those who are at high risk for heart failure, but the results of these trials are awaited, so we cannot say definitely about them. These are the algorithms I am skipping for the want of time. In patients with acute heart failure, pulmonary edema, and cardiogenic shock, which has been discussed. There are some upcoming therapies for the prevention of myocardial remodeling in AMI. Device therapy like LV pacing, peri-infarct LV pacing, biventricular pacing, or no pacing has been compared for 18 months in patients with a large MI and failure. There was no difference in the outcome. MitraClip has been tried in severe acute MR patients post-MI. Intracoronary deployment of bioabsorbable cardiac matrix 2 to 5 days after STEMI, after deperfusion in subjects with large MI, did not reduce adverse LV remodeling or cardiac events. There are some biological therapy which has been tried, particularly stromal cell-derived factor 1 alpha and CXCR for axis activation. It creates a homing gradient which leads to proliferation of the stem cells and reduces the scar burden. This has been tried as a therapeutic measure in some animal experiments and early human experiments, but results are all awaited. Thank you very much for your patient hearing. And this is the first medical college in Asia. This is the first building established in 1835, where fortunately I do work. Thank you very much.
Thank you, Dr. Shantanu. Other speakers, other chairpersons would like to say something, or we go to the next speaker? Dr. Satyawat is ready with the next topic. So Dr. Datta is here. Would like to say something? No. Okay. Dr. Satyawat, please.
Am I audible?
You're audible.
And is my screen?
Not yet, not yet. Yes.
Are the slides seen?
Yes.
Okay. Good evening, friends. What I'm going to do in the next 10 to 11 minutes is speak on a fascinating topic, antithrombotic and atherothrombotic. Will DOACs ever have a role? We all know atherosclerosis is a process which passes through two phases, a stable phase and an unstable phase. The stable phase, also called as a chronic coronary artery disease, is usually the one where for secondary prevention we use antiplatelet drugs. When the atherosclerosis becomes atherothrombosis or atheroembolism, what we get is an occlusion of the coronary artery, and there is a acute coronary syndrome, either ST elevation or non-ST elevation acute coronary syndrome. This is the pathway of the plaque rupture, and we are all aware that in the process of plaque rupture, there is a major role which platelets play. There is aggregation of the platelets, there is activation of the platelets, and we have been using for decades the antiplatelet therapy. When there is a rupture of the plaque, there is also activation of the prothrombin and the thrombin pathway, which contributes to fibrinogen and fibrin-rich thrombus. What we have been doing for years has been attacking the platelet pathway. There is some anecdotal evidence using vitamin K antagonists of our tackling the thrombin pathway also, but let's see what is new in this field. Now, this is the platelet activation and the various drugs and the various mechanisms by which these drugs act. We all are familiar with our age-old aspirin, which acts by inhibition of the thromboxane A2. We have all P2, Y12 inhibitors, clopidogrel, prasugrel, ticagrelor, and also the final pathway of the platelets, GP2A inhibitors. What is being more and more studied in preventing atherothrombosis is the pathway of the thrombin, and the drugs with which we are familiar, the NOACs or the DOACs, Debigan, Apixaban, Rivaroxaban, and Edoxaban, and of course, the warfarin. Now, when we are speaking in terms of preventing atherothrombosis, we are looking at the secondary prevention of coronary artery disease, either the stable ischemic heart disease or acute coronary syndromes. And these can be the type of patients which we are treating in our day-to-day thing. We can have a stable patient of coronary artery disease, which is treated by non-invasive or invasive modality. We can have an acute coronary syndrome, which is treated either by invasive or non-invasive this thing. we can have stable coronary artery disease with atrial fibrillation and acute coronary syndrome with atrial fibrillation. So how do we prevent atherothrombosis in these clinical situations? The time will not permit me to go into each and every subclass, but let me give some broad points. Let me first deal with an acute coronary syndrome. Despite using optimal medical management with or without revascularization, the MACE rates in these big trials, the CURE trial or Prospect ACS trial or Plateau trial, has been high. That means despite using good antiplatelet, optimal medical management and revascularization, still there are some patients who keep getting the major coronary events. That means there is some gap in what we are doing. This is what is called as a new concept of dual pathway inhibition strategy, where you attack the coagulation cascade by DOACs, direct oral anticoagulants, or and the platelets by the antiplatelet therapy. And there has been several trials with a meta-analysis available of almost 30,000 in different DOACs, different agents have been used in different trials. And the important one has been Atlas ACS STEMI 51, in which rivaroxaban was used. Apris was a apixaban trial, and different radium trial, ruby trial with different agents. And the meta-analysis or the message from these trials was that there is a favorable data in terms of reducing ischemic events in STEMI. In non-STEMI, the data was not that strong, and there is an increased bleeding whenever you are using a combination of DOAC and antiplatelet. And there is a thrombin paradox. They work as anticoagulants at low dose and they become procoagulant, there is a high dose. So there is what is very important, and what I will be dwelling subsequently is that you have to use a proper dose. And these are the various agents which we are all familiar and where they act in the coagulation pathway. The rivaroxaban, apixaban, and edoxaban act in the conversion of 10A to 2, whereas dabigatran at factor 2A. Now, when we look at the treatment strategy in acute coronary syndrome, and what we have seen that when we have used antiplatelets, either aspirin clopidogrel or aspirin ticlopridine, there has been reduction of events and there has been some increase in the bleeding. These two important trials, Atlas ACS2, in different doses, 5 milligram twice a day and 2.5 milligram twice a day, it was seen that there was a reduction in the ischemic events, but there was an increase in the bleeding. And this is the data from the Atlas ACS2 trial, which in crux tells that if there is a patient with an acute coronary syndrome, and on top of the DAP therapy, if you add a DOAC, in this trial, it was rivaroxaban 2.5 or 5 milligram, there will be benefit in reducing the ischemic events, but there will be increase in the bleeding. Now, there was more bleeding in the higher dose and there was less bleeding in the lower dose. So on the basis of this trial, the European Society did approve the use of DOACs in patients following acute coronary syndrome in those patients where there was a low bleeding risk. Now, when we look at the patients of post-acute coronary syndrome and we are trying to give them therapy, from the point of view of preventing atherothrombosis. I think this slide gives the crux that we have to look at two factors. What is the thrombotic risk of the individual and what is the bleeding risk? And we have to individualize the therapy depending on these two factors. If a patient is having a high thrombotic risk and the bleeding risk is low, then after that, then along with the dual antiplatelet low dose rivaroxaban 2.5 milligram can be added in these patients. Even one can consider escalating the dual antiplatelet therapy. Whereas those patients where there is a low thrombotic risk and low bleeding risk, there is no benefit of adding rivaroxaban or any DOAC in these patients. In these patients should be continued on the dual antiplatelet therapy. Those patients where there is a high thrombotic and the high bleeding risk, we will have to downgrade the duration for which the dual antiplatelet therapy is to be given. So individualization of the therapy depending on the bleeding and the thrombotic risk is the key message which I like to give. And just a little bit about the stable ischemic heart disease. Again, when we look at all the trials, the Courage trial, Freedom, Pegasus, ischemia, the MACE rates in patients with ischemic stable coronary artery disease, despite optimal management and revascularization, have been in the range of 2 to 5%. That means there is something more which we can do in terms of therapy for preventing the atherothrombotic events. And this is a summary from the various trials. When we have been using the antiplatelets, aspirin propylogrel or aspirin ticlopridine, we have been able to reduce the MACE rates at the cost of some increase in the bleeding. And here comes a very important trial. I will be talking about this in a little bit of detail, called as a COMPASS trial, in which rivaroxaban was added, was studied in 2 different doses with aspirin and without aspirin. And this is the COMPASS trial. I won't go into too much of details. This is a trial which involved almost 27,000 patients in 33 countries, double-blind, double-dummy, in patients who have got a stable vascular disease. And the inclusion criteria was the one where patients with documented atherosclerosis, either in 2 vascular beds or having 2 major risk factors like diabetes, non-lacunar ischemic strokes, were chosen. And there were 3 strategies. In one was rivaroxaban 5 milligram twice a dose. In one arm was only aspirin, and in the third arm was rivaroxaban in the reduced doses 2.5 milligram BD with 100 milligram of aspirin. And the primary endpoint was the usual composite of cardiovascular death, stroke, and MI. And the secondary endpoints were composite of stroke, myocardial infarction, acute limb ischemia. I'll show in the next slide a very limited results of this trial. The major flaw of this trial was that this trial was prematurely terminated, and that might have magnified the good results. However, the main result was that the primary endpoint was lower in the arm where there was low dose rivaroxaban was used along with 100 milligram of aspirin with mortality benefits. And this 2.5 milligram twice a day is called as a vascular protection dose in many of the articles. And when we look at the benefits of using rivaroxaban with aspirin, one can see that if we look at various different groups, patients having polyvascular disease, patients having renal dysfunction, patients having heart failure, diabetes, in almost all the groups, the group where there was a rivaroxaban plus aspirin, the number of events were reduced, thereby telling that there is a tremendous benefit of adding this in those patients who are having a high risk stable coronary artery disease. And this is where I will finally summarize my approach to patients who are having a stable coronary artery disease for atherothrombosis. Here again, the same thing. Look at the patient's ischemic risk and look at the patient's high bleeding risk. Those patients who have a high ischemic risk, like multiple vascular territories being involved, patient having coronary artery disease and a peripheral arterial disease, patient having a multivessel disease, patient having a recurrent infarction, patients having undergone multiple times PCI, the patients who are having an end-stage renal disease. These are the patients who have got a high ischemic this thing. Now, in these, there can be benefit of adding rivaroxaban to aspirin. If the patient is having a high bleeding risk, and again, many of the factors are well known to us, then we should restrict to using aspirin and not adding rivaroxaban in patients with stable coronary artery disease. So I will end here telling that there is a new paradigm is developing of using newer oral anticoagulants along with antiplatelets in patients with acute coronary artery disease and in patients of stable ischemic heart disease. And of course, the key remains is assessing the patient's ischemic and the bleeding risk. Thank you very much.
Thank you, Dr. Satyavar. Dr. Goswami is here. You'd like to say something, Dr. Goswami? No? Okay. So we will go to the our president, Dr. Mohan, and he's got a very interesting talk on the SGLT2 in the post-MI secondary prevention. Dr. Mohan.
Will somebody permit me to share the screen? I'm not being permitted. Okay. Are you able to see it?
Yeah.
Thank you.
Yes, we can see your screen, sir.
Thank you, Nitish, and respected chairpersons. Before I just go into my subject proper, I just wanted to take you back to some fundamental things like the definition of a secondary prevention usually refers to patient who suffered a previous SQ event. Now, this distinction between the primary and the secondary prevention in diabetes is no longer reported in the European Society of Cardiology guidelines on diabetes. And if you look at the EASD, you could see that they have just done what is that. They just graded the risk, basically because we know that the diabetes has even otherwise a proclivity to develop the disease. So that is just what I wanted to say. All of us were captivated when the SGLT2 inhibitors, and of course, to an extent, the GLP-1 receptor agonist came in a big way for the last 5, 6, or 7 years, and showed us the excellent benefits of in cardiology and, of course, in nephrology. And the phenomenal improvements in heart failure hospitalization, prevention of heart failure instances, and of course, in renal, the deterioration of the renal status was, everybody agreed to that. But when it comes to the MACE reduction, that's an area where now we maybe are on a little sandy grounds because the figures doesn't match to something that you have seen in renal disease reduction or heart failure reduction. Of course, now we have every day you see the mechanistics of SGLT2 on heart and the vasculature. And of course, every other organ is something which every one of you are aware of. And I will not go into detail because of paucity of time. But this is essential, telling that we have a prothrombotic milieu in diabetes and in all other instances of CKD or hypertension with a heightened inflammatory milieu again, which results in endothelial dysfunction. And we have, in fact, a prothrombotic status in this. I was mentioning about the heart failure part and the SGLT2 role. Phenomenal. You look at every one of those SGLT2 trials, right from empagliflozin to canagliflozin to dapagliflozin to vertugliflozin to finally sotagliflozin. See, when it comes to heart failure, there is no questions asked about its efficacy, saying that we have the best evidences available. That is also applicable, that is also seen in the renal outcomes. I have, this was taken possibly a little earlier before the DAPA kidney study. I'm sorry about that. But here again, you could see the hazard ratios. See, the outcomes, the kidney composite outcome, whatever you take the parameters, see, whether it is the deterioration to develop, going for a RRT or a transplant, renal death, every areas of renal deterioration has been tremendously improved by all the gliflozin, especially we have more data possibly with CANA. See, but look at this. When it comes to the MACE reduction, that is not showing the similar benefits. You could see here, especially now, this is also related to the underlying renal function. If somebody has a very good renal function, you have a 9% MACE reduction. If somebody has a GFR of less than 60, you may have a better 23% risk reduction. This is also seen, this is correlated at least in one of the sub-studies of age. If you are less than 65, then your MACE reduction is something like 9%. But when you are, if you are more than 65, of course, you have a better chance of a MACE reduction. So again, this is a very, busy slide, I will say, but then I just wanted to tell you about all the gliflozin trials and tell you that in most of them, the MACE reduction is reported. See, I do agree that there are some dichotomies from cardiorenal, for example, ertugliflozin and sotagliflozin did not give us the expected renal benefits, but that these are something which we will discuss on some other time. I just will take you to some of the data which is already available. So this began with the EMPEROR, and you could see the phenomenal reduction in heart failure hospitalization and the nephropathy reduction. But here again, the MACE was also ran. We have canagliflozin, and this is just a experimental study which showed that when you give canagliflozin in the setting of a myocardial infarction in rats, they do very well. They have improved the LV dysfunction, and remodeling happens to the good. The DAPA study, the DAPA Declare MI, and also the DAPA also study also showed that there is significant MACE reduction, and as you could see that those with a prior MI benefited much better, unlike those who had no prior. I'm saying that the secondary prevention is the watchword. But again, I caution you that then in diabetic subsets of people, we don't need to be much worried about this particular differentiation. The reduction was there. As I said, this was basically related to the renal dysfunction, underlying renal status, and also to the age group. This is something which I have already said. The benefits of dapagliflozin reducing MI was very manifest when in the initial part of the period, the 12 months part. So basically, if you take that, and most importantly, as I said, now the renal and the heart failure benefits are phenomenal. By the MACE reduction is also there, but it is not something which you and me will possibly highlight. possibly I have talked about this in every one of those trials. We have seen ertugliflozin and sotagliflozin, both of the molecules are not available for us, but that also has shown us that the MACE reduction is there, but may not be at the extent of that we have seen for the the renal benefits and the heart failure benefits. Now let us look at some of the data of SGLT2 use in acute myocardial infarction. I should caution you that we don't have too much data, but then there are data coming up. We have an embody trial which shows that which showed a change from baseline to in the late potentials, showing that there may be advantages in diminishing the depolarization. And this again tells you that in patients with acute myocardial infarction and diabetic subset, most of the studies of gliflozin, when it comes to MACE reduction studies, are done in diabetics, unlike in heart failure or renal part where you have non-diabetics also in the group. Here, MACE reduction studies, basically secondary prevention studies, are confined to basically in diabetic subsets. So this study has shown that we have some improvement in the sympathetic activity and the parasympathetic activity. We have another one coming up called the ME trial, which will test empagliflozin in patients with acute myocardial infarction, which will of course get also some non-diabetic patient about cardiac remodeling. But these are studies which will show us in late, we don't know the results yet, but we have sufficient data which showed that we have a reduction in the left atrial volume, left ventricular mass volume, improvement in the diastolic function. This is another one which is going to again, which has just started showing an improvement. This is another of the data and experimental data in rats, which showed that when compared with metformin, empagliflozin improved the systolic and diastolic functions in diabetic rats. So we have a quite lot of information in the anvil. We don't have a definite recommendation for the use of SGLT2 inhibitors for secondary prevention, except from certain corners. If you look at the mechanistics, you could possibly propose many mechanisms, and I have no intention to bore you. You have heard all these mechanisms of cardioprotection, renoprotection, and time will not permit me to detail each one of them. But then these are something which we have been listening for the last 5 years. This looks much more interesting, which shows you that in setting up an acute myocardial infarction, SGLT2 can theoretically definitely improve by the fuel kinetics and other very many tongue twisting names here, but it can improve cardiac dysfunction and possibly will become a winner in the regular secondary prevention approach. So in our comprehensive cardiovascular preventive approach, apart from all these, exercise, blood pressure control, lipid control, glucose control, and ACE-ARB, we are possibly going to see soon SGLT2 and possibly GLP2 receptor antagonists. Here again, now we have the data from, this was a recent study from Gugliano, which again has shown you, look at that, in all these conventional studies, and we have evidences for the importance of decreasing MACE reduction. I told about this is not from ACCHA or ESC, but a national case period clinical practice guideline, which also says that this is more attuned with the diabetic population, not for the cardiology folks. That's why we are not very familiar with this KP clinical practice guideline. They have recommended that SGLT2 are recommended for diabetic with established ASCVD for secondary prevention. Of course, for prevention of heart failure, for prevention of renal dysfunction. There is no questions about that. So thank you very much for your kind attention.
In the interest of time, we will have to conclude the session, but 3 fantastic lectures which have added on a lot of things for us: heart failure, post PTCA, NOACs, and so thank all the speakers. And I think we're not too much behind time, so I will restore Nitish Naik to normal sinus rhythm. He must be having palpitations. They're going behind. And thank you very much for this session.
Thank you, sir, and thank you, Dr. Mohan, for taking us through the journey of SGLT2 inhibitors to their current day status. And as we will now move on to the next session, and this session is Learn with the Masters. And we have 2 very eminent speakers from overseas who will be taking us to very good, eminent Indians settled abroad. And I would like to begin with to invite our chairpersons, Dr. Ashok Seth, Dr. D.S. Gambhir, Dr. H.K. Chopra, Dr. Manutosh Panja, Dr. Mohan, and Dr. Samuel Matthew to begin the session. And I see Dr. Samuel Matthews here, so I would request him to take over the proceedings.
Dr. Matthew, please.
Good evening, everybody. Sorry.
Dr. Mohan, maybe you can.
It was on mute.
Yes.
Good afternoon, good evening to all. I think wasting much time, we'll go and listen to people following the excellent lecture we heard from Mohan and go to Sipal, Bangalore.
Thank you very much, and thanks first of all inviting me, and it's great to see all of the familiar faces. Okay, so there it is. Okay, so I've been asked to give my thoughts on DAPT after PCI for STEMI, and first of all I want to start by saying that with a couple of the late breakers at ESC, it's not an easy situation for STEMI patients. I mean, for other patients, we have now almost gone into the mode of lower the duration of the shorter the duration of DAPT, that is better in other group of patients. So in terms of DAPT duration consideration, the way I see DAPT duration consideration is you have to balance between bleeding risk and ischemic risk. What do I mean by that? So in terms of preventing ischemic risk, I mean, we know from a number of trials and analysis that if you want to prevent ischemic risk, you have to go with longer DAPT duration. So it doesn't matter if you look at Pegasus and other trials, 1, 2, 3 years, even after CAD, MI, etc. If you want to prevent a recurrent MI event, longer DAPT is the way to go. And if you want to prevent a bleeding event, the shorter the better. So we kind of are faced with this conundrum of trying to go longer to prevent ischemic event and going shorter to prevent a bleeding event. So as an interventionalist, when we see patients with coronary artery disease, I can tell you that some of the data are outdated back in the day when we had older generation stents. We have made significant progress. You'll hear from Alok Finn next about stent technology and where we have come in terms of outcomes, etc. But just to summarize, our stents have become thinner. Our polymer is much better. So here, when you compare early generation drug-eluting stents and the polymer technology to newer generation, there is much more uniform coating, no webbing and bonding of surfaces, no delamination. And what has this translated? This has translated into optimal healing at the time of PCI and beyond, so that there is actually, once we deploy a stent, there is faster endothelialization. So the stents gets covered pretty quickly. And also, at least some of the surfaces, especially the fluoropolymer surfaces, are thrombo resistant. And so there is less thrombogenicity of these surfaces. Why should we care about all of this? Because if you look at what we are doing with ischemic risk after a PCI, so we have made significant progress at reducing restenosis with newer generation stents compared to older generation stents. We also made significant progress in reducing the risk of stent thrombosis. So if you look at some of the newer generation stents, the risk of stent thrombosis is reduced by almost 2/3. And consequently, with reduction in restenosis and stent thrombosis, there is reduction in myocardial infarction and eventually reduction in death with newer generation stents when compared to older generation stents. So the key message, so let's go back to this drawing board of decades of progress in PCI and medical therapy. What have we done with ischemic risk? With all of the improvement in stent technology, we have reduced the risk of ischemic events significantly. Let's look at the other side of the equation. What have we done with the bleeding risk? There is some decrease in procedural bleeding risk, mainly because of rapid adoption in radial access technology. There is also use of agents such as bivalirudin, use of heparin without the use of 2B3A. All of these have reduced the peri-procedural bleeding risk somewhat, but overall, we are increasing the risk of bleeding in our patient population because we have more potent P2Y12, ticagrelor, prasugrel. The patients are also getting older, so there are more elderly patients, more patients with atrial fibrillation, more patients who need some kind of oral anticoagulant therapy. So if you look at this equation of ischemic risk versus bleeding risk, we have reduced the ischemic risk, but in fact, we are increasing the overall bleeding risk. So with that framework in mind, let's start with the guidelines and what do we DAB duration for stable coronary artery disease. So in patients with stable coronary artery disease, the recommended DAB duration, because of what we have done in progress in reducing ischemic risk, it's no longer 1 year. So the recommended duration of DAB is 6 months as a class 1 indication. And if you have a patient who is at high bleeding risk, you can get down to 1 to 3 months of dual antiplatelet therapy in stable coronary artery disease patients. Okay, so that's stable coronary artery disease, but now let's talk about STEMI and ACS patients. And this is a good study from the Horizon MI trial looking at what is the patient's risk of ischemia and bleeding immediately after PCI and up to 1 year. So I think this is important to set the framework of what we'll discuss in the next few minutes. So early on, so within the first day after PCI to up till 30 days after PCI, the bleeding risk kind of slightly outweighs the ischemic risk. And 0 to 30 days, this is the bleeding risk is kind of outweighing the ischemic risk. Interestingly, in STEMI patients, after 30 days up to 1 year, the ischemic risk outweighs the bleeding risk. So this is important to recognize early on bleeding risk, later ischemic risk in patients with STEMI. But again, this is from the Horizon trial, but this is not a trial of high bleeding risk patients. We'll come back to that later. So with that in background, so what do we do with ACS patients? There have been a number of trials. We published this meta-analysis in 2017, looking at 8 trials, 13,000 patients with ACS. We looked at less than 6 months versus 12 months or extended DAPT, or compared 12 months versus extended DAPT. So what we showed was extended DAPT kind of was favorable to reduce your risk of MI. But for major bleeding, the results favored shorter DAPT duration of time. So in other words, it wasn't a one-size-fits all. So in ACS patients, so in 2017, we said short-term DAPT may be reasonable for some patients, whereas extended DAPT may be appropriate in select others. And so individualizing an approach, taking into consideration competing risk of bleeding and ischemic events will be the way to go. So earlier this year, we published an updated meta-analysis. This was somewhat late last year, where we looked at 14 trials and now 32,000 patients, looking at a different duration of DAPT. And here we compared less than equal to 3 months, 6 months, 12 months, or greater than 12 months, and what should be the optimal DAPT duration in ACS patients. And these are some of the results. If you look at death, and when comparing it to long duration of DAPT, greater than 12 months, whether it's less than 3 months, 6 months, or 12 months did not make a difference for death. It did not make a difference for MI or stent thrombosis, and shorter DAPT significantly reduced bleeding. But what I want to point your attention to is look at the point estimates for MI and stent thrombosis. these clearly favor a longer DAP duration when compared to short duration. So although these are not statistically significantly different, although short DAP reduced bleeding, there is a hint, at least in this analysis, that there is a high risk of MI and stent thrombosis if you go short DAP. So the conclusion here is short-term DAP did not increase death MI and stent thrombosis compared to long DAP, and this is short DAP defined as 3 or 6 months DAP. But the point estimate indicates higher MI and stent thrombosis, whereas short DAP clearly reduced bleeding when compared to longer DAP duration. So in the next few minutes, I'm going to show a series of trials. I mean, the key thing is, and of course, not to get bogged down by clinical trials, but just the underlying message. Here we'll start with patients with trials where no STEMI patients were included, and end by trials where it predominantly included STEMI patients to answer the question, what should be the optimal duration in STEMI patients? So if you start with no STEMI patients included, this is the Science short DAP trials. I'm on the executive committee of this trial. So where we tested 30 days versus a 30-day DAP or a 90-day DAP in compared to historical control of 12-month DAP in patients who are high bleeding risk. And we showed 30 or 90-day DAP after PCI with the Zion stent was non-inferior for ischemic endpoints of death or myocardial infarction, and in fact was superior for reducing bleeding. So 30 or 90-day DAP reduced bleeding, no changes in ischemic endpoints in a trial where STEMI patients were excluded. Now, moving on to another trial where STEMI was excluded. This is the Twilight trial. The Twilight ACS subgroup was published and presented recently. 4,600 patients randomized to 3 months of DAP, and after 3 months of DAP, the patients were only on ticagrelor monotherapy, or comparing with to 12 months of DAP with those aspirin and ticagrelor. Again, STEMI was excluded. In this, if you look at 3 months when compared to 12 months, 3 months again reduced bleeding. I mean, there is no doubt that shorter DAP will reduce bleeding. And in this, when comparing ticagrelor monotherapy versus aspirin and ticagrelor, there is no difference in ischemic endpoints. Again, a trial where STEMI was excluded. Now let's look at trials where some patients with STEMI got in. So this is a smart choice trial looking at 3 versus 12 months. Only 10% of the included patient population at STEMI. Here, after 3 months, you would continue P2Y12, and the P2Y12 continued was in 76% of patients was clopidogrel, 23% was ticagrelor prasugrel. And in this, abbreviated DAP was non-inferior for MACE, no difference in MI and stent thrombosis, and again, shorter DAP resulted in superiority for bleeding in a cohort of patients where 10% of them had STEMI. Let's look at more recent trial, the Master DAP trial, where again, this is a high bleeding risk trial. So 4,500 patients, high bleeding risk patients, randomized to 1 month DAP versus 6 months. And after 1 month, 70% of them continued P2Y12. I think around 70% of those were clopidogrel. And this was compared to 6 months DAP. 12% of them had STEMI. And again, this trial showed that 1 month was good enough, non-inferior for net adverse clinical event, non-inferior for MACE, and again, superior for bleeding. Now let's look at the STOP DAP2 trial. Again, 18% of them with STEMI randomized to 1 month versus 12 months DAP. After 1 month, you continued clopidogrel. And most of this were IVUS-guided PCI. And what we see is the trial met non-inferiority for ischemic endpoints. The primary endpoint, which was a composite of ischemic and bleeding endpoint, was non-inferior for 1 month compared to 12 months, and also superior. And the superiority was mainly driven by decrease in bleeding, no difference in ischemic endpoints. Those are all great. I mean, all message seems to indicate shorter DAP is better, but now let's add more STEMI patients. So if you, in the STOP DAP2 ACS trial, more than half of these patients had STEMI. So 56% of patients had STEMI. So 4,100 patients randomized to 1 month DAP. This was followed by clopidogrel compared to 12 months DAP. Interestingly, in this trial, 1 month DAPT did not meet non-inferiority criteria. In fact, 1 month DAPT increased MI 1.6% versus 0.9%. But of course, shorter DAPT reduced bleeding. So again, it's interesting that when you increase the number of STEMI patients, the shorter DAPT may not be the best way to go because the risk of thrombotic or ischemic event is actually higher. And finally, this is an analysis, patient level data of SMART DAPT and SMART DATE and the DAPT STEMI trial. 72% of this cohort at STEMI. This looked at 6 months DAPT followed by aspirin monotherapy versus longer DAPT. And you can see where short DAPT was non-inferior for net adverse clinical events, no difference in death, no difference in stroke. But again, shorter DAPT increased MI in a cohort where 72% of patients had STEMI, and of course, reduced significantly major bleeding. So what is the take home? So this is an analysis from the precise DAPT looking at complex versus non-complex patients. So if you have a patient with complex lesion and low bleeding risk, longer DAPT is the way to go. But if you have complex lesions and high bleeding risk, shorter DAPT is the way to go. So in summary, what I want to say is when you have concordant bleeding risk more than the ischemic, when you have patients who have both higher bleeding and higher ischemic risk, the bleeding risk more than the ischemic risk should inform decision-making and duration of DAPT. And I'll come back to my thoughts on how we should individualize treatment care. The other thing that has been hotly debated is what should be the single antiplatelet therapy after short course of DAPT. We published this recently looking at should it be aspirin, should it be a P2Y12 therapy after you do your required whatever duration, 3 months, 6 months, 1 year of DAPT, should we go back to aspirin or should we do P2Y12? Again, the answer is not simple. So if you want to reduce bleeding, you should go with an aspirin monotherapy. If you want to reduce your stent thrombosis or ischemic risk, P2Y12 monotherapy is the way to go. So again, you have to base your decision on bleeding versus thrombotic risk. So what do the guidelines say for ACS in terms of duration of DAPT? Both the American and the European guidelines would say that minimum duration of DAPT should be 12 months. If you have a patient who is at high bleeding risk, the minimum duration can now be reduced to around 3 to 6 months of duration of DAPT for these patients. So, see, I always use this as a framework. If you were wanting to know what should we do for our patients, to reduce ischemic events, of course, you can do a lot of things. Optimize your stent deployment. I mean, I see Ziad on the screen here is going to talk about imaging guidance and how we can further reduce the risk of ischemic events. So that's the way to go there. And to prevent non-stent related events, let's not forget now, you heard from many speakers about SGLT2. We have high intensity statins, PCSK9, low dose anticoagulants. So we have a lot of things to go to reduce your ischemic events. For bleeding events, and of course, consistent signals showing that short-term DAPT is the way to go. In patients with ACS, I mean, I take this strategy because we still really need to individualize care for these patients. So if you have a patient who is at high bleeding risk, I still go short duration of DAPT for these patients and do P2Y12 inhibitor de-escalation therapy for these patients. So to conclude, to answer the question that I was given, what should be the optimal duration? In stable CAD, I go short duration of DAPT, 1 to 6 months DAPT, because this has the benefit of reducing bleeding without increasing ischemic events. In STEMI, it's a tricky situation. They are at high risk of ischemic events. So short DAPT reduces bleeding, but non-inferiority and ischemic outcomes is less certain. So optimal duration in non-high bleeding risk patients should be 12 months. Optimal duration in high bleeding risk should be 3 to 6 months. If you have such a patient, don't forget they're also at high ischemic risk. So try to maximize other therapies to reduce ischemic events. And at the end of the day, it's all about balance. Thank you for your attention.
Good evening. Thank you, Sripal, for an excellent overview of DAPT. But still we are confused, Sripal. You have to tell us very clearly. A patient who comes with STEMI has got we have a total revascularization, single vessel disease. Are you clear in your mind about the the DAPT regime?
Yeah, so if you have a patient with STEMI, my first question would be, what is the bleeding risk? If the bleeding risk is high, I just go short duration of DAPT, 3 to 6 months of DAPT. And for that particular patient, if the bleeding risk, for example, if it is greater than 75, they're on oral anticoagulant, etc. So short duration of DAPT, 3 to 6 months. And after that, I'm more likely to drop aspirin and continue P2Y12 on those patients.
And if the patient has got only a single vessel disease, does it change?
A good question. So if it is a single vessel disease and non-high bleeding risk, I mean, so if I don't see any, lumpy bumpy disease in other beds, if it is just straightforward single lesion, you still can get away with short duration of that, because there is that thrombotic risk is that patient's thrombotic risk is going to be low. So again, I think that's why individualizing care, you're absolutely right. I mean, will be the way to go.
Thank you very much. Any other questions, anybody?
Okay, Sripal, one thing you have to simultaneously correct the source of bleeding. Some patient having the piles, you have to correct the piles, and varicose bleeding from esophagus, that should be also corrected, apart from all the antiplatelet and dual therapy. That is what simultaneously must be done also.
Yeah, absolutely. I completely agree. And many times it is possible that the DAPT actually uncovers a bleeding event, and then you'll figure out, oh, maybe the patient has cancer, maybe has, hemorrhoids, etc.
Yeah.
The organizers are told that we are already running late. Let us proceed to the next speaker if acceptable to all of you. Yeah. We'll have to request Dr. Alok Finn to talk on the stent design and polymer and what is it in improving.
Can someone help me share my screen? It says I can't share. I don't know why that is, but I'm not allowed to share my screen. There we go. Let me see. Thanks a lot, Dr. Bathier. I really appreciate it. Great to be with you all. I have to say, I've seen many people that I know really well, and it's a pleasure. Can you see my screen now? Am I sharing the screen?
Yeah, clear.
Yeah.
Okay, let me just put it on the. Does that look good, or is that okay? Okay.
It's excellent.
Okay, thank you. So I guess I was given the task to talk about stent design and polymer. Is it of any relevance in improving outcomes? And I'm going to tell you, yes, it is. And I'm going to give you my opinion on the subject. Here are my disclosures. So, Shripal gave a great lecture. I think that the modern era is really about DAPT flexibility in stents. We really are trapped in this era where we are using DAPT for long periods of time, and we really have to change the technology so that we don't need such long periods of DAPT. For instance, I treated a 93-year-old lady yesterday with a non-STEMI. How long should she get DAPT for? I got all concerned about that. So I think the questions are still evolving. What would we want if we could make the ideal DES? We would certainly want proven, potent anti-restenotic benefit. We'd want good radial strength. We'd want good short and long-term vascular responses with minimal inflammation. We want the stent to stay patent for decades. And we want a good biomaterials-blood interaction, which demonstrates that the stent itself is thromboresistant. Therefore, we really don't need a lot of antiplatelet therapy because the stent itself serves as a thromboresistant element, preventing stent thrombosis. And that's really the key element I think I'm going to talk about today. So what matters in terms of thromboresistance? We obviously want a thin strut design. Most of the stents today are less than 100 microns. If you ask me, that's probably the standard for stents these days. We want a polymer coating preferably, and different permanent polymers exist. In the United States, we have two different permanent polymer stents, Xience/Promis and BioLinks. The Onyx stent, which is a BioLinks polymer, which is another permanent polymer. And then we have bioabsorbable polymer coated stents. You have many more than we do. We've got Synergy, we've got Osiro. Those are basically stents with polyalpha hydroxylic acid family of polymers. Then we've got stents with no polymer. We don't, but you do in terms of biofreedom, things like that. And then what is the polymer coating? Is it coat the entire surface? Does it only coat the abluminal surface? I'll show you why that might be important. And then what are the healing characteristics? Obviously, the faster the healing, the better. Now, here's the outline of the different stents we have. You can see I've divided them into durable polymer, Xience and Onyx. with those two different polymers. The Xience has the fluoropolymer, the PVF, HPF membrane. Onyx has a BioLinks polymer. The rest of the bioabsorbable polymers, I've lumped them together. We either have PLA or PLGA coatings, and they're meant to degrade over time. That degradation profile differs among the different stents. Also, conformal versus abluminal coating is also different. Now, this is just an experiment conducted by Edelman many years ago, just showing you the simple idea, two simple ideas. In a flow loop model, there's two characteristics of stents that are important for thrombosis. One is polymer coating. If you coat a stent and DES, you have less thrombus formation on the stent. And if you have a thin versus a thick strut stent, you have less thrombus formation on the stent. Those are two elements that are important in thromboresistance. Now, what about healing? I hear a lot of people here saying, oh, the stents heal. They're healed by 30 days. That's why this is all working. We're able to do the 28-day DAP. It's no issue. That's not true. In animal models, if you compare Xience, Synergy, BioFreedom at 28 days, they basically all have the same number of uncovered struts. And remember, animals heal more quickly than humans. So humans have unhealed stents at 28 days when withdrawing stents. So what matters is that the stent itself have some thromboresistant element so it doesn't thrombose, because struts are uncovered at that time point. And so what matters, if you think about it and you put a stent in the body, basically the metallic surface attracts platelets, fibrinogen causes thrombus formation to occur. If that stent itself is coated with some other element, preferentially like albumin, that prevents thrombus formation from occurring. It's really a protective coating. So if the coating itself absorbs albumin more highly than platelets or fibrinogen, that forms a thromboresistant surface. And that's really the idea behind fluoropolymer passivation. And this is shown here in this basic science slide where we look at the effects of a PDF HPF fluoropolymer membrane versus stainless steel, and you can see the albumin binding is just 80 times more superior with the fluoropolymer surface than stainless steel. Stainless steel is not a good surface for thromboresistance. That's just the reality of it. And when you try to elute that off, it sticks there more highly. Now, what about inflammatory cells? They are much less adherent to a fluoropolymer membrane than a stainless steel surface. So what happens in albumin binding between different stents? This is an experiment I conducted in my lab in a flow loop. We used fluorescent albumin. We said, how much albumin binds to these different types of stents? And you can see here, we fluoresced the stents in green if they bound albumin. Bare metal stents don't bind any albumin, as I just showed you. Synergy, because its luminal surface is bare metal, with the abluminal surface is polymer, you can see the luminal surface does not provide good albumin binding. Onyx, Osiro provide more, but Xience provides superior amounts of albumin binding. There's no question. That's because of that fluoropolymer membrane. And this is just a low power showing you that I'm showing you the entire surface of the stent to give you idea it's truly representative of what I showed you. Now, how can we show thromboresistance in experimental models? We can show this very easily using a porcine AV shunt model. And Shripal showed this briefly, but I'm going to show you some more follow-up data. In the porcine AV shunt model, we connect the artery and the vein of the pig with silastic tubing, and I'll show you that in a minute. So here's the idea of thromboresistance. This is another flow loop I conducted in my lab. We took human platelets, we fluoresced them, and we put them in a flow loop, and we put a bare metal surface and a fluoropolymer surface under a microscope. And we did this under real time over the course of minutes. And you can see here how much platelet forms on the bare metal surface. Look at all the orange platelets binding, whereas the fluoropolymer surface really can't hold the platelets. That's the whole idea behind this thromboresistant effect. And under the porcine shunt model, this is what I was showing you earlier. This is how we can show it in experimental models. We can basically connect the artery and the vein of the pig with silastic tubing, put 3 stents in line, and run this for about 60 minutes under different types of therapy. We used to do this under low-dose heparin therapy, but now we're doing it under single antiplatelet therapy to show you no heparin. What are the effects of different stents in terms of thromboresistance? We can put the animal on aspirin therapy, for instance, or clopidogrel monotherapy, and then run the shunt, and basically at the end of 60 minutes, collect the stents and look at them for amount of platelets collected. And what you see here in this experiment is it's quite clear that under aspirin monotherapy or clopidogrel monotherapy, Xience performs the best in terms of intrinsic thromboresistance. Now, Onyx doesn't perform badly. There is some green there, some platelets, but it's not bad at all. And Synergy doesn't perform very well, especially under clopidogrel, probably because that luminal surface is metallic. Now, the idea behind 1-month DAP really originates with this Leaders Free trial, which was done in 2016. That was a trial of the BioFreedom drug-eluting stent versus bare metal stent in high bleeding risk patients for 1 month of DAPT. And at that point, it was like 1 month of DAPT, not possible with drug-eluting stent. What they showed was the drug-coated stent for safety endpoint was significantly better than the bare metal stent at 1 month of DAPT. So we really got an opening for the 1 month with this type of trial, was showing it was efficacious. But the problem, of course, was both the polymer-free DES, the BioFreedom, and the bare metal stent had fairly high rates of stent thrombosis. Those were not polymer-coated stents. Remember, the rates of stent thrombosis there were 2 and 2.2%. I would say 2% is really unacceptable clinically. Now, short-term DAPT trials have gone crazy. We've got lots of data. Shripal showed you a lot of that, and I'm going to review some of them. Most of them have been completed, and we've learned a lot from these in terms of different stents, different design, what works. Now, here's the original Stop DAPT 2 trial. That was a Xience trial, basically 1 month of DAPT versus 12 months of DAPT. The patients were taken off of DAPT at 1 month and continued on clopidogrel, and you can see the cardiovascular bleeding composite endpoint was significantly lower with 1 month of DAPT versus 12 months of DAPT, which was really excellent, showing you the thromboresistant idea does work with this fluoropolymer-coated stent. And what was more interesting was and this was not really an ACS trial or HBR trial, this was an all-comers trial. What was more interesting was the major secondary cardiovascular endpoint, ischemic endpoint, was not different, but bleeding was significantly lowered, showing you we could get away in mostly stable patients with this 1 month of DAPT. And then the Xience short-term DAPT trials explored a different hypothesis, the HBR patients, high bleeding risk patients. How did they do in terms of 3 months of DAPT or 1 month of DAPT? And I won't go over this a lot, but the safety objective was death or MI of short-term DAPT versus up to 12 months. And then the secondary were bleeding and stent thrombosis. And again, you see that it worked. It was no question. 1 month of DAPT was not inferior to 12 months of DAPT in terms of historical control for death and MI. So it was a safe approach. Same thing with 28 days of DAPT. Again, showing you this thromboresistant idea works very well with this fluoropolymer-coated stent. And stent thrombosis rates from 3 to 12 months were extremely low in the Xience stent, 0.2%, 4 cases. And you can see again, in the 28 days, it was almost the same, 0.3%, 4 cases out of 1361 from 1 month to 6 months. Again, showing you this thromboresistant idea really makes a difference. Now, Onyx 1 was a randomized trial, same idea, randomized against BioFreedom, the BioFreedom stent I showed you earlier, versus Resolute Onyx. And you can see they were basically HBR patients taken off DAPT at 1 month. Most of them were put on aspirin SAPT. And you can see the rate of composite endpoint, death, MI, stent thrombosis was 17.3, no different. Kind of disappointing for Onyx in the sense that BioFreedom is not a polymer-coated stent. Stent thrombosis rates were higher than you'd like, but not terrible and not different between the two stents. Now, I'm going to skip the last part of this talk is about COVID-19 because I was asked by Dr. Naik to do this. Does polymer matter in high-risk thrombotic situations? That was what we wanted to explore with this paper that we published recently. And this was, it's been reported in STEMI papers that patients with COVID, and I'm sure you all have the clinical experience to know, they seem to have higher rates of stent thrombosis and overall thrombosis than non-COVID patients. And we looked at this in our pathology series and we said, is this true? Is this possible? Well, we found we only had a few cases, of course. This was a patient that died shortly after stent was placed in the LAD. And you can see what we found right after that at the time of death was this patient had didn't die of stent thrombosis, but had a lot of platelets and inflammatory cells accumulating at the stented segment right after the stent was implanted at the time of death. It died of something else. So you can see here, that was the case. Unusually high inflammatory cells and platelets. It got us interested. We looked at non-COVID cases. We said, in our pathology series, same duration, right after stenting, do we see the same amount of thrombus formation? No, we don't. We hardly see any. So we got the idea. It was only an N of 1, but we said, hey, maybe there's something going on. So we tested that in a simulated cytokine storm where we said, hey, let's look at what we can simulate for COVID-19 and how it affects stents, because this had not been done before. So, as you know, PCI may be indicated with some patients with COVID-19. It's not superior, not known what type of device is superior. But again, we got this idea, maybe fluoropolymers are better for patients with COVID-19 because of the thromboresistance than non-fluoropolymer-coated stents. So we simulated cytokine storm, but basically using a flow loop model. We said, let's pretend it's a COVID-19 patient. Let's use the same type of cytokines that are up on these patients at the same doses. So we used TNF-alpha and IL-6, and we spiked the blood, human blood, with these type of cytokines and said, let's run them through a flow loop where stents are placed in that flow loop, and let's look at how much thrombus forms over time. And we processed them for SEM and immunofluorescence. And here you can see the stents we tried. We tried a Cobra stent, which is a bare metal stent with a different type of fluoropolymer coating. We used an uncoated Cobra, just the same stent design, no fluoropolymer, Resolute Onyx, and Synergy. And you can see in red, I've stained the platelets. What you see immediately is the upper panel is the non-cytokine storm conditions, and the lower panel is the cytokine storm conditions. And you can see immediately what you should see is that overall, the Cobra, the fluoropolymer coated stent, performed perhaps the best of any of the stents in terms of fluoropolymer coating. The uncoated Cobra did not perform well. It had a lot of thrombus on its stent surfaces. Onyx performed perhaps better than an uncoated stent because you can see here there's less platelets. And Synergy did not perform well at all, because what I showed you. So when we quantitated this, we saw really no change in the fluoropolymer coated stent under control in cytokine storm conditions. But for things like the uncoated Cobra and the Onyx stent, there was significantly more increase in thrombus under the cytokine storm conditions than there was under the control conditions. Now, Synergy performed poorly under both conditions. And so it gives you an idea of what happens in a cytokine storm of COVID-19. So in summary, I hope I've convinced you fluoropolymers make a difference in terms of thromboresistance, and that the type of polymer makes a difference. If he doesn't have any polymer on the luminal surface like Synergy, probably not as good as ones that have fluoropolymers like Onyx and Xience. So I think when considering short-term DAP, the capability of thromboresistance of individual stents is important. And I think I showed you COVID-19 subjects are a high risk for thrombotic events, including stent thrombosis. And this may be another situation where stent thrombogenicity makes an important difference, as does antiplatelet therapy. So with that, I'd like to thank you for your attention.
Thank you, Alok, for excellent presentation. My question in cases of diabetes is the pro-thrombotic state. Where pi is very high, the ulcerative lesion, thrombus spontaneous lesion. One situation. Second is acute myocardial infarction, thrombus spontaneous lesion. Third, you have already mentioned COVID is the pro-thrombotic state. So tell me which will be ideal stent, whether the abluminous surface, abluminous containing stent is better, just for synergy, both albuminous and other polymer also there. And similarly, Onyx and the Orsiro, Xience, everything. So durable polymer. Tell me the comment on that three situation.
I think it's a great question you have. I mean, I think ultimately, I like polymer coated stents more than I like stents that are not polymer coated. Like you saw Synergy, I don't like being metallic. I think the question about diabetes patients is right on the mark. I mean, the reality is diabetic patients are hypercoagulable. They do worse. I traded 2 of them yesterday. Both had in-stent restenosis. I think we have a lot of data on short-term DAPT, but we don't have diabetic subset data that's really been shown to us. How good are these for, we say HBR, we say non-HBR, we say ACS, but I haven't seen a lot of individualized data for diabetics. And I agree with you at this point. I tend to prefer these polymer-coated stents for diabetic patients, although I don't have good data to support that.
Anil, thank you very much for presentation. I have one question. In the recent post-exam trial and smart choice trial also, it was shown that clopidogrel long-term use instead of other PY12 inhibitors has a better outcome compared to aspirin. Is it, and all these 2 important studies contain a lot of South Asian patients, particularly Korean, in post-exam and smart choice. Do you think that genetically these patients are better with clopidogrel than with other PY12 inhibitors?
That's a great question. I think that you're right on the money in terms of extrapolating trial data from Asian patients or Japanese patients or Korean patients to other types of patients. I don't think that all races have the same predisposition towards thrombosis. I actually think Europeans, Americans are more prothrombotic. And why do I say that? Not only from the data, but I'll tell you, my own lab, when I draw blood from people and do these experiments I showed you, the platelets from people of East Asian origin just don't aggregate at the same level as patients who are from America or Europe. So I think there's a big difference in terms of the bleeding ischemic risk equation in people with of different races, and I don't think that's quite worked out well in terms of the trials.
Thank you, Dr. Alok. That was a wonderful session, and Dr. Shripal Bangori. I think so. In the interest of time, because we have grossly overshot our times, I will have to request for us to draw close to the session. Thanks again so much. And now I'd like to introduce, bring our chairpersons for the next session, which is a series of keynote lectures. And I would like to invite our chairpersons, Dr. Anjan Lal Datta, Dr. C.P. Roy, Dr. Debrat Roy, Dr. M.K. Das, Dr. S.S. Kothari, and Dr. Sunita Vishwanathan to take over the proceedings. And I would request, and I'm been told by requested by Dr. Ziad Ali that he has a flight to catch, and he is requested for a change in the order. And I think so. I would request Dr. M.K. Das to introduce Dr. Ziad Ali, and then we begin the session.
Thanks to the organizer. Actually, it's a very high-powered keynote lecture session. Dr. Ziad Ali will be presenting his deliberation because of some technical problem on his part. Intracoronary imaging in ACS intervention current status. Now, Dr. Ziad Ali is a very, very important man who pioneered the development of techniques such as IVAS zero contrast PCI OCT using saline flash. He is also the director of the Mattis Cardiovascular Institute, Investigational Interventional Cardiology, Cardiorenal Program, St. Francis Hospital and Heart Center, New York. He is also the director of Angiographic Core Laboratory, Cardiovascular Research Foundation. Clinical research interests are in use of intravascular imaging and physiology techniques, integral role in development of resting full cycle ratio. It's a huge list. I request Dr. Ziad Ali to present his deliberation. Over to Dr. Ziad Ali, please.
Thank you very much. Are you able to hear me okay?
Yes, very much.
Excellent. And you're able to see the slides?
We can hear you loud and clear.
Excellent. And you're also able to see the slides?
Yes, sir. Yes, sir.
Excellent. So firstly, I'd just like to thank the organizers for inviting me, and also for Greg and Jagat Bhai for being so accommodating to my schedule, which is limited by air traffic control. So I'm going to talk to you about intracoronary imaging and acute coronary syndrome interventions. And I thought a lot about this talk because this is probably something that we don't investigate enough. So I spent a fair amount of time thinking about this. So what I'm not going to do is inundate you with a huge amount of data. What I'm going to do to you is talk in a clinical, practical sense about how we manage patients with acute coronary syndromes. And really what you're going to see on this slide is the predominant mechanisms of acute coronary syndrome in clinical practice. The vast majority are plaque rupture. Approximately 30% are intact fibrous cap, which is a imaging diagnosis, but in practical terms, either embolism or erosion. Calcified nodules, approximately 5%, and spontaneous coronary artery dissection, approximately 1%. So the question is, can intravascular imaging really help us in these situations? So Greg and I published this work from a very large pooled analysis of almost 14,000 patients from contemporary drug-eluting stent trials, which shows that, in fact, acute coronary syndromes or patients with an STEMI have a significantly higher risk of events compared to all comers. And you can see that the risk factor for target vessel failures are the inclusion criteria for the Illumian 4 study. And when we look at the Kaplan-Meier estimates, you actually notice something interesting, and that is the vast majority of the hazard of STEMI patients comes very, very early. And to me, that suggests a potential caveat for angiographic guided PCI because the events are occurring at an early stage. So here's a case. This is a 39-year-old male current smoker who is wrestling with his child and develops sudden onset chest pain radiating to the shoulder. He's seen in the emergency room and he's treated for a pulled muscle. His EKG is diagnosed as left ventricular hypertrophy. So he returned to the emergency room some hours later due to this unresolving chest pain, and there's not a whole lot on the angiogram. And so, but the patient is in the cath lab, patient has ST elevation, is having ongoing chest pain. So we undergo, there is an ambiguous lesion somewhere near the septal, which if you look very, very carefully, we can see some haziness. But the question is, what is this haziness? And this is where I think OCT can help. So if you look on the left side, the high resolution of OCT and pulling back, what we actually notice is right after that septal, there is a large burden of thrombus. Now, it's a 39-year-old patient, so the question here is this intact fibrous cap, or is it actually a plaque rupture? And this is actually one of the areas where I think thrombectomy can still be useful. In this young patient, when we actually perform thrombectomy, we see the typical features of a plaque rupture, and a fibrous cap that's been ruptured and a smooth hollow crater underneath. And as a result, this patient should be treated with a drug-eluting stent, and actually did end up undergoing such. Now, I think what can be also valuable in this patient is to go ahead and look in this young patient about the burden of disease. Greg is going to talk to you about what happens with plaque burden over time and risk, but you can see that on OCT we see a large lipidic burden, we can see macrophages within the lesion, and we have a thin cap fibroatheroma in the reference segment. So when performing PCI, we want to cover the lipid, cover the macrophages, and cover the thick fibrous atheroma, the thin cap fibroatheroma to a normal vessel. And so in this patient, the OCT findings show clearly that after wiring and thrombectomy, that this patient is suitable for stenting. And what we know from more recent data, such as this complete OCT substudy, and the complete trial, as you recall, showed that a complete revascularization strategy in patients with ST elevation MI has a hard endpoint benefit. In this OCT substudy, what they found was that in patients with obstructive lesions, the prevalence of TICFA was actually very high, 35%. And also on a patient prevalence level, the obstructive TICFA, so patients with obstructive lesions who have a thin cap fibroatheroma, was the predominant lesion subset. So in these obstructive non-culprit lesions in STL segment elevation patients, there's high lipid content and other plaque features of vulnerability, and almost half the patients undergoing multivessel OCT had at least one obstructive non-culprit lesion containing vulnerable plaque morphology. Greg's going to talk to you more about this. Then we have this patient, a 77-year-old female with a recent knee replacement with a postoperative myocardial infarction. Now, here again, we have what looks relatively like normal coronary arteries, except perhaps for some haziness in the distal vessel. And when we go ahead and look at this in more detail, what we see is actually there's a thrombotic presence within the distal, mid to distal left anterior descending, a large burden of white thrombus, which suggests it's on the older side. But what I want to bring your attention to is actually the ability to see the media or trilaminar appearance outside of the white thrombus suggests this to be embolism rather than plaque rupture. And this is how we know this is an intact fibrous cap. This patient was treated simply with thrombectomy, followed with some saline flushing, and you can see that there's complete resolution with a totally normal trilaminar appearance. And as a result, you can manage your dual antiplatelet therapy accordingly and certainly not place a stent. Other intact fibrous cap lesions, here's this patient with ST segment elevations. You can see that there's what looks like a very moderate lesion, which may even be IFR, RFR worthy. But when we go ahead and look at this in detail, what we see is actually there is thrombus within the mid left anterior descending, and this is the typical appearance of an erosion. When we look at this in greater detail, and I want to credit Ajit Mulasari, who's really been moving this field forward, you see this 33-year-old male smoker who presented to the emergency department with positive biomarkers. You can see, again, a large area of red thrombus suggesting that it's fresh. But this patient, amazingly, was treated with a GP2B3A for 48 hours and discharged on triple therapy with warfarin, aspirin, and Plavix. And at 6 weeks, the OCT showed a complete resolution of the thrombus and no evidence of plaque rupture, and in fact, no evidence of lipid. These preliminary data suggest that thrombotic erosions have a better prognosis compared to plaque ruptures, and that perhaps we can actually not stent some of these patients. This is a lot of data. As we know, the erosion 3 studies is going to be reported soon. What about our third type, which is a calcified nodule? So this is a 8-year-old male with hypertension, hyperlipidemia, end-stage renal disease. These renal disease patients see nodules commonly. You see a nodule in the proximal left anterior descending. And what you see is that this nodule is protruding into the vessel wall, and there's a small amount of fibrous cap, but there's also exposure of the calcium. Because of the rheology of blood, this is highly thrombogenic, and so this patient was treated with atherectomy to shave down the nodule, followed by stenting. What other possibilities are there? The less common things such as spontaneous coronary dissections. A 51-year-old female with hypertension who has acute onset chest pain in the emergency room. She has ST depressions in one AVL and AVF, and you can actually see that there is a lesion in the circumflex, which looks like spontaneous coronary artery dissection, but because the patient was having ongoing pain, it was decided to investigate it further. So the questions are, is this actually a dissection, yes or no? What type of dissection is this, and where does the dissection start? Those are all important questions. And so if you look on this OCT, what we are able to see is that, in fact, this is an intramural hematoma consistent with spontaneous coronary artery dissection, and that the entry point of this spontaneous dissection is actually not at the most proximal segment, and in fact there are multiple areas of fibrous cap disruption, and thus simply treating this with a proximal stent and distal ballooning will be inadequate. So in fact, this was a dissection. This was a type 2 dissection, and the dissection started at point B. So the dissection flap that occurs as a result from an intramural hematoma really is not predictable and not necessarily at site D. The Vanquish trial showed that as much as 50% of STEMI patients had no identified culprit or have multiple potential culprits. That's also important because we have an increasing recognition of MINOCA, myocardial infarction with non-obstructive coronary artery disease. This is taken from our recent HARP paper, which I'll highlight on the next study, which show that the mechanism of these can be actually plaque rupture, a healed plaque, or actually an intraluminal hematoma. So in the Women's Heart Attack Program, which was led by Harmony Reynolds and was, from a core lab point of view, led by Akiko and I, women with myocardial infarction were referred for cath with an intent to perform a PCI. The patients were found to have no angiographic lesion more than 50% stenosis, and as a result, they went to OCT for 3 vessels. And what we found on the OCT was quite interesting. So these 145 patients, they could be either normal. We often found plaque ruptures, but we also found things such as intraplaque cavitary, spasm, layered plaques, and thrombus without plaque rupture. So in the final few minutes, what I want to do is just take you through a case of how we might be able to help in STEMI. So this is a 63-year-old female with hypertension, hyperlipidemia. Her EKG shows clearly ST elevations. And most commonly, we do not perform intravascular imaging on STEMI, but let's see how it can be helpful in this patient. So here you can see the circumflex is normal, but we have a complete occlusion of the proximal left anterior descending. After wiring, we have some flow. And when I'm going to perform OCT or planned OCT on a STEMI case, I still like to perform thrombectomy to clear some of the artery. The total study showed that we could reduce the thrombus burden by 23%. And then this really becomes an MLD max guided approach. And so if we go through the MLD max algorithm, as you remember, we're going to look at morphology, length, and diameter pre. And so this is an angiographic co-registration. And what that will do is really highlight for us some of the key features that we want to do when we're performing STEMI PCI in any PCI, but also in STEMI, and tell us some of the features, especially since we, in this case, we have a separate ostium for the left anterior descending. So if we go through the steps here, what you're going to see is we've identified the plaque by the angiographic co-registration. We can see that there is a thrombus present. What we're going to do is go ahead and find our reference segments. And we're going to identify normal segments. So we're looking at the lumen profile. We see clearly that there's a lesion. We're going to scroll through the artery to find a normal segment of artery as best as we can. This looks like a normal segment where we can identify the external elastic lamina. So this is me just performing EL guidance. I'll speed this up just a little bit for you here. And so I'm going to go ahead and perform the same thing on the proximal side. And then just quickly peruse here through the artery to look at plaque morphology to help me determine whether I need to do any other lesion preparation. Do I need a non-compliant balloon? There's the presence of the cap, fibrous cap rupture and the plaque rupture, and you can see the remnants here. At the proximal edge, we're actually going to do a lumen-guided stenting because we couldn't see the EL. And what do we see? We see a plaque rupture, we see adherent thrombus, we see macrophages, and this is a proximal lesion, which is actually in plaque because there's no normal segment. We use our OCT stent sizing algorithm from Illumian. Our MLD max, the morphology shows this is really soft plaque. We know we need a 38 millimeter length from normal to normal. Our distal reference is sized at 3.05. We round down to the closest stent size, and we go ahead and place our stent. Then we finally do a repeat OCT assessment in the post-procedure. And what we really see here is we do a very quick assessment. Oh, sorry about that. A very quick assessment of the distal and proximal edge. Here, so very quickly we can peruse the distal and proximal edge to make sure that there's no dissection. We can see on the apposition bar the stent is fully opposed, and actually the expansion is already laid out for us. There's 0% under expansion proximally, and we're also 100% expanded distally. So very quickly, I mean, this is a STEMI case that was done in 20 minutes. We assessed the plaque composition, identified the reference segment, chose our stent size, determined the expansion, and ruled out any complications. And this might be one of the reasons where we can prevent complications early on in the high-risk phase. Now, one of the things I'd like to mention about STEMI is, one of the reasons we took it out of Illumian 4 is you'll notice that compared to non-STEMI patients, the STEMI patients actually have a lower event rate. That's usually because the vessel's lesions are more proximal, and then we end up putting bigger stents. And one of the problems is sizing is very difficult to the sympathetic response. Residual thrombus prevents complete late apposition, and aggressive post-dilation does risk distal embolization. There is data to suggest that the IVUS and OCT-guided primary PCI improves clinical outcomes. You can see OCT guidance and IVUS guidance both improve the outcomes in terms of patient-oriented composite endpoint and device-oriented composite endpoint. And I'll just end by asking you all to join us for OPCI Live, our monthly program with live cases and journal clubs. And it was a real pleasure to be able to present it to you. Thank you very much.
Dr. Zayad, it was a very interesting demonstration of the importance of imaging, particularly in terms of the plaque morphology, plaque anatomy, and plaque character. I was wondering why the imaging till now is not recommended as a class 1 indication. Is it because many of the countries globally cannot afford to do that routinely in all cases?
I think that's part. Well, I think the global impact doesn't usually affect the European or American guidelines. You know, as you know, Greg and I are leading Illumian 4, which is completed enrollment. And in the addition to the long-term data from IVUS XPL and the Ultimate study, I believe we genuinely are going towards a class 1 indication in the guidelines. So, you know, as with all things, you remember when statins first came out, it takes a very long time for them to become a standard of care, but we certainly are going in that direction. I agree with you completely that the cost of the catheters can be prohibitive and it needs to come down, or there needs to be a strategy, for example, to be able to reuse them. But I think our first step really is to increase its utilization and provide you with the evidence that it does actually improve clinical outcomes.
What about left main ostial lesion and
left main ostial lesion? The modality of choice is definitely IVUS, not OCT. There are certain situations where IVUS is a superior modality. In my opinion, that is osteal lesions, patients with chronic kidney disease, and for chronic total occlusions. I think in terms of subsets of patients where OCT is a superior modality, I do think that for patients with moderate to severe calcification, the ability to see the thickness of the calcium is a major benefit.
Is it that sometimes we use normal saline instead of others dye in case of CKD, chronic kidney disease?
Yeah, so that's, as you know, we published our first experience of using saline, and there was also a very nice publication from India. In the right coronary artery, you essentially can replace contrast with saline starting tomorrow. In the left coronary artery, if you have a very tight stenosis for the pre, actually it works very well. But when you stent in the post procedure, if you have a very large lumen, the viscosity of saline is so low that during contraction of the heart, especially during systole, blood pushes the saline out retrograde. So you won't have a really good runs in the left side unless you use a guide extension catheter to sort of exclude the other vessel.
Thank you, Dr. Ziad, for a phenomenal talk. And due to paucity of time, we will move on to the next speaker, and I would request Professor Greg Stone to come up next, preventing myocardial infarction. I would request Dr. Devdutt Roy to say a few introductory words. You are muted, Dr. Devdutt. Dr. Devdutt, you are muted. You are on mute.
Am I audible?
Yes, you're audible now.
Yeah. So Professor Greg Stone doesn't require any introduction. And without losing much time, I request Professor Stone to start his deliberation, please.
Okay, thank you very much. Can you hear me?
Yeah.
Good. Let me share my screen. Here we go. Okay, so I was going to follow Dr. Narula, and we were going to give a series of lectures on preventing myocardial infarction. And he was going to talk about medications being at the heart of preventing myocardial infarction. And I'm going to talk about the potential role of revascularizing before it's too late for preventing myocardial infarction. And that's the interesting aspect. Can revascularization prevent myocardial infarction? These are my disclosures for this talk. So the answer is our attempts to prevent myocardial infarction have been pretty dismal. If you look at the COURAGE trial, and these are patients with chronic coronary syndromes, we had absolutely no difference in death or myocardial infarction or either of the individual endpoints in about 2,280 randomized patients who had either PCI or medical therapy. More recently in the ischemia trial, we had also no significant difference of cardiovascular death or myocardial infarction at 5-year follow-up after randomization of about 5,200 patients. So overall, pretty frustrating. When we look at myocardial infarction in ischemia, we did have a little bit of a glimpse of possible benefit. You'll notice that early on, there was actually a hazard of the invasive approach compared to a conservative approach with more myocardial infarctions early on. That's not surprising. But then you'll notice that the curves cross at about 2 years, and later there seems to be a few less myocardial infarctions in the invasive group. But overall, you can see this difference, even at 4 years, is only 1% difference. So it's 0.3% per year, which is nothing. And including peri-procedural plus long-term MIs, absolutely no difference in myocardial infarction. And so why is this? Well, the reason is that we've been treating with both PCI and surgery the wrong types of lesions for the most part. And this is your garden variety, 75% stenosis in patients with chronic coronary disease that causes angina, exercise limitation. And when we look at most of these pathologically, they look like this. They look like pathologic intimal thickening. Sometimes they're fibrotic or fibrocalcific. And these are very, very stable lesions. These lesions, for the most part, do not thrombose. They can certainly be flow limiting, and so they will cause exercise-induced ischemia, angina, dyspnea on exertion, et cetera. and doing PCI or bypass surgery of these lesions will improve quality of life and relieve angina, but it doesn't particularly prevent myocardial infarction in most cases. Now, we do know the type of pathology that is responsible for most MIs, and this is what Ziad showed you. While there's at least 4 different types, when you can think about ruptured plaques, erosions, calcific nodules, and spontaneous coronary artery disease dissection, the majority of them, probably 70% or more, are caused by ruptured plaques. And the precursor lesion to a ruptured plaque is this, a TICFA, or a thin cap fibroatheroma. And these usually are expanded plaques that have a large, well-formed necrotic core. And the necrotic core consists of cholesterol, cholesterol esters, and dead inflammatory cells. And it has very prothrombotic contents, including a lot of tissue factor, and it's separated from the lumen, which is usually a pretty large lumen, which is well preserved, by a thin fibrous cap. And that fibrous cap often has macrophage infiltration, and when matrix metalloproteinases and other digestive enzymes are released, that fibrous cap will rupture. And once it ruptures, all that tissue factor and other prothrombotic contents from the necrotic core are released into the lumen, and that can turn a 40% stenosis into a 100% stenosis over hours to days. And depending on the body's own thrombolytic system and its ability to try to fight this clot, whether, that will determine whether or not the patient presents with sudden death and a large, massive MI, or a non-STEMI, or just stuttering chest pain, or atypical chest pain, or sometimes actually be asymptomatic and just lead to progression of the underlying stenosis in kind of a stair-step fashion. Now, we do have one situation, one trial, where we've been able to convincingly show that we can prevent myocardial infarction. Only one, and that's the COMPLETE trial. And Ziad talked to you a little bit about the underlying OCT findings from COMPLETE, but this is the clinical data. This was 4,021 STEMI patients with multivessel disease that had a successful primary PCI for STEMI, and now they have other lesions. And they basically randomized those other lesions to either routine PCI or just medical therapy, with best medical therapy. And you can see with follow-up out to 5 years, there was a clear reduction in cardiovascular death or new myocardial infarction, and even a bigger reduction when you include ischemia-driven revascularization. And when you look at the endpoints, you can see, if again, I'm talking about MI in this talk, MI was clearly reduced from 7.9% to 5.4%, a 32% reduction, p-value of 0.002. Also, there were reductions in ischemia-driven revasc, unstable angina, but no differences in mortality, which were pretty low in both groups. Now, I do want to point out, however, that 99% of these lesions had greater than or equal to 70% stenosis. Okay. They also were able to include 50 to 69% stenosis with an abnormal FFR, but only 1% of the cases had such lesions. So these are pretty severe lesions after a STEMI with multivessel disease. And why is this trial positive where ischemia and courage are negative? And that's because, as Ziad showed you, in patients with acute coronary syndromes, these other lesions are more likely to be TICFAs. Okay, they didn't look at them, with enough completeness to know that that's why this happened in this case, but that's almost certainly the reason. In addition to treating a lot of those pathologic interval thickening histology case anatomies, they were also treating a lot of TICFAs. But that's not going to really help us. Because most vulnerable plaques are non-flow limiting, and we can't see them angiographically. Remember, 99% of those cases are greater than 70%. So what we want to be able to identify is the mild plaques that will suddenly thrombose and cause a acute coronary syndrome or cardiac death. So I really got interested in this field a couple decades ago after the publication of the NHLBI Dynamic Registry. And they looked at 3,700 patients undergoing PCI, and within 1 year, at an untreated site, there was about 6% of the lesions that required an unplanned PCI. And the plaques of these progressed from 42% to 84% at a mean of 5.2 months. So here, for example, is this right coronary artery with mild diffuse disease in the mid-right coronary. And what happened here at 4 months later, you could see there's a sudden progression to a subtotal stenosis. So this is what we actually coined. There's a histologic term for vulnerable plaque, and we coined the clinical term for vulnerable plaque as a plaque that places the patient at risk for a future adverse cardiovascular event. So can we identify these non-flow limiting angiographically mild vulnerable plaques? And the answer is yes. Without a shadow of a doubt anymore, there's about 8 what I would consider really good prospective studies that show using grayscale IVUS, radiofrequency IVUS, near-infrared spectroscopy, and OCT, we can identify plaques that place patients at risk for future adverse cardiovascular events. I don't have time to go through all of this data, but I will just tell you quickly, these are the 4 FDA-approved modalities which can take real advantage, invasive imaging, take advantage of the high signal-to-noise ratio of placing these imaging catheters right next to the plaque and can show vulnerable plaque characteristics, particularly that of an unruptured thin cap fibroatheroma. So again, by IVUS, by virtual histology IVUS, by OCT, and by NIRS, we can differentiate the features that have fibrocalcific disease, fibrous, pathologic intimal thickening, thick cap fibroatheroma, and thin cap fibroatheroma, the ones that we really, really care about. So again, I won't go through all 8 studies, but I will just tell you most recently, 2 of the important studies, Prospect 2, which we recently completed and published in the Lancet, 900 patients who presented with an acute coronary syndrome. We treated all the culprit lesions, and then we followed about 3,500 plaques from 3-vessel imaging that were untreated on maximum medical therapy for 4 years. And the plaques that were at high risk were those that had large plaque burden and high lipid content. And the plaque burden we evaluated by intravascular ultrasound, the lipid content we evaluated by near-infrared spectroscopy. And you can see if there was a plaque burden of greater than 70% and a what we call the max LCBI 4 millimeter from the near-infrared spectroscopy of greater than or equal to 324.7, which basically means it was more than about 33% lipid. Then these plaques had about a 7% adverse event rate over the next 4 years. If they had one of the other 2 characteristics, then the event rates were low. And we had about 2,300 plaques that were not large plaque volume and did not have a lot of lipid, and almost nothing happens to these plaques over a 4-year period, a 0.2% event rate. So we can identify the high-risk plaques. So this, for example, is a case where you can see we treated a high-grade stenosis in the distal right coronary artery. So there's a culprit stent there. And you can see the rest of the right coronary artery. There's kind of mild diffuse 10% stenosis there. We'll call that non-culprit lesion 2. Non-culprit lesion 1 had a slightly more focal, maybe 15, maybe 20% stenosis. The IFR of this vessel was 0.95, okay? When we look at it by near-infrared spectroscopy, okay, for those of you not familiar with this, basically it's very, very simple. Yellow is lipid, red is not lipid. So this is distal, and here's the culprit lesion and 5 millimeter reference. The black line, by the way, is the guide wire artifact. And there's only a tiny little bit of lipid remaining. As we pull back into that non-culprit lesion 2, there's no lipid whatsoever. As we pull back into non-culprit lesion 1, there's one high, very, very high lipid content with this measurement of 687, meaning about 69% lipid, right where that arrow is, okay? When we look at the ultrasound right at that arrow, we can see, again, this is the cross section, and here's what the core lab drew out. The plaque burden is 80.1%. The minimal luminal area is 3.8 millimeters squared. The lipid circumference is about 180 degrees. And you can see, despite this, the IFR is 0.95. So what happened to this patient? He was fine until about 3 years, and then he suddenly presented with a non-STEMI. And you can see right at that spot of lipid is where there was sudden rapid plaque progression. So more recently, we got data from OCT. This was a very nice study that was done by Elvin Ketty called the Combined OCT FFR study. He took 390 diabetic patients, about a quarter ACS, 3/4 chronic coronary syndromes, that had intermediate stenosis, 40 to 80%, with an FFR of greater than 0.8, mean of 0.88. So non-flow limiting intermediate lesions. And a quarter of these were a TICFA by OCT criteria with a mean fibrous cap thickness of 60 microns. And he treated them all with medical therapy. And as you can see, over a 1.5-year period, the TICFAs had a 4 times higher rate of MACE than the non-TICFAs, particularly because of myocardial infarctions. So we can identify these vulnerable plaques. But the question is, what do we do about them? Okay, so here is a 65-year-old man who is the chief executive officer of a Fortune 400 company. So you don't want to make a mistake with this man. And he has exertion, not that we want to make a mistake with any of our patients, but not particularly this guy. He presented just a routine presentation to his doc. And he told his doc, you know, I get a little short of breath when I walk. I'm a prior smoker. I have hypertension. I have hyperlipidemia, but he's taking Lipitor and his LDL 68. So not bad. And so his doc said, well, let's do a stress echo. And he had 1 millimeter of exertional ST segment depression in the anterior leads, but he had a normal resting and stress LVEF. Okay. So you might just treat this patient medically, but because he was a VIP, the doc said, let's do an angiogram to be sure. And here's his angiogram. And the circ in the right looked perfectly normal. And the LAD has got this about 20% proximal stenosis and about a 20% mid stenosis. So I guess you would just stop, right? Well, no, the doc's worried and said, well, you know, you did have a little exertional ST segment depression. You do have some dyspnea. Let's make sure this is not an ischemic vessel. So he does an FFR. And the FFR is 0.88. So it does not meet our risk for ischemia. So now what do? Just intense medical therapy, right? Well, the doc was still worried about this patient. So he said, let's do a Neers-Ivas procedure. So he did a Neers-Ivas. And here's what the frames look like at these 2 lesions. Both of these are highly lipidic plaques. You can see they're above our 325 criteria, 361 and 568, and they're both high plaque burden, 71% and 74%. These are both vulnerable plaques. So they may not be causing this patient's dyspnea today, but they certainly place this patient at risk for future myocardial infarction. And if that happens in the proximal LAD, the patient might die. So what do? Do you put the patient, his LDL 68, do you put him on a PCSK9 inhibitor? Do you do PCI of these lesions? Well, we don't really know because there's no big trials. Now, we do know what happens if you stent these lesions. So this is an animal model of a hyperlipidemic rabbit, and you can create TIFA-type lesions, okay, with a necrotic core and a lot of foam cells and a thin fibrous cap. And we know if you stent these, what you basically do is you compress the old fibrous cap. Sometimes you rupture it, but you compress the old fibrous cap, and there's the stent strut. And then, of course, you get neointima that grows over the stent strut. So you basically increase the cap thickness by the neointimal hyperplasia. So your new fibrous cap thickness is kind of the old fibrous cap thickness plus the neointimal hyperplasia. So you're thickening the fibrous cap. So will this stabilize vulnerable plaques? Well, we did the first pilot study ever to see if this would be a feasible therapy. And this was the Prospect Absorb randomized trial that we published last year. And we took 182 patients who had a non-flow limiting mild lesion with at least 65% plaque burden. And we randomized them to an absorbed BBS plus maximal medical therapy versus medical therapy alone. And this is a pilot study. This is not powered for clinical events. So we followed the patients at 25 months to see if we could safely enlarge the lumen, okay, and put a new thicker fibrous cap on these lesions by using a BVS. And so if you look at what these lesions were like, okay, 182 lesions, here's the QCA. The diameter stenosis was 40%. And we said that if the diameter stenosis is more than 50, the sites had to do an FFR and IFR, and they did, and the FFR or the IFR was negative in 96% of those. So they're really treating non-flow limiting mild lesions. But when you look at it by IVUS, it turns out the maximal plaque burden is 74%. So you can't appreciate this. These are big, bulky lesions by IVUS. And the lesion lengths are about 24 millimeters, 23 millimeters. So they're not that short. And when you look at the NIRS findings, they're also pretty lipidic. Again, the mean is right at or slightly above our cutoff of 325 that really makes us worried. So these are, for the most part, vulnerable plaques. So the answer was, yes, we were able to safely enlarge the lumen with BVS. And this was the minimal luminal area at baseline. And when we brought the patients back at 25 months for routine intravascular imaging follow-up, the MLA had increased to 6.9 millimeters squared after BVS treatment by 3 compared to about the same by medical therapy. And if you looked at the follow-up IVUS and NIRS findings, you can see we put a cap, a new fibrous cap of 210 microns in neointimal hyperplasia above the old fibrous cap. We didn't do OCT here, so I can't tell you in detail exactly what the cap was, but we certainly made it thicker. 65 microns is when we worry about it rupturing. So now we've got probably about 250 or more microns to 300 microns in most cases. And this was very, very safe. These things expanded beautifully in these soft lipid lesions. There were a few continuities. And then finally, while we were not powered for clinical events, when you looked at the randomized lesion-related MACE, we were very optimistic to see that the untreated lesions had about an 11% MACE rate in 4 years, and we seemed to reduce that to 4% by BVS treatment of these vulnerable plaques. And again, the 62% reduction, p-value is only 0.12, but it looks like it's really going to be favorable. We just need an adequately powered randomized trial. So there's one trial that's going on by SJ Park in Korea. This is the PREVENT trial. It's 1,600 patients with these intermediate type lesions and FFR greater than 0.8 with vulnerable plaque characteristics by one of those different either VH-IVUS or OCT imaging tests. And they're randomized to either a scaffold or an everolimus-eluting metallic stent versus medical therapy alone with a primary endpoint of target vessel failure at 2 years. This trial has enrolled about 2/3 of the patients. It may still not be large enough. I'm a little worried about it. It may not be large enough, but it's the only big outcomes trial we've got going on. So finally, what will we do in the future? Well, this was, again, 15 years ago, promoted by Eugene Braunwald as what he thought we were going to do to screen and treat vulnerable plaques. He thought we would start with simple demographic screening parameters like the Framingham risk score. And for those who have relatively high risk based on that, like diabetics, smokers, et cetera, that you can't modify the risk factors, we might do an additional test. Maybe that's going to be CRP to look for inflammation. And then for those with high risk, we might do a non-invasive test to look for vulnerable plaques, such as a CT angiogram. I haven't talked about that today, but it's not bad. And then for those that are high risk after the CT angiogram, we might do an invasive risk to really identify whether they're vulnerable plaques. That would be NIRS, IVUS, or OCT. And if we have a very high risk there, maybe we're going to have a, quote, new treatment, which will be either pharmacologic intensification or maybe stenting or scaffolding. So what do we do about our patient today? Do we treat this patient today? Well, with stents, well, we probably want to make sure his risk factors are ideally optimized. I think we've got enough data to suggest that we should do. Should we stent them today? I would say not today, but after these randomized trials are done, maybe tomorrow. Thank you very much.
Thank you, Dr. Greg, for a wonderful presentation. I think so that was really what we would like to have heard. And I think so Professor Jagat Narula has joined in as well. So we would request Professor Narula if he can speak on the other side of it, preventing myocardial infarction, would meds goes better.
Thank you, Nitish. Can you see my screen?
We do, Jagat.
Can you see the screen?
Yes, sir. We are able to see your screen.
Great.
And you are very audible as well, sir.
Thank you.
And
so I'm truly grateful, Nitish, Dr. Bhandari and Dr. Yadav for the invitation. And my apologies because I didn't know how exactly to negotiate. That is how technically savvy I am. But you cannot blame me because I'm not an interventionist. So I don't have to be technically savvy. So after such a brilliant talk by Dr. Greg Stone, and this is something which probably he would also agree with. And obviously now that we would have Dr. Kern to follow and he would clarify some of these concepts further, I would be presenting a very, very conceptual talk to you. How can we prevent spontaneous myocardial infarction in chronic coronary syndromes? So I would like to discuss optimal medical therapy with revascularization studies over decades and define the importance of the anatomical or physiological extent of luminal compromise in preventing spontaneous MI. Discuss if the pathological characteristics of the lesions could offer incremental value and explain the gap in outcomes as well as in our thinking. And Dr. Greg Stone has pretty much covered quite a lot of it. Discuss the importance of plaque progression as a prelude to spontaneous myocardial infarction. Discuss if optimal medical therapy can prevent plaque progression. Could such a construct help us better place FFR in the management algorithm? And if so, can we shun anatomical stenosis altogether? Because CT angiography gives us all the anatomical, physiological, and morphological lesion characteristics should that become a gatekeeper. And that is what was the last sentence of Dr. Greg Stone also. So we have seen all these studies from decades. It is essentially approximately 50 years ago that we had excellent revascularization studies. And this is the data from the European Coronary Surgery Study Group, where we knew that not only does the revascularization help in improving the lifestyle and reducing the angina, but also in long term improves the survival. Why does it do that? Were these lesions different in those times? Were they high risk, ready to pop? And obviously, we also did not have statins. Were the lesions like this? And this is what Dr. Stone just told us what the vulnerable plaques are or high risk plaques are. So I don't need to go into the definition of the high risk plaque here. So here, almost 50 years later, comes the COURAGE trial, where it shows you that the optimal medical therapy was as good as the revascularization. Now, it was seen as a win for the optimal medical therapy. But I don't believe that it was a win for the optimal medical therapy. And I think it was failure, both for the revascularization as well as medical therapy in 21st century, where you would lose 20% of people in 4 to 5 years. What kind of a therapy is it, be it medical or revascularization therapy? And then we saw the FAME group of studies where we found that the physiological important lesions did better than the anatomically defined lesions. So do we really need ischemia-producing lesions to succeed with revascularization? Understandable for the chest pain, but not understandable for the prevention of myocardial infarction. And at least not so for the functionally severe ischemia, as was shown to us by the ischemia trial. However, the ischemia trial had to reveal something else also. It does tell us that the reason that both the arms were similar were probably because the number of the peri-procedural myocardial infarctions were similar to the spontaneous myocardial infarctions. And that was the reason that we thought that the study was not significant. But is it truly so? But something very similar we will be seeing in the FAME study also. So in ischemia study, the spontaneous myocardial infarction rate. So forget about the perivascular, the periprocedural MI, but the spontaneous MI rate in the conservative arm was 5.8%. Invasive arm was 2.8%, with absolute risk reduction of 3% and relative risk reduction of 52%. What does that mean? Did ischemia demonstrate failure of revascularization to reduce MI, or failure of ischemia testing to guide revascularization? And I believe the second. Now, something very similar was shown to us by the FAME2 study also. This is the 5-year follow-up. And in the 5-year follow-up, we see that approximately 50% of the people at the end of 5 years do not require revascularization, do not develop MI, or have death, essentially telling us that even with the people with FFR of less than 0.8, optimal medical therapy is capable of giving you excellent results in at least half the people. So all lesions with FFR of less than 0.8 may not require revascularization. So how can we identify FFR lesions that are safe to FFR positive lesions that are safe to defer to optimal medical therapy? And that is something which was shown in the sub-study or post hoc analysis of the FAME2 study by Habib Samedi's group, where they demonstrated that by looking at the high wall shear stress, that if the wall shear was significantly high, these were the people who did not do well as compared to those where the wall shear was low, and essentially explaining that possibly it was the plaque morphology which was equally important in these cases. So in significantly ischemic lesions, lack of plaque vulnerability is protective. Again, proving the point what Dr. Stone was presenting. So let's say what the algorithm is. What we thought, that all anatomically significant lesions should be revascularized. And here came the FAME group of studies that suggested that you can bite 33% of the cases where the FFR is not low, and you can take them away. Remaining 66% are the people who should be revascularized. However, this FAME2 post hoc analysis tells you that if I am able to identify the HRP negative group, that is those with the low wall shear stress, these people may be safe to defer, leaving only 33% of the lesions which would require the revascularization. However, what we are missing here is what Dr. Stone just showed to you, that more than 0.8 FFR also might have the problems. So what do we do with FFR? Can we place the FFR differently, and can we better place it? Look at the studies which we have seen in the last 2 years: Forecast, Flower, Future, Ripcot, whatever you can talk of. FFR has not done what the FAME study did to us. So can we do a little better? Some of these here, for example, Flower and others, maybe the ACS, but what can we do with the FFR here? Can we think a little differently? We can create a 2x2 here. And if we created that, and what we just simply say that, look at what Dr. Stone presented to you, forget about anatomy here. Let's go with the CT angiography, identify the high-risk plaques, and say that if it is high-risk plaque, and then it gives you the FFR also, it is safe to defer to the lipid-lowering therapy. But not only that, another huge group would be FFR positive, HRP negative, or FFR negative, HRP positive. Could that be safe to defer to LLT? So what are we left with? Only FFR positive, HRP positive, which require the intervention probably. Why I say that? And again, Dr. Stone might differ here a bit with me, but I would like to prove that to you with a few more things here. We also have seen recently that the FFR also correlates with the not only the QCA or the extent of stenosis, but significantly or almost as significantly with the low attenuation plaque volume on the CT angiography. That if you have a large necrotic core, the FFR will be lower, and that kind of confirms what we used to see with the positive remodeling when the vulnerable plaque is there. So something similar to what the Glagau's phenomenon was that if you have the low attenuation plaque volume higher, you have more likelihood of having an FFR positive lesion. Or in other words, even in the group where the QCA shows you less than 50% lesion, the LAP volume picks up the FFR positivity. So if we go to the CT angiography, we are able to identify the high-risk plaques as many groups, including mine, have shown repeatedly that we have the high-risk plaques. So high-risk lesions can be recognized, and there is a dose and temporal relationship that bigger the low attenuation plaques, more is the likelihood of having an early event, as shown here. Now, not only that, we also demonstrated 3,000 subjects, 10-year follow-up. Endpoint is the major adverse cardiac events here, that if the plaque demonstrated progression over the next 1 year, there was 35 times higher likelihood of having an event over the next 10 years as compared to those where the plaque progression did not occur. If the plaque progression did not occur, there were no adverse outcomes in these cases, suggesting thereby that plaque progression is one of the major problems. Now, here, writing with Dr. Stone, we had presented in circulation research that even those studies, including one of the famous one from Dr. Ambrose and Dr. Fuster, that these plaques which result in events are the small plaques. However, those studies which demonstrated that the plaques were small plaques, they were far removed from the time of event. Those studies which were done within few months before that demonstrated that the plaques were huge plaques. And all the data where you look at after the event has occurred, you will see that most of the plaques that you intervene, they are not flimsy plaque, they are huge plaques, suggesting thereby. And whenever you had the situation where you had two different tests before the event had occurred, and one which was remote and one which was near the event, you will see that there was an obvious plaque progression. Compare the purple to purple and blue to blue bar in this particular diagram, suggesting that plaque progression is a significant phenomenon. And if it is so, can we prevent it? Look at all the studies of the intravascular ultrasound that have been done. They have demonstrated that as the lipid levels are reduced, there is progression which is stopped in these cases. And these are the intravascular angiography studies where you are seeing the, the angiography are on the top and intravascular studies are being shown in the blue color here. And you would see that once we start to come below 70 to 80 LDL milligram percent, you start seeing the regression of these plaques. So you need to bring it significantly lower than even 70 if you are trying to look towards the plaque regression. And about almost a month ago, or even less than that, the HYPHEN study, which was presented at the ESC by Steve Nichols, where they had randomized their patients with the optical coherence tomography assessment, almost 70%, 70 patients on each side, and they were either given the maximum doses of statins or they had an added evolocumab. And as you can see here, that the LDL came down to less than 30 in the evolocumab group. And if you see that the fibrous cap thickness over the period of time increased significantly, almost 90% increase in the evolocumab group, or the group that received the PCSK9 inhibitors. And also, as you can see, this exploratory endpoint where fibrous cap thickness of less than 65 micron was left only in 1/8 of the subjects as compared to 1/3 of the subjects in the group which was treated with the maximal statins. And as you can see here, that there was a clear-cut relationship with the decrease in the LDL in these cases. Not only that, you also know that the events are reduced significantly, and look at all the primary and secondary prevention trials and extend these lines to the hypothetical level that if you want to have the 0 events in the secondary prevention group, you will have to bring your LDL to under 30. And in the case of the primary prevention, you will have to bring it to under the 55 milligram percent. And Fourier trial, which uses the PCSK9 inhibitor, shows you that you can indeed do it. You can even bring to under 15 in about 15% of cases. So we can bring down the LDL to what we are born with. And we are born with 25 milligram LDL, and that is what we need to have. Can it really help us? Look at this, and I would be ending soon with the example here, that here is a subject, again, 25 to 50% lesion, quite like what Dr. Greg Stone was alluding to. Here you see a huge lipid core, large necrotic core, and here you'll see that there's a significant positive remodeling. But in this particular case, again, you will see, however, that there is a significantly lower FFR in these cases. Since there was only 25% coronary artery stenosis anatomically in this particular case, we went ahead and increased his statins and added ezetimibe in this. And within 6 months' time, you will see that the FFR has improved, the luminal stenosis has not changed, and the lipid core has completely regressed in this particular case. So CTA can give us all, give all anatomy, physiology, and pathology. Did ischemia knowingly or unknowingly started right, but they could have concluded it better because they had an access to the CT angiogram in every single case that was included. And that is what we are now proposing with Dr. Stone and Dr. Leslie Shah, whether we can do that and should CTA become our gatekeeper. So fact remains that medicines can do it, but we will have to come up with some where we need to be going with the interventional arm in these cases. Thank you very much.
Narula, it is Dr. M.K. Das. Mrinal.
How are you, Manaji?
Okay, you gave us a very, very important insight about the prevention of the really cardiovascular, coronary artery disease. And both of you, Dr. Greg and yourself, really did an excellent job. Now, my question, since I am taking up from the last line that CTA should be the gatekeeper. Now, suppose a patient is having multiple coronary calcifications at different levels in both right as well as left, but there is no symptom whatsoever. So should I go ahead with the invasive coronary angiography, and then if some lesion comes out, we should take in preventive intervention, or we should even then try with the various medical measures that you have suggested that your patients got, they really improved the FFR or improved the CT level, CT angio level.
So, Miralji, it's a great question, and obviously that's a dilemma, as you can imagine. And my answer would be as equivocal as it was by Dr. Greg Stone, that till we have the trials, we would not be able to say anything. But I certainly believe that we have to put the FFR into perspective. And the FFR has a major role to play, and I would not preempt anything before Dr. Kern has spoken, and I will wait for that. But I believe that if I have a lesion which is giving me a significant FFR value and has a high HRP characteristics, I would certainly be quite be scared of that particular lesion, suggesting thereby that with the FFR being so low, having such a large necrotic core, if there is any hemodynamic perturbance, I think I would be wary that lesion can certainly break. But can I recommend anything at this point in time? I don't think that I can, because I will need to wait for the trials as well as wait for the guidelines for any recommendation. But this was a conceptual framework on which I've been very lucky since Dr. Stone has joined us, that almost on a weekly basis, when I'm able to talk to him, it becomes an enlightening day for me, because we are able to discuss all these points. But can we really make any recommendations at this point? At this point, I think I will stay with the same answer that Dr. Stone gave you after his talk, that let's wait. The data would be there, and I look forward to Greg's leadership here.
Yeah, I agree completely with Jagat. We just don't yet have the data to say you should aggressively intervene in such patients. We learned, from ischemia, if people are asymptomatic, you can't make them feel better. A major benefit of revascularization in ischemia was improving quality of life in patients with at least moderate or severe ischemia and symptoms. But the asymptomatic group, you can't make feel better. So then the only reason to revascularize them would be to try to prevent cardiac death or myocardial infarction. And we just don't have that data yet. So I totally agree with Jagat that the FFR is useful for two reasons. Number one, if somebody's got symptoms and you want to try to understand if the symptoms are more likely to be cardiac and more likely to be due to ischemia, then FFR or IFR can be useful for that reason. And number two, I do think that the greater or the lower the FFR, the more ischemic the lesion, that is actually a marker of more high-risk plaque characteristics. And so, yes, I think those individual lesions are probably higher risk than non-full limiting lesions, although probably most vulnerable plaques are non-full limiting lesions. We just don't have the data yet to say that you should cath and intervene on those patients if they're totally asymptomatic. Today, I would drive their LDL as low as possible. If the patient can afford a high-dose statin tolerated and a PCSK9 inhibitor, that's the way I would treat that patient if he's asymptomatic. But I desperately hope that we'll be able to fund and complete a 3,000 to 4,000 patient randomized vulnerable plaque trial, because I do believe it would be positive for revascularization.
And if I could add one more thing, Greg, and I would look forward to your response to that, that if we have a way to identify, and obviously it will have to be non-invasive and not an invasive way of doing it, if we are able to identify the progression in these lesions, that which are the lesions which are likely to progress, if we are able to identify that, I think that would be the holy grail here, that if we can, that our intervention, is it truly preventing the progression, inducing the regression or not? And if the lesions are rapidly progressive, we probably should be intervening. And if they are not, then probably we could take it slow and we can go with the medical therapy. So I think the most important thing would be on the non-invasive imagers, whether we are able to demonstrate the behavior of these plaques and can provide a little more data for the interventionists to be able to intervene. So I don't know how.
Can I ask? Jagat, this is Prakash Didwania. I think both you and Greg addressed the issue as if there is only single or maybe one or two lesions, but I present to you a question about diabetic patients who have multiple downstream lesions, and whether your CT or other non-invasive techniques will help any further, rather than suggesting that we should aggressively be modifying the risk factor, particularly as you suggested about aggressive LDL lowering. What's your comment on that?
Prakashji, you're absolutely right that diabetes, or for that matter, wherever we have significantly more inflammatory milieu, we basically do have more lesions, and likelihood even could be that they would be even more rapidly progressive as compared to the non-diabetic patients. But with this effective intervention at the lipids and bringing down the lipid levels to, say, 30 or something like that, which eventually would most likely become a goal. And if you have recently read Dr. Braunwald's viewpoint in European Heart Journal, bring it down to 30 and live for 100. I think that's a very valid point there. And my belief is that there are most of the cases, if your LDL is down, the inflammation would significantly come down, regardless of what milieu do I create. And there will only be a few people left where the inflammation would be out of proportion to the LDL insudation. So likelihood is going to be that you bring the LDL down, your patients will do well, be it diabetic or be it non-diabetic. And the best part is that your own work, Dr. Didwania, that you people now have come up with so much of the cardioprotective drugs also. I think we would be in a very different arena now than what we were forced to be dealing with earlier. So I think with bringing the LDL down and having the other better drugs around us, which are cardiovascular and renoprotective, I think we should be able to do much better.
Thank you.
Dr. Narula, thank you very much for the comment. I do agree that the LDL reduction goes a long way in preventing coronary artery disease. About CT scan, I just want to ask you one question. How many times a patient can, or for that matter, a gentleman can take CT scan without any hazard radiation harm? And secondly, in the ischemia trial, before randomization, the patients had a CT angiocoronary done before randomizations. And 16% of the patients who were thought to be having a significant lesions were found to be having minimal lesions. And that probably is one of the criticism of the ischemia trial as to what is the outcome finally.
Great questions, Dr. Datta. The few important things here, that CT angiography now, if we do it right, and if we can do the prospective gating with the properly managed heart rates and all, I think we can now do these scans in less than a millisievert now. So with that kind of a situation, I don't think that there is much of a problem in doing CT angiographies, even if you are not able to bring it down to 1, even if it is 2 or 3. I mean, we have been sending our patients for nuclear imaging, where we give between 12 to 30 millisieverts of radiation. We do them like the annual nuclear scan, which is not done as much these days, but that has been the practice that we have been following. So CT angiography from that perspective is an extremely safe phenomenon. I mean, my one trip to Dr. Morton Kern in Los Angeles and back probably gives me more radiation than a CT angiogram. So I don't think that radiation is that much of a challenge, and I think we need to educate the people better. Now, as far as some of the false positive and false negative are concerned, yes, we definitely have a lot of inter-observer variations and intra-observer variations as also, and the reasons are obvious. And they will gradually be sorted out as we improve the resolution of CT angiography further. It is 0.5 millimeter as yet. So you can imagine that whenever you are looking at a 2 millimeter lumen, it could be interpreted as 1.5 or 2.5, and that changes your entire perspective in these cases. So the way it is going to be better defined, that you now see that there are significantly large number of automated based on the artificial intelligence softwares which are becoming available. And again, Dr. Stone is very heavily involved in evaluating some of them. And I'm fortunate that I'm able to work with Dr. Stone on them. And we should be able to exclude quite a lot of inter-observer and intra-observer variations once we go to the machine learning methods here. So I'm hoping that that problem would be sorted out relatively soon. So, but again, with any test, such a problem can occur. And all the interventionists are absolutely stalwarts on this panel. They all know that when we look at the coronary angiograms also, people interpret them as 30% versus 70% as well. So those things do happen in our test. And but as the time goes by, I think our science will become more perfect and more accurate.
Thank you, sir, for the fascinating. This was really a fascinating session, and we can't thank you enough for giving these fascinating talks. And as we are running terribly short of time, we will have to move on to our next session. And I would request our chairpersons, Dr. Dev Pelajani, Dr. Goswami, Dr. Khalilullah, Dr. P.K. Dev, and Dr. Naran to take over proceedings.
Hi, everyone.
I request Dr. Khalilullah to introduce our first speaker, Dr. Morton Kern.
Thank you, Nitish, for inviting me to this very important conference of the National Conference on the Scientific of the Hello.
We can hear you, sir.
Yes, it's the National Conference of the STEMI Council of CSI, and there are two very important speakers. The first is Professor Morton Kern. He is the head of the Department of Cardiology at the Long Beach, California, and Professor of Medicine at the University of California. He is deep interest in the study of coronary physiology and also in interventions, and has two important books to his credit. He's going to speak on FFR in STEMI. Why did the flower fail to blossom? Professor Morton Kern, please.
Thank you. Can you hear me okay? I'm going to share my screen.
Yes.
Very good. Let me just pull this up, and I will go ahead and run it. Let's see here. Share and run. Okay. Well, I think there's a problem with our discussion of the vulnerable plaque, because the vulnerable patient may not always be identified correctly. So I'm going to focus our discussion first on FFR and STEMI on this particular trial, which was a negative trial for the favorable outcomes related to FFR, but probably for some good reasons. And second, I think we should not conflate stable ischemic heart disease and FFR values directing outcomes with acute coronary syndromes and FFR directing outcomes, because they're not identical groups. But let's just start right in. My conflicts include those companies that make pressure measuring equipment for physiology. That would be no mystery. I don't think I'm an equal opportunity insulter, so I get to use all these devices. And I just want to start right here and give you the landscape of the field. So when we talk about treatment of STEMI and multivessel disease, there has been three schools of thought. There was originally the culprit-only approach. There was the culprit plus staging all the others, either at the index hospitalization or time of procedure or after discharge and returning them, or the immediate do all at one setting. And there have been a number of different trials, which I'll highlight to you, which have attempted to put these all in perspective. And then I'm going to bring us down to the Flower MI study to show us where that fell and what it gave us. So let's just take a look. Here's just a brief summary of probably the 5 most relevant studies related to treating the non-infarct related artery in the stable STEMI patients. And the oldest ones were angio-based, that is PRAMI, culprit, and dynamic. And my dog is here. And then the most recent ones are the compare and complete studies, which added in FFR, close to the dynamic 3 study. And all of them demonstrated that complete revascularization was a superior method for fewer events, mostly related to repeat revascularization or MI. And these studies now led the way for the Flower MI study. Now, the complete infarct-related revascularization study versus infarct only showed benefit to complete revascularization. But recall Dr. Stone pointing out to us that most of these non-infarct related arteries were very severe, greater than 70% in diameter and positive in FFR. Very few were negative. So it's hard to know what a negative FFR or positive FFR in a minimal lesion might indicate. So here we are with the Flower MI study. Now we know that culprit lesion approach is not taken up anymore. We're trying to do complete revascularization as best we can at the time or shortly thereafter. And immediate total revascularization, again, is an issue. And the Flower MI study took culprit lesion and looked at the additional non-culprit lesions, angio versus FFR guided approach to treating that additional lesion. And they did it mostly at the index hospital, but they did stage some of these individuals. So if you follow that blue circle down, you'll see the comparison between angio-guided and FFR-guided revascularization. And randomization occurred not before identifying which lesion they were going to treat, but after they identified it. The study was presented at the American College meeting last March, and Pari Mirat from the University of Paris in France and colleagues presented this data. Here is the bottom line for this study. Multivessel PCI by FFR or angio for MI in this Flower study showed no difference in those that were guided by the angiogram compared to the FFR guided approach. This is contrary to almost everything we've seen before, but there have been almost no studies in the acute STEMI patients using this randomized approach to purely angio-guided or FFR-guided. Remember, the number of patients in the FAME study having acute STEMIs were very small, unstable angina, relatively few. So this large study of 500 plus patients in both arms gave us some pause on where the FFR might be helpful. Now let's look at some of the detail, because it's always in the details that our understanding increases. So major adverse cardiac events, no difference. Death from any cause, no difference, very low number. Myocardial infarction rate, numerically a little more in the FFR, but no difference. Unplanned hospitalizations, no difference. But in the urgent revascularization, need to come back, it looked like the FFR guided group had about twice as many as the angiographic guided group. Now, what does that really tell us? It tells us that, again, no difference was identified for these secondary outcomes of any importance. That is, stent thrombosis, any revascularization, hospitalization for heart failure, recurrent ischemia, or almost any reason. FFR didn't sort out those individuals. And unfortunately, or fortunately, the quality of life indicators and recurrent angina were similar. So is FFR not important for this approach? And I think there are some limitations which we'll look at. I thought it was also interesting and contrary to what I learned in the FAME study that the economic analysis, the bootstrap analysis of the FFR approach was no better than the angiographic approach. If you look at their graph and plot, the red dots are the quality are the cost. Higher is more cost, lower is less cost. Here's your zero line. And difference in efficiency, meaning outcomes. The blue plot is here with better efficiency, better outcomes on the right than on the left. And they are above the cost line and actually worse slightly as a group. And this was translated into a $500 to $600 savings in dollars, absolute dollars. And the findings were contrary to the FAME study, which I'm showing you here, in which the FAME study had most of their outcomes down in the better quality, lower cost approach. And this is in a predominantly stable ischemic heart disease group, whereas in the STEMI group, this was not the case. So we have to think carefully as to why these two had such different outcomes. Now, The investigators concluded that, of course, the major adverse event rate for this size population is low, and that's quite good. Non-culprit revascularization was done on the investigator's preference as a stage procedure. So there may be some bias involved. The FFR-guided approach to the non-infarct related arteries didn't reduce endpoints, as I showed you, and the cost was really no difference. Now, not everything is the same as our prior history tells us. We know that no matter what kind of FFR measurements you make, they're always worse, and outcomes are always worse if they were made in an acute coronary syndrome group. So this group from Lee and Neurointervention a couple of years ago says that the event rates were always higher. Here it is broken down on the right by stable, unstable, and non-STEMI, and the same findings occur. That is, differences in lesions are present regardless of the FFR outcomes in the acute coronary syndrome. They are a different population than stable ischemic heart disease. Where the transition from stable to unstable occurs is the mystery, and probably at the heart of the discussion of Dr. Narula and Dr. Stone. Here's another example recently, or not recently, but another long-term outcome study demonstrating that stable ischemic heart disease has fewer events in the deferred population than unstable and non-STEMI in the deferred population of FFR patients. So you can't always base a negative FFR on deferring in the acute coronary syndrome. And again, the same data is plotted over here on the right, showing that if you have an FFR of 84 in the acute coronary syndrome, your event rates are lower. If you have an FFR of 81 or greater, your event rates in the stable ischemic heart disease are 1/4 as much as in the acute coronary syndrome. So this clinical substrate really impacts how we should interpret and use FFR in these patients. We also know that regardless of FFR, let's just look at the presentations, these are factors which impact events in deferred artery populations, acute coronary syndromes, diameter stenosis, multivessel disease, prior revascularization, diabetes, and so on. And of course, if your FFR is low, that's a factor portending future events. So that's not a good finding. Now, if we look closely, why did the flower not bloom in this study? I thought that was a kind of a cute topic. And this is a challenge for us believers in FFR to understand what to do. But let's just take a look. FFR identified 1/3 of the non-culprit lesions that could be safely deferred without anything happening. So that's a plus. Rather than treating every one of them, if you FFR, you are going to identify benefit. FFR supported deferring unnecessary interventions. It does in the FAME studies, in the defer studies, and in a lot of studies. In this one, you could defer as well because there was no difference in outcomes. Now, the FFR significantly reduced the non-culprit PCI by 40% compared to an angio-based strategy. And remember that we discussed angio assessment of lesions always is subjective in the clinical setting. And interventionalists see a 70% lesion as 90, and non-invasive cardiologists see a 70% lesion as 50. So we should think about that. And we do know historically, if you don't put in more stents, you are going to save money. Now, limitations of these types of studies which randomize 2 strategies for different indications does create problems. So the inclusion of lesions that are indicated by angio and both by FFR, they get the same treatment. Thus, any difference would be diluted in those individuals. Probably some of that occurred here. And that there was a large inequity in the number of non-culprit lesions in the FFR group compared to the angio group. This was operator bias, and there was a significant number more in that group. There was no blinding to the outcomes. That's a problem. And that lesions planned to undergo PCI should be identified in advance of the randomization to the 2 strategies, and this was not done. So let's just take one more look. I think this study was excellent. I think it highlighted both the limitations of FFR and the pluses of FFR and the physiology for these patients, but it should highlight the fact that the ACS population behaves differently and has a future need for other information than simply the FFR alone. Now, unanswered question. So should we be doing everything at the same setting, stage versus multivessel? Question to be answered. That's the same question down here. When you have a culprit lesion with others, you do it in the same hospitalization. That is, maybe not the same day, but at least the same week. Or should you wait several weeks after and bring them back? And if you bring them back, should they have an indication of ischemia? The treatment of the asymptomatic coronary artery disease patient is a problem. And we create that problem ourselves by performing unnecessary testing. If we do an angiogram in an asymptomatic individual and find disease, we are confronted with a very challenging decision. And Greg Stone pointed out one of those cases to us earlier. Now, IVUS or OCT guided intervention compared to FFR guided intervention is a question remains open. And I think in both the timing and the acute events, this question could be very important to our approach in the STEMI management of these patients. So I'm going to stop here and leave time for discussion. I think that Dr. Narula covered the world of vulnerable plaques as eloquently as ever, and Greg pointed out the highlights of our limitations on this. I would just like to redirect our discussion and think again, should we be doing a lot of work on the silent ischemia question, or did the ischemia question get answered, which I don't think it did? And in the asymptomatic individuals, not these ACS patients, should we be addressing the challenge of positive FFR with the high-risk plaque, even though they are asymptomatic? So I'm going to stop there and hear some discussion. So I thank you all and look forward to questions.
Dr. Kern, Dr. Palajani here from Bombay. I got one question. How reliable is FFR during an acute myocardial infarction? Because there have always been some apprehensions that during the acute phase, there is a vasoconstriction. You may not be able to achieve the maximum hyperemia. So does this interfere with the actual readings if you did it on the day when the patient got an acute myocardial infarction and perform the FFR a little later? Have there been studies, there is a difference in the FFR readings?
So that's a good question. So let's just look at it. In the culprit vessel, we never use FFR. In the non-culprit vessel, a positive FFR is always positive. In the non-culprit vessel, a negative FFR is problematic on occasion because if that non-culprit vessel is close to the infarct territory, you will have a diminished hyperemia and you will have a potential false elevation of FFR. The last thing is that if you measure FFR and you remeasure it again in 3 months in that same individual, the number is almost always the same. That is, Bill Fearon in Stanford did that study years ago in the non-STEMI patient, non-culprit. It's a stable measurement. So yes, you can use it, but you must consider how close it is to the infarct zone. That's an unknown. So if it is positive, it is positive. Nothing will make it falsely positive. If it is negative, then the concern exists. But I don't know how much of that played into the Flower MI study because we just don't have that data. I don't know if that was helpful, but we try.
And who would like to present the paper next to Dr. Barton-Kerr? Dr. John Eichelboom, please. We'll keep the discussion at the end of 3 presentations.
Well, good evening, everyone, and sorry about that short delay. I'm delighted to be with you, and I'm going to change course of the discussion somewhat and address the issue of antithrombotic therapy with direct oral anticoagulants in patients with coronary artery disease. And I think you can now see my screen shared. I'm going to address 3 aspects of antithrombotic therapy with DOACs in coronary artery disease. And firstly, to set the scene, the long-standing potential role of anticoagulation pre-DOAC, which was never realized. Secondly, I'll talk to you about the evidence for dual pathway inhibition, and I will conclude with some comments about the implications for clinical practice. Of course, when we speak about antithrombotic therapy, we should not ignore the fact that it is only one of what I like to term 3 pillars of cardiovascular prevention in coronary artery disease. That is 3 pillars of pharmaceutical and lifestyle intervention to prevent further events. And the one, of course, is smoking. The second is medical risk factor modification. And the third, antithrombotic therapy. In terms of antithrombotic therapy, antiplatelet therapy has been the foundation for many years, particularly aspirin. We've tried to improve on aspirin by replacing it with clopidogrel, by adding clopidogrel to it, by adding ticagrelor to aspirin, by using ticagrelor alone, by using prasugrel, and indeed, we've tried warfarin and various DOACs. Today in 2021, the one oral anticoagulant left standing is rivaroxaban. More on that in a moment. But the potential for oral anticoagulation to be effective was first suggested by trials of warfarin. And we have a number of trials where warfarin was added to aspirin or where warfarin replaced aspirin. I've tried to summarize 2 of the meta-analyses on this slide. We see that the composite of CV death, stroke, or myocardial infarction was reduced by 1/4 when we add warfarin to aspirin, but no mortality benefit and a big increase in bleeding. When we replace aspirin with warfarin, we also see a benefit, but we do not see a significant mortality benefit, and we pay the price with bleeding. Accordingly, oral anticoagulation with aspirin has never become a foundation therapy. And as warfarin was being tested, ticagrelor and clopidogrel emerged, and clinicians realized that dual antiplatelet therapy was at least as effective or more effective and had less bleeding. There has been, in the past, a lot of evaluation of the DOACs. And one of the first studies was with zimalagatran, the first direct oral anticoagulant to be approved, at least in some countries. But this agent, although promising in post-ACS patients, was withdrawn from the market because of liver issues. The Bigatran and apixaban were both tested. The Bigatran phase 2 study did not suggest a benefit. The apixaban phase 3 study was stopped after almost 10,000 patients were randomized, stopped early because of harm. And in APPRAISE 2, apixaban was used in full therapeutic doses on a background of antiplatelet. Well, in that context, we now have an approach using a DOAC in combination with aspirin, which has been tested both in the acute phase and in the chronic phase, and has realized MACE and mortality benefits. And I'd suggest to you that this is the new standard for long-term antithrombotic therapy in patients with coronary artery disease. So let's look at the evidence to support that suggestion that dual pathway inhibition with low-dose aspirin in combination with low-dose rivaroxaban is the new standard. I'll start with the Atlas ACS TIMI 51 study. And although rivaroxaban is not approved around the world in the immediate post-ACS setting, this trial conducted by the TIMI group established that when we add a low dose of rivaroxaban to background antiplatelet therapy, we reduce MACE and we reduce mortality. For various reasons, this regimen wasn't approved in the United States. It was approved in Europe, but clinicians have been cautious about using triple therapy, and therefore this has not received as much use as one might have expected, based on the results, a 16% reduction in MACE, and with the 2.5 milligram dose, a clear reduction in mortality. But it certainly demonstrated the efficacy of the low dose of rivaroxaban. In the long term, the COMPASS trial took that same dosing regimen and applied it to apparently stable chronic coronary or peripheral artery disease patients. The trial involved 27,395 patients, so a very large study, 3 arms with the combination of rivaroxaban and aspirin, rivaroxaban alone, or aspirin alone. The trial was to continue until 2,200 participants had experienced a primary outcome, but the trial was stopped early because of clear benefit of the combination. And I'll show you the data in a moment, but the data are absolutely consistent with what was seen in the ATLAS trial that I've just shown you, with one important exception. The hazards of bleeding were substantially lower, presumably because we didn't use dual antiplatelet therapy. The majority of patients in COMPASS were randomized after 1 year, that is at least 1 year post ACS. Many patients were in various chronic stages of coronary artery disease. Now, it's notable that almost all patients enrolled in COMPASS were receiving effective state-of-the-art secondary prevention therapy. 90% on lipid lowering, 70% on ACE-ARB, 70% on beta blockers, and almost 90% on aspirin. And this is key, and we'll come back to this later, because the benefits of low-dose rivaroxaban were realized when it was added on top of all of these effective therapies. The key results of COMPASS are shown here. There is a 24% risk reduction in MACE. That may seem somewhat modest, but I'll give you some perspective on that a little later on. This risk reduction was evident early. There was a consistent reduction in CV death, in stroke, and in myocardial infarction, particularly when we looked at all types of acute coronary events. The 3 most striking features of COMPASS are probably, first, this reduction in stroke. There was a 49% reduction in ischemic stroke seen with low-dose rivaroxaban plus aspirin versus aspirin, also seen with the 5 milligram dose, although overall the rivaroxaban alone arm did not realize a significant benefit. It did reduce stroke with no excess of hemorrhagic stroke. And it's notable in this coronary disease population that for every 3 MIs, there were 2 strokes. So this is important, not just from the perspective of preventing a potentially disabling disease, but also because it's a common condition, even in coronary patients who don't have a history of stroke. The second key result from this trial was that low-dose rivaroxaban reduced major adverse limb events. In fact, low-dose rivaroxaban reduced the need for amputation by about 50%. Very low event rates, but there was a population of patients with peripheral artery disease in this study, and this was a striking result, the second of 3, the third being a clear-cut and compelling reduction in all-cause mortality. As you all know, it's incredibly challenging to find therapies that save lives. And when we get a clear-cut, a robust, a compelling reduction in mortality, it emphasizes the net benefit of the intervention. This mortality reduction became evident very early. In fact, striking that even in the first 3 to 6 months, there was a mortality benefit. The estimate remained very stable. Over time, the confidence intervals became narrower as the number of deaths accumulated an 18% risk reduction. This is a secondary analysis of the mortality benefits. If we divided the population according to the presence of polyvascular disease, of renal dysfunction, of mild or moderate heart failure, and of diabetes, and we evaluated the benefits of low-dose rivaroxaban plus aspirin versus aspirin in various subgroups, we see that if a patient has 3 or 4 of these clinical features, they have an almost 5.5% or 53.9 events per 1,000 patient treated reduction in mortality over 30 months, a number needed to treat of 19. This is a remarkable survival advantage in the highest risk patients. There is a price to pay. Of course, this price is already captured by the mortality benefits, but over 3 years of follow-up, there was about a 1.4% increase in major bleeding, about 0.5% per year, or just under 0.5% per year. This excess of bleeding occurred almost entirely in the first year, was almost entirely gastrointestinal, with no excess of fatal or intracranial bleeding. Keith Fox and others have published with Jan Steffel in Circulation the net benefits. This is not taking into account total mortality, but simply balancing the reduction in MACE against the numerical excess of symptomatic bleeding into a critical organ or fatal bleeding, remembering that there was no significant excess thereof. But you will notice that in the first year, in the second year, and in the third year, there is a clear net benefit, which actually becomes greater and greater over time, because any excess of bleeding appears to be confined to the first year. To provide some perspective, low-dose rivaroxaban plus aspirin produces a 24% relative risk reduction. This compares favorably with other antithrombotic strategies, aspirin 19, clopidogrel in an overall chronic population about 9%, a combination overall in a population versus aspirin about 7%, and even aspirin plus ticagrelor, which is a very effective treatment, a 16% reduction, and no significant reduction in mortality in any of these except with aspirin alone, rivaroxaban an 18% relative risk reduction. The benefits of low-dose rivaroxaban are on top of routine therapies such as were employed in the COMPASS trial, an additional 24% risk reduction in MACE, an 18% reduction in mortality, and a 42% reduction in stroke. Well, what are the implications of these findings for clinical practice? And I will be brief, but highlight what I believe are some of the key messages taking away from here for prescribers, for those who care with patients with coronary artery disease. There are 2 ways in which we can identify the ideal patient, and the ideal patient is almost certainly the patient who is at highest baseline risk because they derive the greatest benefits. We can identify such patients by clinical features such as polyvascular disease, the presence of mild or moderate heart failure, chronic kidney disease, or diabetes. So patients with coronary artery disease with these features are amongst those who derive the greatest benefit. This is illustrated here for the overall population. We prevent 23 events for 1,000 patients treated for 30 months. This increases to 31 in the diabetes patient, in 36 in the renal impairment patient, 44 in the heart failure patient, 60 in the polyvascular patient. And for a patient who has 3 or 4 of these, the mortality benefit is 53, 1,000 patients treated for 30 months. One word about the post-PCI patient. There has been for 20 years relentless messaging that dual antiplatelet therapy is the strategy of choice. More recently, we've seen de-escalation of dual antiplatelet therapy early on post-PCI. In such patients, ticagrelor alone may be an attractive option. In the COMPASS trial, among those who were at least 1 year post-PCI, if we added a low dose of rivaroxaban to aspirin, we saw a 1/4 reduction in MACE and a 1/4 reduction in mortality. And this was evident irrespective of whether a patient was 1, 2, 3, 5, or even 10 years post-PCI. So a dramatic benefit for long-term secondary prevention. We can also identify the high-risk patient by various scoring systems. We can look at the number of cardiovascular risk factors, the number of medications they're taking, or even their CHADS-2 score, which is a useful predictor even in the absence of atrial fibrillation. The plots are shown here. The steeper the curve corresponds with the more risk factors, higher baseline risk, higher absolute benefits, more drugs at baseline, more cardiovascular drugs, more of any drugs equivalent to higher risk, which means greater benefits, or higher CHADS score, more risk, greater benefits of the dual pathway regimen. My final slide, let me summarize. Rivaroxaban is already the world's most widely studied and approved DOAC. In the context of coronary artery disease, it's the first and only oral anticoagulant that has been shown to save lives and prevent MACE. Highest risk patients derive the greatest benefits. I think this is the new standard of care. It takes time for practice to change the guidelines to incorporate these recommendations, but the challenge is before you. This treatment is now inexpensive in India. It's generic, it's readily available, and we can treat a higher proportion of eligible patients, thereby further reducing the huge burden of morbidity and mortality due to cardiovascular disease in India and worldwide. Thank you very much for your attention.
I can boom. We now go to the next speaker, Dr. Prakash Didwania, who is a very well-known cardiologist to the whole country, and he is an outstanding contribution in the field of hypertension, ischemic heart disease, and heart failure. He has about 1,000 publications to his credit, and is a very popular speaker in all national and international conferences in India. Prakash Didwania, please. We're going to talk on STEMI and diabetic mellitus, how to manage a real difficult challenge. Dr. Prakash Didwania, please.
Thank you very much. I'm pleased to be joining this August faculty on this topic of STEMI in diabetic patients. I think we clearly know that diabetes is affecting a lot of patients in India, and particularly when it comes to the cardiological disorders, we can see that 60% of the patients will have some other manifestation of diabetes. As you can see here, India has one of the largest population of diabetic patients, and there is certainly a lot more to come with ongoing dietary habits, lack of physical activity, as well as poor dieting is going to lead to further tsunami of diabetes in India. It is expected that a child born 2 or 3 years ago will have 50% risk of developing diabetes or related problem. I think it is also very well known that coronary heart disease is significantly more prevalent, as well as the mortality of CHD patients is 3 to 4-fold increase in men, and also significantly increase in women. Patients with diabetes and coronary artery disease who come with STEMI have an increased risk of death immediately and subsequently, as well as higher risk of developing heart failure. Rate of reinfarctions are also high, and diabetic patients with established CAD develop more severe congestive heart failure. I think we can easily surmise that patients who have STEMI are going to be a substantially higher risk. This is some data from 3 different studies. This is from Europe, China, and you can see that patients who present with myocardial infarction, almost 2/3 of them will have either pre-established diabetes, shown in the brown color, or pre-diabetes that is to be diagnosed during the acute event, and only about 1/3 of the patients will have normal glucose tolerance. It is also very well known that not only acutely, but subsequent to the myocardial infarction, patients with diabetes will have a much, much higher mortality and event rate. Here we see the data for 1-year mortality. And when we look at the highest risk of death in post-ACS patient, of all the variables listed here, diabetes probably trumps the risk. 2.5-fold increased risk, as I mentioned earlier, in all comers in all different studies. Now, there are very few studies about STEMI and diabetes in India, but here are some of the data from other countries. This is from TIMI group, 11 independent TIMI study group, including 62,000 patients, 46,000 of whom had STEMI. And what they showed was that mortality at 30 days was significantly higher among patients with diabetes as compared to those without, as well as diabetes was independently associated with higher 30-day mortality and led to subsequent poor outcome. Now, obviously, the goal here should be to prevent the acute mortality, but also keep in mind, as shown in the East-West study, that patients who survive the STEMI in the diabetic setting will have twice the mortality overall as compared to non-diabetics. So not only the acute phase of STEMI, but subsequent follow-up will present these patients for subsequently higher risk. Now, what should we do? That's the question posed to me. What to do during a STEMI in a diabetic patient? Obviously, the first and foremost is we should get them to the hospital as quickly as we can. And that's not always feasible or always seen in diabetic patients. Here are the data from a study from Pakistan, similar to the environment here. We see the non-diabetic patients at significantly less, diabetic patient has significantly less presentation to the hospital within the critical period, which we consider 1 to 3 hours or even 3 to 6 hours. And the reason for them were several fold. And here we see that many diabetic patients did not believe that they had a heart attack because their symptoms are frequently atypical. They do not develop the typical crushing chest pain. Many of them may have silent heart attack and have unusual symptoms like diaphoresis or uneasiness, etc. And of course, other factors play a role as well. This is a study from China where obviously the overall risk is increasing. Here is a study of 35,000 patients with acute MI, a recent study published in 2019. And this is one of the largest studies that provides the evidence that acute MI patients with diabetes were more likely to have atypical symptoms, took a longer time to present to the hospital. And this is very important wake-up call for us clinicians to be aware of recognizing acute MI patients rapidly and reducing delays in diagnosis and treatment, particularly in context of diabetes. So clearly we can see that in this Chinese CAMI study, 22% of the patients had diabetes. As I mentioned to you, that they were older, more women, higher body mass index, fewer diabetic patients presented with persistent precordial chest pain. The message here being they need to be alerted ahead of time. Any diabetic patient should be educated to present to the hospital immediately when they have unusual symptoms. Now, what can we do in terms of the treatment? When they come to the hospital, I think in countries like India, it is quite feasible to get them thrombolytic therapy immediately, unless they happen to be in a larger metropolitan area where primary PCI can be done and should be instituted immediately. As has been plentifully discussed, it is well established that primary PCI will be helpful if feasible in diabetic patients, which may be challenging, particularly if they have multivessel disease, but infarct-related artery can indeed be recanalized. Or as you heard from Morten Kern and others, that complete revascularization is probably the best way to approach multivessel disease patients. And it is challenging in diabetic patients. FFR-guided complete revascularization prior to discharge is indeed helpful in across the acute MI populations. As shown here, you can see the rate of mass is much lower. Mortality may not be significantly different. And to total revascularization, when feasible, will avoid subsequent issues. 64% of the patients in this culprit trial received multivessel PCI in the same setting, and they did significantly better as compared to those who only had infarct-related artery recanalization. Now, one of the major issues, as I presented earlier in questions with Dr. Narula, is unfortunately when patients with diabetes present to us with STEMI, they have multiple lesions in addition to what we have related to the infarct. As you can see in this particular coronary angiogram, there are so many lesions in so many vessels and the tributaries of vessels that it is quite challenging to have total revascularization. So stenting has been tried in this setting, and what has been shown is that, of course, in diabetic patients, the earlier stent, the evolocumab or Plaxitel stent, did not show any significant benefit in terms of the primary event, which was cardiac death, MI, or total revascularization. Here we can see the newer stent, however, is a different story. This is with Resolute stent, with Zotero stent, and here you can see in diabetic patients, the outcome was significantly better and equal to that in non-diabetic patients. So clearly with the improving in technology of stents and medications that are coating the stent, we may be able to provide acute stenting in diabetic patients with good results. Now, the reason diabetic patients have higher event rates post-stenting or post-PCI is very well known to all of you: endothelial dysfunction, impaired platelet function, altered coagulation, and decreased fibrinolysis, as well as what leads to stent stenosis, increased smooth muscle cell proliferation, which really is quite responsible for many early stent restenosis. It has already been discussed extensively that antiplatelet and the antithrombotic agents are quite useful. I just want to show you that as compared to just clopidogrel, in Triton study, they showed that diabetic patients did significantly better when they were treated with prasugrel, and similar results have been seen with ticagrelor. And you can see the benefit that was seen in the Triton study was predominantly in diabetic patients. And if you take the non-diabetic patient, the effect is much less. They also showed that the major bleeding was not significantly higher in diabetic patients, although in non-diabetic patients it was somewhat higher, and the net benefit was quite good in diabetic patients. As you can see, the curves separate from the early on time, from the get-go, and continue to diverge, and giving us the message that in this highly thrombotic milieu of diabetic patients in the acute coronary syndrome STEMI setting, that perhaps using, at least initially, dual antiplatelet agents, especially in patients with PCI, would be extremely beneficial. Now, the last point I want to talk about is hyperglycemia that is directly related to the outcome. It has been shown that many patients with STEMI, in this particular large study, more than 4,000 patients in the 3 TIMI trials will have higher glucose, particularly those with diabetes. You can see here the number of patients who have hyperglycemia. And it has been shown in studies that patients who have the highest level of glucose are a substantially higher risk. This is the odds ratio for death by 30 days. Those who had a higher level of glucose, particularly above 200 during the acute setting, had significantly higher event rate. And admission glucose in acute MI patients in other studies has also been shown as a marker of independent marker of mortality, both at 30 days and at 1 year. Those patients with diabetes, or particularly those without diabetes who show acute reactive hyperglycemia, and they may not be previously diagnosed with diabetes, but with the stress of STEMI, they develop hyperglycemia, they actually have the worst prognosis. So we were involved in developing a statement from American Heart Association about what to do with hyperglycemia in the setting of STEMI in diabetic patients or even non-diabetic patients. It was emphasized that patients admitted to an ICU with acute coronary syndrome, glucose levels should be closely monitored. It was also suggested that it is reasonable to consider intensive glucose control in patients with significant hyperglycemia, particularly plasma glucose above 180 milligrams per deciliter, regardless of the history of diabetes in the acute setting. And we can see here that the recommendation we made was, although efforts to optimize glucose control may be considered in patients with milder degrees of hyperglycemia, we don't have a very strong evidence. This was a level of evidence was just consensus. Data regarding benefits from this approach are not yet definitive, and future randomized trials are needed, and these trials have been done and have not been very promising. The precise goal of treatment is also undefined, and as such, we said that we should avoid hyperglycemia and keep the levels somewhere between 90 to 140 milligram deciliter, in no case lower than 180 milligram per deciliter. Now, I want to conclude by emphasizing, as I always do, that in patients with diabetes, it's not just enough to treat them with interventions acutely. They never get complete revascularization. Most of the patients don't. They continue to have a large burden of vulnerable plaques. So it is very critical to provide a multifactorial comprehensive risk reduction in diabetic patients. And I'd like to present to you this very well-known landmark study of STENO2 that showed that when they were able to control not only the glucose and reduce glycated hemoglobin, but also cholesterol, triglyceride, and blood pressure, they showed a substantial reduction in subsequent outcome in these patients. So I'd like to conclude by emphasizing that yes, in the setting of STEMI, we should do whatever we can for the diabetic patient, the usual measures that we all do, recanalize, thrombolize whatever is feasible, do complete revascularization when we can, use dual antiplatelet drugs, but don't forget the subsequent comprehensive risk reduction in these patients to achieve the maximum protection for future. Thank you very much for your attention.
Thank you, Dr. Prakash Didwania. It was an excellent presentation of STEMI and diabetics, how to manage. In fact, it is the biggest challenge we have in the country. And stringent restriction that we have is in STEMI and diabetics restricted due to the load of dye in these patients. And that becomes a big dilemma. What do you suggest should be the strategy? Should always be stage PCI, or you would say the multivessel PCI at the time of the STEMI?
No, I think we should do a stage PCI because it's going to be challenging to do it in the acute phase. And during the acute phase, diabetic patients have much more thrombotic milieu. They have activated system, and diabetic patients, as we well know, have multiple problems, and it will really present a challenge to the interventionist to do the total revascularization. And also quite often it takes much longer because there are multiple lesions. So I think it will be best to provide acute, rescue PCI or primary PCI. And then as time allows, after good control of risk factors, then consider doing the stage PCI.
Thank you indeed. The next speaker in the session is STEMI PCI, multi-vessel or culprit only or staged. The speaker is distinguished Dr. K.K. Sethi, who is the professor and president of the past president of CSI. Dr. Sethi has very vast experience of PCI and STEMI. Dr. K.K. Sethi, please.
My slides are not visible, it seems. Are they visible?
Not really.
Your screen is visible. You just need to put up your slides.
Is it visible now?
No, sir.
Oh, I tried to do that, but
Can you do the resharing, sir?
yeah, I'm trying to look for that. It's gone. Stop sharing. Okay. I do this share screen. My PPT is open already. Can you see now?
Not really.
Not really.
No, sir.
How do we do that then? Problem. Okay, I share screen. Now, is there anything else that I have to press? There is a mail inbox that leaves it. So I press share again and open my PPT.
Sir, we can't see your screen, sir.
Can't see my
Open your PowerPoint first, then share.
Yes, I opened the thing.
Now we can see your screen, sir. Just open your PowerPoint presentation.
Can you see it now?
Put it on, yeah, sir. Put it on full presenter mode, sir. Perfect, sir.
Thank you very much.
So,
yes.
Everybody, I'm sorry for this little bit of glitch. Now we're going to switch gears again, and we're going back to percutaneous intervention in ST elevation, myocardial infarction. And you all know that the question that has been posed is whether it should be multi-vessel, culprit only, or a staged PCI. Fortunately, I'm not able to move the, yes, thank you very much. Now, whereas the general approach to primary PCI is almost established, that we use radial access, use thrombus aspiration only when absolutely essential, and use new generation drug-eluting stents, there is a lot of confusion regarding whether we should be doing multi-vessel PCI or culprit vessel only in STEMI. We all know that approximately half the patients have multi-vessel disease, and they have worse prognosis as single vessel disease. Following PCI of infarct-related artery, evidence supporting immediate revascularization of additional stenosis is conflicting. And you can see some of the earlier data that was published a few years ago, which may or may not be very relevant today. But let me quote the US National CV Data Registry, which in 2009 showed more adverse events with immediate multi-vessel PCI versus infarct-related PCI only. And similar results in two large meta-analyses involving more than 40,000 patients each showed that pre-discharge or PCI within 1 month of the acute event had lower mortality, and the cardiogenic shock was excluded in all these analyses, as has been the case in some of the more recent randomized controlled trials. Unfortunately, there have been relatively few randomized controlled trials in this subset of patients, total about 5 only, and the first 4 included between 69 to 885 patients, and the last one, which is the most recent, the complete trial, included approximately 4,000 patients. Now, the inclusion criteria and the strategy after the infarct-related PCI of infarct-related artery varied somewhat in these studies. The first one was the PREMI trial, 465 patients, where immediate preventive PCI of non-culprit vessels was compared with ischemia-guided PCI on follow-up of the other vessels. And the definition of significant stenosis in this study was angiographic 50% or more stenosis. The next one was culprit study, which included 296 patients, in which preventive PCI, immediate or pre-discharge versus PCI of infarct-related artery only were compared. And the definition of significant stenosis in this study was 70% or more stenosis in the non-infarct-related artery. Now, the most talked about studies is the Dynamic 3 Pri-Multi, which included 627 patients. Preventive PCI was performed pre-discharge, but this was FFR guided in more than 50% angiographic stenosis in non-infarct-related vessels. And the PCI was done if the FFR was 0.80 or less. It was important to see in this particular study that 31% of the patients were FFR negative. That means FFR was more than 0.80, and this comparison was made in the other half patients in which no additional revascularization was performed. In the Compare Acute, which was published in 2017, 885 patients. Again, this was an FFR-guided study in more than 50% stenosis in non-IRA vessels, FFR of less than 80. Immediate preventive angioplasty was performed in 83%, and approximately 17% of patients had pre-discharge preventive angioplasty. And this group was compared with ischemia-guided strategy in 1:2 ratio. And in this particular study, more than 50% of the patients in the non-infarct-related artery were FFR negative. That means the FFR was more than 0.80. And as you have seen here, the definition of significant stenosis was 50% or more stenosis as seen by angiography. The last of these randomized trials is the complete study published in 2019, consisting of 4,000 patients, where preventive strategy was pre-discharge angioplasty. 68% of the patients underwent pre-discharge angioplasty, or less than 45 days after discharge. After discharge, 32% of the patients underwent preventive angioplasty less than 45 days after discharge. And this group was compared with those in whom revascularization was not performed. And here the definition of significant lesion was 70% or more angiographic stenosis in non-infarct-related artery. FFR was performed if the stenosis was judged to be between 50 to 69%, and those with FFR of less than 0.8 were then subjected to infarct-related artery angioplasties. Now, the endpoints in these patients, in these trials, in all of them, the primary endpoint was a combination of various factors or various endpoints, which differed somewhat between the different studies. And let me quickly go through all of them one by one. In the PREMI trial, which was a small study, as you know, the primary endpoint constituted a combination of CV death, non-fatal myocardial infarction, and refractory angina. And the combined primary endpoint was less in patients who underwent preventive PCI versus those who did not undergo preventive PCI. In the culprit study, in the culprit trial, the cumulative event rate of IRA only versus complete revascularization again was better in the complete revascularization group. The primary endpoint here constituted of all-cause death. In the previous trial, it was the cardiovascular death. Here it was all-cause death, recurrent myocardial infarction, heart failure, and ischemia-driven revascularization, a combination of 4 endpoints, and the hazard ratio here was 0.45, which was quite significant when a combination of all these 4 factors was considered. In the dynamic 3 primulty, which was FFR-guided pre-discharge PCI, the primary endpoint consisted of all-cause mortality, again, non-fatal reinfarction, ischemia-driven reinfarction in non-infarct-related artery, a combination of these 3 endpoints. And again, if you combine these endpoints, the patients who underwent complete revascularization did better than those who had infarct-related artery-only revascularization. In the compare acute, which is again a combined primary outcome of all-cause mortality, non-fatal myocardial infarction, any revascularization, or a cerebrovascular event was also included in this. And again, you see that the events were significantly less in those who underwent complete revascularization versus infarct-related artery-only treatment. The last one, as I said, was the complete trial, where again the cumulative incidence of first and second co-primary outcomes was looked at. The first co-primary outcome was a combination of CV death or new myocardial infarction, and the second co-primary outcome was a combination of CV death, new myocardial infarction, and ischemia-driven revascularization. And in both these, you can notice that those who underwent complete revascularization again had less combination of these endpoints as compared to those who had culprit lesion only percutaneous coronary intervention. So if you look at all these randomized controlled trials, one thing is evident that if you combine the endpoints, then all combined endpoints put together, although they were slightly different in different studies, occur less frequently in complete revascularization with culprit lesion revascularization only. And in the complete trial, an analysis was performed where to look at whether all revascularization was done during index hospitalization, or if you postpone it to less than 45 days, whether there was a difference in the results. And it was seen that the benefits were similar, no matter whether the stage PCI was performed pre-discharge or a few weeks after the patient was discharged home. Now, more recently, another meta-analysis has been published, which has included the complete study. In the previous meta-analysis, the complete was not included because they were earlier meta-analysis, and that looked at 4 different issues. First is the cardiovascular death in patients with complete revascularization versus culprit lesion only. And here in this particular meta-analysis, the CV death seems to be reduced vis-a-vis the other ones in which we found that it was not reduced. Again, a combination of CV death and new myocardial infarction was less in complete revascularization as compared to culprit lesion PCI only. Then the analysis was performed whether if we do the FFR guided approach versus an angiographic guided approach in the non-culprit lesion PCI, whether the results would be different. And in the FFR guided approach, although there were a number of studies in this particular meta-analysis, only dynamic 3 primulty was included. And you can see here that the test for overall effect, there was no significant interaction. The results were almost similar, no matter which strategy did we use. And long-term CV death stratified by approach, again, whether it was FFR guided or angiographically guided, the results were more or less similar. So if we look at the summary of the results of RCTs, the first point that comes out is that the primary outcome, which is a composite of different endpoints in different studies, was significantly reduced in all. Total mortality not statistically different in any of these studies. Non-fatal myocardial infarction was reduced in non-IRA PCI in PRAMI and complete only. Repeat revascularization significantly reduced in majority of the studies in the complete revascularization, including PRAMI, dynamic 3 primulty, compare acute and complete trials. There was no effect on death or myocardial infarction between the two groups in the previous two meta-analyses. However, in the complete trial, which is the largest trial with a 3 years follow-up as compared to the others, which were 1 to maximum of 2 years follow-up, the combined deaths and myocardial infarction were decreased. And in the last meta-analysis, which was published in 2020, cardiovascular death or new myocardial infarction was reduced irrespective of angio-guided or FFR-guided strategy in the non-infarct related vessel. Looking at the guidelines, the ESC guidelines published in 2018 say that in the non-IRA strategy, routine revascularization of the non-IRA lesions should be considered in STEMI patients with multivessel disease before hospital discharge. Non-IRA PCI during index procedure should be considered in patients with cardiogenic shock, which is a 2A indication, although cardiogenic shock has been specifically excluded in all the trials with multivessel disease. And to actually look at the data, a majority of the patients, almost 80 to 85% of the patients in all these studies were CLIP class 1. And obviously in others in whom PTCA is not possible, CABG has to be considered. So in conclusions, ladies and gentlemen, I would like to say that revascularization of non-infarct related artery lesions should be considered in STEMI before hospital discharge. However, optimal timing of revascularization, which is immediate versus stage, has not been adequately investigated as the number of patients in each of these trials is relatively small. In staged PCI subset, results of pre-discharge and post-discharge PCI up to 45 days after discharge appear similar, although once again, the numbers tested are rather small. So that is what would be my message, a take-home message from all the data that is available today. And I would like to thank you for giving me this opportunity, and thank you for your kind attention.
Thank you, Dr. Sethi, for a brilliant talk on stage versus primary PTCI in multivessel disease. I now request Dr. Nitish Naik to proceed further on the discussion. Nitish. Hello. Yes, I asked the question to Dr. Prakash Yadav about the multivessel PCI in diabetic patients. He also suggested that stage PCI would be better than the PCI multivessel disease in diabetic patients at the same time. Dr. Sethi, do you have any different opinion on that?
See, in these studies which have been published, almost 25 to 35% of the patients had diabetes, and they were randomized in the same way. The diabetic subset was not separately randomized into anything. So the diabetics and the non-diabetics were treated by the same strategy, either immediate multivessel PCI or stage PCI, and results for the diabetic population have not been separately analyzed because the total number of patients is so small in most of these studies. All of them are less than 1,000 patients, some only 250 odd patients, except one which includes about 4,000 patients.
Right. What's planned in your experience? How do you like to proceed in diabetic patients personally?
We don't do immediate multivessel angioplasty in any case. In our hospital, the default strategy is to do culprit vessel immediately and then try to do the stage angioplasty pre-discharge, generally 2 or 3 days after the patient gets stabilized.
Well, I think, Kamal, it's probably better to do it even a little later, unless there is ongoing evidence of ischemia, after you modify the risk factors, particularly, as I mentioned, a lot of diabetic patients during acute STEMI will have, obviously, hyperglycemia. Also, they have a very hypercoagulable profile. So I probably, my personal opinion, and we have no data specifically on that, that we should probably give a little more time for the hypercoagulable milieu, the platelets to calm down and cool down a little bit, as well as their metabolic profile is better controlled. What do you think about that?
Yes, I completely agree.
I think many of these people also have renal dysfunction.
Yes, absolutely. Yeah.
I agree with you completely there. And when I said that we do it in 2 or 3 days after the first angioplasty, this is after the patient gets relatively stabilized, because many of them are very sick. And as I said, that most of the patients in these randomized trials were class 1, Philip class 1. So maximum class 2 cardiogenic shock was excluded. Most patients were not in pulmonary edema or anything like that. And we also discussed with the patient the pros and cons of this. And majority of the patients actually ask for 1 or 2 weeks of respite. So mostly we do these staged interventions at about 3 weeks after discharge. We recall the patient, readmit them, and then complete the revascularization.
And I think Dr. Khalilullah make a very good point that diabetic patients will have at least 1/3 of them or half of them will have renal chronic kidney disease, and giving them too much diaload, which you will need in diabetic patients because they have so many lesions to do angioplasty. You'll have to inject them multiple times, and that can really do an acute renal shutdown despite what we do.
In fact, there is a big handicap in primary angioplasty because you take the patient immediately to the catheter lab and no reports are available. So you don't know what the baseline renal function is, and the angioplasty is completed, and the next morning when you see the reports a few hours later, you find that the serum creatinine is 3 or 2.9. And you know, obviously there is an acute kidney injury, but what was the baseline creatinine? Unless the data is available with the patient, you know, you just see that the patient has a renal problem.
Right. Professor Morton-Kern, any suggestion, any comments from you?
Yeah, so I'm a very practical interventionalist, and I think a staged approach works best. If you're going to stage it 3 days, you might as well stage it 2 weeks or 3 weeks. It doesn't make any difference.
Right.
The timing would be for convenience. In the diabetic or anybody with elevated creatinine, I think a delay of a couple of weeks is indicated. Let the kidneys heal up, give them a chance to have better renal function. In the middle of the night, I think a lot of work becomes complicated, and if should you have a difficult case, it becomes an unnecessary complication. So I would attack the critical lesion, the culprit lesion, and go on. Now, one thing we do, of course, is we do FFR on the non-culprit. I still am a believer, and if it's negative at that time, I would have to have some overwhelming evidence that it turned positive, which is pretty unlikely. If it's positive, at least you know what you're doing when you come back, and you don't have to do a stress test.
Yeah.
In terms of lesions, suppose you do a primary PCI and RCA lesion, and you see that the angiography does not show an LED lesion. Would that prefer to go at the same time, or you can delay it further, as compared to those who have both LED as well as L6 lesion apart from the RCA?
I do the culprit lesion, and just as I stated, wait on the other one. I don't think that the location makes an overwhelming case.
Nitish, we thank you for giving us this opportunity to chair the session. All the speakers have done a great job. Give them a big hand, please.
So thank you. We are
Thank you.
very
I'm going
grateful to have all our guest speakers, and we are very sorry for having so many stoppages of time. And I'm very grateful to everybody, Dr. Morton-Kern, Dr. Prakash Didwania, for staying back and bearing with the inconvenience caused. Thank you very much.
Thank you.
Bye.
Bye.
Thank you, Nitish. Nice to see you, Didwania.
Yeah, good to see you, Mark.
No, and we hope to see you tomorrow.
Thank you very much.
Dr. Goswami is saying something.
Thank you. Thank you. Good night.
Good night.
Thank you, sir. Thank you. Good night.